Good morning, Adab, Sat Sri Akal, Namaskar, Hyderabad, and welcome to all the delegates from far and wide across the city. I've also seen some registrations across the borders also, so welcome to all the delegates. I know it is festival season of Ganapati and Onam today, but to see you all here is a great pleasure. So welcome to everybody. So today's conference is Infection Control and Prevention in ICU. It is a part of a pre-conference. It's a pre-conference, a part of G-SPARC conference, which will be held in Hyderabad between 3rd to 5th of October, held by Infection Control of India, which was established in 2016. And they work all across India to promote infection prevention and control and also promote AMSP program. So ladies and gentlemen, fasten your seat belts, put your mobile phones on silent mode as we dive into the stadium of infection control. So as an opening batsman for today, I request our moderators, our opening batsman, Dr. K.C. Mishra. Dr. Mishra is the head of critical care and also the chairperson of HIC program at Yashoda Hospitals, Somajiguda, to please take the seat. Our second batsman is Dr. Dilip Nandamuri, sir, who is the Consultant General Physician at Yashoda Hospital, High-Tech City. I request our moderators to please introduce our our speaker for the day to bowl his first innings.
Yeah, good morning. Good morning, everyone. Maybe by mistake you have told a correct thing. He is one of the first bowlers in our medical college. Maybe the deadliest bowler what we have at our time. And apart from the first bowler, I think he is one of the person in India who when it comes to infection control and all, he is one of the center stage. He takes a lot of let it be academic wise and maybe practical things when it comes to infection control. I think Dr. Venkatraman doesn't require much of introduction when it comes to Yashoda High-Tech, his home ground. Dr. Venkatraman Kolla is the clinical director of critical care and heading the unit of Yashoda Hospital, High-Tech City. Apart from that, all 4 units of critical care comes under him. Without delaying much, Dr. Venkatraman, it's over to you.
Yeah, thank you, Mr. for that kind introduction. Thank you, Chairperson, for honoring our request to be here in the early hours. Thank you, ma'am, for that initial beginning. Yes, it is a festival season. Happy Onam and good morning, Hyderabad. Yes, I have been a passionate, you can say it's not just passion, but I'm paranoid about some of those infection control measures in ICU. And that has been my life in the last 10 to 15 years. So when the G-SPARC conference spoke to us about a pre-conference workshop, we thought about we all being a critical care clinicians, why not we have a workshop on ICU infection controls, and that's where this all the workshop program started from there. So the first lecture to actually roll the ball going, much before the other elite speaker come onto board, our ID clinicians come onto board, I just wanted some time to spend with all of you so that we will have the whole full of the auditorium before we start to the main workshop on. And I took the task of selecting why are we here to only talk about ICU related infections. The hospital is such a big place, ICU is one of the component, and we are only talking about ICU related infections and their prevention. So why is that the purpose of this? And we discussed the ICU is an epicenter for infection and epicenter for HIPC role. So why is that? Actually, I know some of you must have been regularly being a part of HIPC. I know some of you may be a regular part of your ICU roles. So I felt I will go through the lines of why I wanted this talk. So what is the statistics of ICU acquired infections in India and abroad? And then I will talk about why antimicrobial resistance became a threat to not only just us but to the world. what kind of patient profile and clinical condition and clinical course ICU does have, what kind of invasive devices and tubes and circuits these patients do carry, and what is this impact of these hospital-acquired infections on the patients, not just cost, but mortality, morbidity, length of stay, and quality of life, and many emergency procedures which we do in this ICU setups. So we will go in this line. In addition to these challenges, the new uncommon, not uncommon to any of us, the challenges are, you every time in every 6 months you find a set of nurses leaving you, and you get a fresh set of nurses who have joined maybe 3 months or 4 months back. And they are your main ICU lead nurses in your patient care area. And sometimes when your season comes in, like what we have seen in the last couple of months, dengue, influenza, or you have a season with some of the viral illnesses, so that causes a surge in your ICU cases, leading to the strain on nursing ratio, including the ventilated patients and those patients on organ support. And not to actually ignore the availability of a critical care clinicians and the ratio in these strain situations do also causes problem. Trainees comes not just to the nurses, but also to the critical care department and emergency department. All of them also play a role how we actually get tussled in the infection control in ICU. What actually ICU look like? A ICU look like something like this. Why ICU look something like this? Why I said is, it's a area which we say ki a long back created or crafted with the equipments, gadget to monitor sicker group of patients and also support the organ system if they required. And these patients sometimes may be observed for any acute tilt. And such a complex situation, if a patient is somewhere on 2 or 3 organ support, if you can see a renal replacement therapy, if a patient on a extracorporeal support and a ventilator or some form of IABP, it will look like something like this. So that is the situation in most of the ICUs. So ICU infection cannot just be a hospital acquired, they can be community acquired, they can come to the ICU after a community acquired, they can be a hospital acquired infection. After the patient acquires the infection in the hospital, because the patient now aspirated, had a pneumonia, had an infection, is shifted back to the ICU. And the last one is your ICU gave an infection to this patient. Now coming back to what generally happens to all of us in the last, suppose I am in the ICUs for last more than 15 to 18 years working in the ICUs. And all of us feel ki if somebody is in ICU, they are threat for any infections, right? But many of you may be working for last maybe 5 years or 10 years. Many of us who are working there for last 15 to 20 years. So none of us got those infections which we talk about. I never got infected with Acinetobacter. I never got infected with Pseudomonas. I never got infected with Klebsiella XDR. And I have been not been a part of the hospital admissions for any other reasons related to the infections. So when we talk about a ICU is a bad area, ICU is an area which creates infection, ICU is an area which is the source and epicenter for infection, then all of us would have been regularly getting infections, right? We get the same kind of influenza, same kind of viral fevers, but not with the infections like Acinetobacter, Klebsiella or XDR, Pseudomonas, which we talk about for our ICU patient. Why is that? Yes? We have? So somebody says we have intact skin. So how does it actually prevent you from infection? Infection can come as a droplets, infection can come as an airborne, infection can come in any other sources in the gut. You have resistance of antibiotics or you have resistance to the bacteria? Anybody wants to give a clue for that?
Patient is already immunosuppressed and
Why do you think ICU patients
already
are
antibiotics.
Why do you think patients in ICU are immunosuppressed?
His immunity power is low.
Suppose any of us gets admitted into ICU.
Already
forget
infected,
about,
that's why you have kept in the ICU.
yeah, forget about a immunocompromised patient. Suppose any of us gets with some unfortunate reason, yes, that do happen unfortunately once or twice. any of us or any of our family members who are otherwise healthy, because of an acute illness, suppose you get a dengue getting complicated, dengue getting thrombocytopenic with polyserositis, you may need ICU admissions, right?
Inadequate nutrition.
In 1 or 2 days?
Devices.
So, see, we always talk about hospitals, ICUs are such a bad places to actually think about an infection. But it is not that place alone, okay? I'm just keeping a picture. Do you know what this image looks like? I can't point out? Okay, you can see this and you can see this picture. Can you tell me what is this exactly? Which needle? A hypodermal simple needle. When it is magnified, it something looks like this. And what is this picture? It's a skin image which is actually magnified to electron microscope layer, where you can see the cells, the skin cells, epidermal cells, and these are the skin colonized bacteria present there. Okay, just imagine when you actually do a IV cannulation, just simple IV, I'm not talking about central lines, I'm not talking about any big cannulas anywhere in, just a hypodermal or a central line related or a peripheral IV cannulation. Okay, if you are not conscious about a proper aseptic precautions during handling, what is that common aseptic precautions? You actually give a alcohol rub and then you actually try to find out a vein, then again you tap and again you palpate and again you keep on actually puncturing. If you are not getting, again you puncture. So this is an example that even a simple IV cannulation which penetrates and takes your skin out of your, if you just imagine how much of skin must be going from here. If this needle punctures, there is a good amount of cellular load which must be going inside your vein. Okay, and that is the microbiological load which can you push into that, and they are in millions. They are not in hundreds or 50s or thousands, they are in millions. So what I'm trying to explain you is, all of us who work in ICU or all of our patients who are there in ICU, if they don't have any breach to their normal protective mechanisms, what somebody was saying, the skin is protecting, your oral cavity, mucous membranes are protecting, and none of us are any form of antimicrobials which somebody has pointed out. These, if we are there without any breach of our normal barrier mechanisms, we don't get infections. We are like any other human beings in this world. But the same person, as we are saying, if any of us by unfortunate reason get sick and get some viral illness and you are in ICU and you get an IV cannula, just an IV cannula, you still have a risk of getting those bugs inside you. And just imagine what happens to an ICU patient. This is a pictorial drawing of an ICU patient. If a patient in ICU is sick, I'm just not talking about just an IV cannula, but these patients may require a central venous cannulation where there will be a larger needle going inside, there is a guide wire going inside, there is a sheath going inside. You can have a HD sheath. You may have an endotracheal tube which actually breaches from your oral cavity nose to your lower part of your respiratory tract to trachea or carina. In the similar way, you may have a breach to your urinary tract by actually establishing a Foley's catheter. You may have an NG tube. You may have an arterial line. If the patient is too sick needing extracorporeal, you may also have a ECMO support. So just imagine if an IV cannula can breach so much of bacterial load inside, what happens if you have so many things in the place of the patient? That is why these patients get infection. It is not because ICU, they are in ICU. If you ask my general physician, Dr. Dilip Nandamuri, or any such physicians in any of your hospital, they have two reasons to say we don't want to shift any of our patient to ICU. They have hundreds of reasons to shift, but they have two reasons to say I don't want to shift my patient to ICU. What will be the first reason? No. That comes second. What is the first reason? Cost. They say the moment I shift, your bill rockets high. Okay. The second common reason they say or we say or our families of the patient say is infection. Okay, that is the reason. It is not the place which is the cause for infection, but I am trying to tell you it is the backdrop or background, what is the reason for those infections. We will come back to that point. Just putting lines, is it the reason? These lines has been placed. If I have a ECMO line, I just plaster it. I don't know, I will show you those ECMO lines which are as big as like any drain pipes of your kitchen. And if you place it and put a proper aseptic precautions, if you are not handling, we don't see any infection. But even though you put a small IV cannula or an arterial line or a central line, if you keep on handling every alternative hour with ABZ or a samples or trying to flush it out for a proper line tracing, the handling of those lines frequently can also create a transmission of the cross infection of the bacteria into your system. So we'll come to that. So these are considered to be the highest risk factor for any ICU. If you have an invasive device in place like mechanical ventilation or a line or those patients who are on a catheters, these are the most three common things which happen. Extracorporeal hemodialysis do add to that. So I said the ICUs are the epicenter for infection. I think many of you are now a part of HIPCs in many areas. So you talk about hospital acquired infection, which the four most common things which we talk about is either we talk about a catheter related urinary tract infection, central line related bloodstream infection, or a ventilated associated pneumonias and surgical site infection. If you look at the four of them, the majority of the VAPs, maybe if I look at my ICU, I was looking at the my ICU data of all the 4 hospitals of Yashoda group of organization, almost 100% of all VAPs are in ICU. There is no question of having a VAP outside. Central line related bloodstream infection. When I looked at our data, 80 to 90% of all our central line related bloodstream infections are related to ICU. Hardly we have any central line outside ICU. Maybe very extraordinary situation where you don't have a peripheral line, 1 or 2 patients may be moved out where you may acquire, or a patient with a chemo port or a peripherally placed central line catheter or a PLAPSI, peripheral line related bloodstream infection may be a reason there. So the 2 major components of hospital acquired infections are only related to the ICU. They have no link to the wards. So majority of them linked to the ICU. And coming to the COTI. COTI is again, some of the COTIs happen in ICU, some of the COTIs in the ward. It varies from the hospital to hospital. We have seen 50-50 to 70 ward to 30, 70 in ICU to 30. So urinary tract infection has a 50-50. Most of the surgical site infections are either OPD based or they are in the sicker groups in the IPD. Very rarely we see they coming to the ICU. So that's why I'm saying good amount of the whole load of hospital acquired infections belongs to ICU. So if you have taken care well of that part, I think 80% of your job will be done as far as the high is concerned. So this is again one of the papers which are talking about 5 to 10 times higher possibility of an infection in an intensive care unit compared to what we see in the ward. And this is also because we will talk about antibiotic usage. So if a patient is in ICU, there is a possibility that few studies talks about a possibility of as high as 18.9% risk of these patients getting infections. And that reason is we'll come to those explanations. And what are the common causes of infection? We talk about all these systems like pneumonia, or we see other lower respiratory tract infection like tracheobronchitis. We talk about urinary catheter infection, bloodstream infection, not just they, but we also see an infected phlebitis, a cellulitis because of extravasation of IV cannulas. We also see a sinusitis. We also see the blockage of your all noses by your large Ryle's tube causing them. And skin and soft tissue infection, a bed sore getting secondarily infected, a IV cannula extravasation getting secondarily infected, a edematous limb getting secondarily infected. We also seeing some of the GI tract infections. They get either by a drinking water contamination or through when they are handling through cross-contamination, or some infections like C. diff getting contaminated. And cardiovascular system, see some of our patients who are on a long-term catheter, like a PICC line, peripherally placed catheter or a central placed catheter, these patients also can get a endocarditis in them, which may not be as common like pneumonia of 70-80% or a 60%, but they may be extremely rare, 1-2%, but that can happen. So we have seen different ICUs having a different permutation combination of infection rate, whether it is a bloodstream, urinary tract, or pneumonias. Coming back to the second part. So the first part is the statistics of ICU population talks about they take the major chunk of hospital-acquired infection, and they are a threatened population, so that's where we are worried. So ICU will be a concerning area. And why it is a concerning area? It is not because it is the place ICU, but it is because the invasive devices we use, the amount of handling we do to it. The second point was one of our colleague in the audience spoke about antibiotic use. Does really antibiotic use as creating a problem as in the ICU? Why am I more worried if I have an infection in ICU? So we will talk about it with some examples. It looks like if a patient got intubated and having something like this, what is the possible reason? Looks like a VAP, right? Ventilated associated pneumonia. And not to surprise, these patients initially come with some viral pneumonias to your ICUs, and these viral pneumonias are most likely by some influenza, or now also we are seeing some COVID or some influenza A virus or some respiratory syncytial virus, and they will be put on the basic regular antibiotic like clarithromycin, oseltamivir, or a BLI or a BLI. Beta-lactam like a cephalosporins of first or second generation. So this is a very common thing which happens in ICU, and then over a few days or day 8, you see their lungs getting worse day by day. They were improving, they worse day by day. So this is not uncommon in many of our ICU situations. Then what do we do? What antibiotic do we change here? Ganesh or anyone? What antibiotics does we change in Visakhapatnam? Not very uncommon situation, right? It's very common. You come with a viral pneumonia, they get a secondary bacterial pneumonia. What happens to your hospital? I'm just asking randomly. This is not linked to any hospital. These are all cases which are created to make a discussion.
So we have XDR Acinetobacter and XDR Klebsiella, sir.
So what will be my choice of antibiotic if I think like this?
If Acinetobacter, I will go for polymyxin along with minocycline.
How many of you have any idea? Somebody like Dr. Ganesh who actually works day in and out in ICU has a clarity what he has to handle there. Theoretically, we may give a lot of lectures in any of the platforms, but what happens in real time is something like that. How many of you work in ICU? I'm not sure, but this is a very common scenario in any of our ICU. So we see this Acinetobacter baumannii, and not uncommon, any patient who is getting intubated coming to our ICUs, or a patient who is in our ICU getting a cross-infected. And the interesting part is this. Is this uncommon? So first of all, they should have been not looked for ceftazidime avibactam, and all the other things are been resistant. And you have a imipenem which is intermediate. Do you also see minocycline resistance? Not uncommon, right? Minocycline resistance. We will not go into those details. This is not the class for that. I am talking about something like this. So what is my problem? I think all of you, if you remember earlier times, when I think many of you are kids and we were in medical colleges, we were talking about cephalosporins like ceftriaxone, ceftazidime, or cefepime as a very good antibiotics in 90s to maybe early part of 2000s. Okay. Now we are from 2000 onwards, we were talking about meropenem as one of the good broad spectrum antibiotic which is having a safe therapeutic index, simultaneously also have probably a good coverage. Okay. Now our problem is ceftriaxone has got resistant by 2005 to 10. Most of our antibiotics, bacteria are now resistant. And now we have a problem that meropenem has been resistant. And this patient was not used meropenem also, but Acinetobacter generally whenever we come across, they will be resistant. This is 2024 released data of ICMR, which talks about 2022, so probably the data which has been collected and released on 2024. It talks about the numbers. You can see the red ones in ICU. The ICU is in red, and these are all the red ones which we are talking about, the isolates which we see. And Acinetobacter in ICU has been one of the most problematic organisms. It's not common in wards, it's not common in OPD, but it is common in ICUs. So that's what we are talking about. You can see these all reds are ICU areas. Klebsiella pneumoniae, you can see the ICU isolates. So we'll come to the other points. ICMR also talks about these other 2-3 difficult bacteria which we see in ICUs. Acinetobacter, Pseudomonas and Stenotrophomonas, these are NLFs. A patient who is in the ICU on 11th day had signs of infection like fever, leukocyte rise, some hypotension, tachycardia, SIRS response, suspected to have a line-related infection sepsis, blood culture turned to be positive. Anybody else? Gautam, what will be a choice of antibiotic at this point? The patient was not on any antibiotic. He was there on 11 days. Probably he is initiated from some cephalosporins. Luckily, our clinicians were kind enough to not hit them with any broader spectrum antibiotics. But this patient grew a GNB in a central line. What will be a choice of antibiotic on day 11?
Usually it will be a carbapenem.
It will be generally a carbapenem. So we will just see. We grew a Klebsiella in this patient. And do you see this uncommon?
No, it is very common situation.
So even though the patient has not been exposed to carbapenem, we do see these reports coming to us. Okay, I'm just showing some examples. Okay, and in this, most of the times we feel as Ceftazidime avibactam with synergy being a choice, but now that has also been a challenge. The Foley's catheter, this is not an uncommon device which is there in most of our patients. And then these patients also get infection. And if my patient had some signs of catheter related infection, when I send a culture, it grows E. coli. And we do see this kind of reports. As I told you, these are resistant to meropenem, resistant to amikacin, colistin in generally intermediate. They don't give a sensitivity pattern to them. And then you see Ceftazidime avibactam is resistant and synergy is negative. So none of those drugs work. What do we do in them? And we don't all know, for just an information, those who are intensivists here, we don't actually probably empirically think that Ceftazidime avibactam along with my azithromycin will work for E. coli like what I can expect for Klebsiella. Good percentage, maybe 40% or 30% of your E. coli may not be sensitive for the synergy. So E. coli will be notorious in them. Klebsiella, you may have a synergy, but E. coli cannot have a synergy. So what will be a choice? What can you think about here? So these are all kind of situations which we face day in and out in our ICUs. Surgical site infection. Yes, we don't see them commonly in our ICUs, but they sometimes get badly infected. The abdomen is opened, or the patient has a deeper layer of infection. They do come to your ICU. And what will be our choice of antibiotics in them most of the times? Anyone? Anyone from the lab departments or clinical side? Any patient comes with a bad surgical site infection, what will be our choice of antibiotics? In general, I know it may need to be adjusted to the culture. Amoxicillin clavulanic acid or something like covering your cocci and maybe early part of your any GNBs if depending on that. So as expected, there is a cocci, but we don't see uncommonly that they get resistant to your vancomycin, teicoplanin also. So what I was trying to say, it is not an example that all your patient will behave the same way, but your patients in ICU can behave in this way. That is the problem. And this is the data from ICMR where you have a chemoport neutropenic patient where you can have a Candida auris which can have a resistant to your not just fluconazole but echinocandin and also amphotericin B. And this is the data again, ICUs being a predominant areas, The ICUs are read from the 2024 ICMR release, which actually talks about the 2022 data, where this is Indian data which is talks about these differences. So patient profiles is again second most common problem. If you see any of our ICU patient, my interns or my colleagues keep on started with, my patient is a known case. Actually we get exhausted by knowing those list of known problems, and they can be like the patient is a known diabetic, hypertensive, hypothyroid, undergone a CABG 3 years back, but still having a kind of a diastolic failure component, known CKD, had a 2 times AKI, dialyzed twice, and then came to us, has some fatty liver, now look like a CLD. So there will be so much of list of comorbidities which they come to the ICU. So the profile is so fragile that became a challenge to us. And patient with this, if they come with some septic shock or spontaneous bacterial peritonitis, that adds to the problem. Similar way, a AML patient post-bone marrow transplant, if you have a hematology unit which is big enough like us, you keep on getting these patients post-bone marrow transplant with a neutropenia, with altered sensorium, with multiple organ failures. You also get a 56 years necrotizing pancreatitis case. It's not just a regular pancreatitis. The patient is there for 28 days to 30 days in your hospital, started with necrotizing pancreatitis, later on had an infected pancreatic collection, needed a multiple pigtail drains, kept on actually growing one after the other organisms, is there in the ICU with a AKI on a CRRT or switched to HDC, and these patients will be there lingering in your ICU. Few other cases I said immunocompromised, few other cases I said those who actually comes with multiple comorbidities. These are the patient who actually comes otherwise healthy initially, but they stay long in your ICU. So the third part, the first part I said ki the ICU patient areas, invasive devices are different. Second is the profile at which the patients admitted are different. Third, I am talking about once these patients get a hospital-acquired infection, your burden of cost goes high. That's what Dr. Dilip said. Whenever they wanted to send any patient, their first threat was what will be the cost added to that. And most of this data comes from the Western countries, but I will just put across my own calculation. Suppose any of your patient gets any of these broader spectrum antibiotics called meropenem or imipenem or avibactam in combination, it adds somewhere between 15,000 to a lakh rupees per day. What is the extreme of lakh? If you have a ceftazidime avibactam with azithromycin in combination with either a minocycline or with a ticoplanin or a daptomycin or a echinocandin, or some of those times where amphotericin B or a isovaconazole is added, it can go up to a lakh per day. Just imagine a lakh per day. This we are talking about antibiotic cost. And this cost will be added for not 1 day, but for 10 days of time. And then every extra ICU day stay adds again to the cost to that. Every extra organ support your patient needs adds to the cost. And all that, not this cost, but the morbidity and the mortality these patients acquire over a time. This will be all additional problems to your patient. So the impact of any healthcare associated infection, unfortunately, if any of our known family member or a known patient gets, they keep on actually screaming about this cost load to you and the prolonged stay on your ICU and the outcomes, the morbidity and mortality to you. Just to talk about, these patients remain on a multiple circuits, which we talk about, and this is an example of how a patients are on a multiple circuits. This is a patient on extracorporeal membrane oxygenation in one of your units, where this patient was put onto ECMO, and can you imagine the amount of lines, tubes this patient will carry and the circuits which will be carried during ambulation and mobilization. So you just imagine, if you talk about IV cannula can get infected, and we are talking about such a huge cannulas, lines and tubes and circuits there which can get infected in them. So overall, ICU area is a specialized area where you have a patient profile, devices in place, breach of the normal mechanisms, and we talk about antimicrobial resistance, which is a problem. Many of us who actually use antibiotics for any reason as an empiric choice in the OPD or IP or in ICU before starting an antibiotic, we do cause them a harm of collateral damage, causing antimicrobial resistance, and that leading to this kind of profiles which I'm talking about. Many of your ICU patients may have growing a bacteria which is resistant to most of the antibiotics available right now. So that actually just changes your game plan of a patient who is having a sensitive bacteria to a patient who is having a resistant bacteria. For example, if I have a patient who has growing some E. coli or a Klebsiella sensitive to your meropenem, probably the survival chances of those patients is maybe close to 70–80%. Whereas in the same patient, if I have a Klebsiella which is resistant to carbapenem and only sensitive to colistin or intermediate to colistin, the survival chances is less than probably 20 or 30%. So that is the change which is making by the antimicrobial resistance. That's the reason why we felt that ICU is an area where our infection control team need to be focusing more, and that is the reason why we thought that if a patient gets an ICU acquired infection, it will not only take the cost, but it will be detrimental to his life, and there will be many, not just money, but loss of lives which can happen. AMR is going to be a major threat, and you cannot have infections in the ICU and have treatment for those. So that's a bigger challenge in the future, because you don't have a good cephalosporins on the pipeline, or you don't have a newer generation carbapenem on the pipeline. Unfortunately, we are just playing with the age-old antibiotics permutation in combination. Many new names which you may be listening in the board, either you talk about a carbapenems with some relibactam, vibrobactam, blah, blah, blah. Many of them don't work in India. None of them work in India. You probably need a azithromycin based combination which are not fully available. We just try to play with one to other antibiotic. So the bottom line is you don't have a real good antimicrobial to counter the bacteria which are now being produced in your ICU. So this is the reason the only option left to us is prevent them and allow your don't allow your patient to go into any hospital acquired infection. Thank you.
Moderators, to summarize, then we will open the floor for questions.
Thank you, Ramna, for a very good opening talk about why we need to control infections in ICU. As Dr. Venkatamna told, it's not only direct cost what happens to the patient, it's the cost of the employment loss for the attendants, the emotional issues, and apart from that, the patient's morbidity. All this can cause a lot of toll onto the total family. It's not only patient, the whole family will be suffering on top of this. So if you can minimize the infections by good ICU practices, I think we'll be saving a lot of things as revenue, productivity from the attendants also. They lose their jobs. They don't go to the jobs. So overall things can be in a mess. So I think it's very important that we have to have a good ICU practices so that, and as Dr. Ramna told, we don't have any antibiotics coming in the pipeline for next 10 years as much as I know. We just have to use old and new antibiotics and hope for the best. And most important problem is, we know they are resistant, they are not working, and patients want to get recovered, which will not happen. It's a big toll onto the medical professionals. What do you call? We will not be able to tell anything to the patients. We don't know what will happen if you have a multi-drug resistant bug. I don't know the patient will become better or not. It's only time will say. All those things will reduce the productivity of our medical professionals also. You need to keep talking to the patients, attendants, explaining them same. And they may not, all the patients, even if we are there, we want to get out of the hospital fast, but sometimes it is not possible. So if you can prevent things, it will be much better for the patient mortality and morbidity.
As usual, it was a lucid and it touched, Dr. Venkatraman has touched each and every facets when it comes to infection control in ICU. Before I comment anything, any questions from the audience?
We can take a couple of questions. I hope it was not a bouncer, a yoker, and it was a sixer. So we are ready to take questions.
It's not a question, just wanted to tell that source control, which was which is very important. I think instead of changing the antibiotic,
To identify this.
yes, source control is, I think,
Yeah,
that
true.
was not stressed.
Yeah, true. But the purpose is why ICU is the epicenter. We actually focused on antibiotic resistance as a problem. So it's not the management of any infection. It's just only why ICUs are been a major problem of any HIPC. The reasons are elucidated. One is the patient profile, one is the devices, one is the antimicrobial resistance. It is not the treatment of any infection. We have not focused on a treatment. So for example, pneumonia, we just gave a bug and possible antibiotics resistance. Similar way, we just gave a description. We tried not to manage the case. It is just a focus, but yes, the source control, particularly when it is available, something like if you have a skin and soft tissue infection or an intra-abdominal infection, that takes a priority role along with antibiotic, just not antibiotic. And to just re-emphasize, not all patients behave the same way. I'm saying these are the cases which can come to your ICU. They are notorious areas where patients get a lot of antibiotic and then they come from, see, even your hospital may not be practicing. You cannot stop and control all the other hospital practices. So they may receive many antibiotics there before they transfer to you, and you grow them one or the other. Our experience was every and all patients who have been transferred from another organization or institution or another center, when we sampled them at the entry, all of them grew Acinetobacter. Surprising to us, they grew Acinetobacter, and that was a surveillance culture from one of our institutions when we had a Acinetobacter series. In the similar way, we have seen many patients who actually had grown a regular E. coli, which is sensitive even to the cephalosporins in many of our ICU settings also. Carbapenem resistance is somewhere between 50 to 60%, but less 30-40% even are sensitive to carbapenem. And whenever they are sensitive, we use them. We are just trying to focus on the pattern which we are seeing, which is sick and bad. Yesterday, keeping behind ICU, yesterday on a live situation, one of my physician colleague has sent me a photograph of a culture report of a Pseudomonas aeruginosa from a OPD patient's urine culture. And you have no clue. This patient grew Pseudomonas aeruginosa, and patient had a typical symptomatic UTI, and patient don't have any sensitive antibiotic in the list. I know all of you, if you have seen Pseudomonas, either it will be pan-sensitive or it will be pan-resistant. And the colistin is also been resistant, it's not intermediate. They never give sensitive because of your whatever newer guidelines change, but it's not intermediate, it is resistant. And my physician was asking me what antibiotic I can give it. And it is an OP patient, it's not a sick ICU patient where I can think about giving 4 or 5 antibiotic together. So this is not also uncommon now we see in either of the area. Yes,
If there are no more questions, sir, you can conclude.
No, I think Dr. Venkat has told each and every possible things when it comes to ICU as an epicenter. Being a working in an ICU since last 15 years. See, when it comes to a patient who is coming to ICU, there are many ways. They can come to ICU from the ward itself, or the patient is sick enough from community directly coming to the ICU, or few cases like being a tertiary center, we get patients from different parts of Telangana or maybe India who are already sick. They are there in their hospitals for a period of time. They receive multiple antibiotics before they come to us. And most of the time, we are forced to start with higher antibiotic that add to the resistance itself. And when it comes to ICU patient, as Dr. Venkat clearly told that the lines, tubes, all those procedures what do that add on to the infection. The patients, if you see that there is an IGCSM article, like 20% of patients who are in ICU, they develop some form of hospital-acquired infections. 20% maybe it is under reported. It might be much higher in Indian scenario. Second thing is, the patients who are in ICU, if they are sick enough, their Apache score is more than 20, they tend to develop more infection than compared to a person who is in ICU relatively stable. Let's say a dengue patient. Staying for 3-4 days, they may not develop much of infection like hospital-acquired infection or ICU-acquired infection. But somebody, let's say, having an Apache score of more than 20, sicker group of patients, and having multiple comorbidities. Apart from that, age is also an important factor. If somebody is having an age of more than 65 years old, maybe a diabetic, hypertensive, some form of immunocompromised state, they tend to develop or they there is a higher chances that these people will develop some form of hospital-acquired infection. Apart from that, the length of stay in the ICU. Those things, let's see, somebody is staying for 3-4 days, maybe multiple lines we have placed. These people, they tend to have less ICU-acquired infection. For someone, let's see, even if they are young enough, but staying in ICU for 20-25 days, the chances of developing some form of ICU-acquired infection is very high. And I am very sure, let's see, in all tertiary care hospital, I don't want to tell that in Yashoda, we have strict infection control policies. See, whatever you do, maybe the best infection control policy, I believe, is hand wash and hand rub. And maybe that crowding of the patients, and maybe the number of sisters taking care of the patients. Sometimes cross-infection do happen in ICU. These are the few basic things we have to look at. I think we are going over time.
Yes,
Like,
I think we will have
Thank
rest
you.
of the lectures which will conclude the same. So thank you, our moderators, and please take your seat back. We will move to the next topic, that is 10 commandments in infection control in ICU. I will request the next set of batsmen to come in. Dr. Gautam Reddy, HOD and consultant ICU, HOD of ICU in Prasad Hospital, Nacharam, Hyderabad. I'd also like to invite Dr. Kaladar, Head of Critical Care Unit, Chairperson of HIPC at Yashoda Hospital, Malakpet, to chair the session. Moderators to introduce the speaker.
Good morning, everyone. With the kickstart lecture of Venkat sir, we'll go to the next session. So the topic will be discussed by Dr. Monalisa Sahu ma'am. She is the Senior Consultant Infectious Diseases at Yashoda Hospitals. So the 10 commandments will be discussed by ma'am. Ma'am, please.
Good morning, everyone. After the lucid lecture of Dr. Venkatraman, I shall be following it, like how to deal with the infections and like how can we prevent it. Sir has already elucidated like how the ICUs have been the epicenter of the infections, and I shall be discussing how the 10 commandments, like the measures we can take to prevent these infections. So we shall be dealing under these topics. As all of us know, the healthcare associated infections have been a major problem, and they are defined as those which were not present at the time of the patient was admitted to the hospital, and they developed about 2 days after the admission, and they contribute a lot to the mortality, morbidity, as well as the costs incurred, and also the duration of hospital stay. There have been the WHO global report which states that about 70% of the hospital-acquired infections are preventable by the various measures that can be taken. And definitely the hospitals are, the healthcare facilities are the environments where these resistant bugs do transmit. There has been a systematic review which states that in the developing countries, the incidence of HAI is as high as 15%, and in the ICUs and the critically ill patients, it is as high as 34%. And they incur a huge cost on the patients and the economics, amounting to about $28.4 billion to $45 billion. And the surveillance of these infections can definitely prevent them. And the major infections include the catheter-associated urinary tract infections, the CLABSIs, and the VAPs. One of the major studies which was conducted in the 45 lower middle income countries showed that the rates of these hospital-acquired infections, the CLABSIs, VAP, and COTI, were much higher in these lower middle income countries as compared to the US. As you can see, the brown lines, bars represent those in the developing countries. In another study which was conducted to see how the economic burden these infections incurred, in a study in the Ethiopia, which showed that the patients who had the hospital-acquired infections, the length of the hospital stay was about 18 days as compared to those of 10 days who did not have a hospital infection, and the costs were about 3 times in these patients as compared to those without a HAI. So even in the developing countries, like a poor country like Ethiopia, even there the costs are about 3 times, and the most common infections were the surgical site infections and the pneumonia. In another study, which is a multi-center study conducted in the India, northern part of the India, which included about 26 tertiary care hospitals to assess the burden of the HAIs, it showed that the main infections were the COTI and followed by VAP and CLABSI. And the incidence rates were pretty high. About 70.9% of the individuals had a hospital bloodstream infection, and among those, the CLABSI was there in 55% of them. And for the COTIs, it was about 89% of them who had the UTIs, and the COTI were about in 97%. These figures are pretty bothersome, and they need, they emphasize how these measures need to be taken to prevent these infections. So summarizing these slides, how the burden of the diseases include, it is the VAP and the COTI are the most common ones. And they definitely have a severe impact on the outcome of the patients, as well as a significant economic burden, and they increase the duration of the hospital stay as well. So we shall be having a few, to know how you go about. You can scan the QR code so that we can have a few questions. Scan. So you need to scan the QR code, and then we can have a set of questions which you can answer after you scan it. Can we go to the question?
If anyone wants an internet connection, they can scan the QR code.
I think all of you have scanned the code, so we can go to the question. So before beginning, what are the 10 commandments, we would like to know, how satisfied are you regarding the observation of the infection control practices in your ICU? So the options are here. You can click on the option in your cell phones. Is it working? Okay. So this is at the beginning of the talk, and let us again, we will see at the end of the talk, you will analyze what are the measures that you are taking and how you go about it. How many seconds is it? 30. The answer is still not there. Oh, subsequently, okay. Fine. So we will see how we go about it. It's not coming. I think there is some glitch.
In the end, it comes. We have 5
The end
polls.
means
We have
at the
5
total end.
questions total.
Okay, at the total end it will come. Okay, we'll see it then. As we know, this is the chain of transmission where there is an interaction between the susceptible host, the infectious agent, and the reservoir, and the other modes the portal of entry, exit, and the mode of transmission. So we need to break this chain of transmission to control the infections. At several points, this can be done. The practices that we need to observe in the ICUs to prevent the infections include the standard precautions and the transmission-based precautions. The standard precautions are those which apply to every patient, whether they are infective or not, suspecting them to be infective. And they are designed to prevent the infection in the healthcare professional as well as preventing the transmission of the infections. And the transmission-based precautions are the ones which are to be used in addition to the standard precautions. And they may be used for the patients who are infected or colonized and to prevent the transmission. The various precautions that need to be taken include the contact precautions, including washing of hands, hand hygiene, and the personal protective equipments, PPEs. And they are mostly for the infections which are transmitted by direct contact, including the MRSA, the Clostridium difficile, and the Sarcoptes, to name a few. Coming to the droplet precautions, they are for the ones which are transmitted by the droplet method, and they include mostly the various viruses like the influenza virus, the norovirus, and the Neisseria meningitis, mumps, to name few. And in that, in addition to the contact precautions, we need to have a eye gear and as well as a face shield and a tight-fitting mask to prevent the transmission. The airborne precautions are for the pathogens like the TB and the varicella. And in addition to that, we should have a tight-fitting mask and the doors need to be closed. So these precautions need to be observed to prevent the infections. There are several components of the standard precautions which need to be observed to break the chain of transmission, which include the hand hygiene, personal protective equipment, respiratory hygiene and cough etiquettes. We shall be dealing with all of them in a while. So the next question on the slide, the answers will be after the poll. Do you feel that performing hand hygiene before the procedures or patient contact would reduce the rates of infection in your hospital? The options are there. All of us know that performing a hand hygiene would be definitely helpful, but there are many barriers to which prevent us from performing it. What do you think are the preventing factors that prevent you from doing hand hygiene before every patient contact? The options are there. Do you feel that it is a lack of time, or you feel it's unnecessary, or there is a non-availability of the hand sanitizer at the bedside, or none of the above? We know that there are two methods of hand hygiene, the hand wash and the hand rub. The hand wash is to be observed when there is a clearly soiled hands or preventing a Clostridium difficile infection, and the hand rub can be observed at the other times. So in the want of time, we will skip this. So as we discussed, hand washing should be observed when there is a visibly contamination of the hands and preventing the Clostridium infection. There are the 5 movements of hand hygiene. We all are well aware with it. The personal protective equipments, which include the gloves, the gowns, the face mask, eye gears, respirators, and the face shields. They are also important part of the standard precautions. The donning and the doffing of the PPE as the day advances. Prevention of the needle stick injuries and sharp injuries is also very important in preventing these infections. We should not be trying to take off the needle or break the needle, or no recapping of the needle, and not trying to force into the sharps container and putting our fingers into the sharps container. These all can prevent the sharp injuries or the needle stick injuries. In the wards, there are several high-touch surfaces which are contaminated with these resistant bugs. So we should ensure frequent disinfection of these high-touch surfaces, and inappropriate disposal of the gowns should not be there. The patient trolleys for transferring the patient should be disinfected, and adequate availability of the hand wash should be available at the bedsides. There are also several environmental control measures which need to be observed. They include proper training of the staff and proper observation of measures to prevent the infections. Hypochlorite solution should be used for the cleaning purposes. There are also certain procedures which are tending to generate aerosols in a large amount, like the ET intubation, endotracheal intubation, bronchoscopy. And when these procedures are being done in the ICU or like a CPR, we should be observing certain measures to prevent the transmission of these aerosol-based infections. Like it should be done in adequately ventilated room, and the healthcare professional performing it should be wearing a full PPE with the N95 mask and face shields, and a long full sleeved gown with gloves need to be worn before performing these high aerosol generating procedures. There is another important approach which can prevent these infections, the bundle care approach, which most of us are aware of. The bundle care approach includes a set of interventions which, when performed together, proven to prevent the infections. We have the VAP bundle, the COTI bundle, the CLAPSI bundle with us. Also, they will be dealt in detail by the other speakers. The bundle care approach, as we know, are a set of interventions when performed together, and the VAP is very common, and the VAP bundle is there. The risk factors which predispose to VAP include the patients with prior comorbidities, presence of shock at intubation, use of higher antibiotics, and re-intubation if required. There have been also studies the systematic review, which showed that in the Southeast Asian region, the VAP was pretty common, and several studies were included in this systematic review, and they showed that the VAP incidence rate was about 2.13 to 116 per 1,000 ventilator days in the various hospitals, and one of them, which was the highest, was in the North Indian Hospital in the GB Pant. The various components of the VAP bundle include the subglottic suctioning, the ventilator tubing management, and readiness to extubate, assessing each time whether the extubation can be done. They are the high quality evidence, and the moderate quality evidence includes the oral care and the subglottic suctioning. So these are the ways to be done. And the various types of suctioning include the subglottic suctioning and the routine suctioning. Coming to the COTI, the COTI are the most common hospital-acquired infection, and they are mostly 60 to 70% of them are preventable. The increased risk factors which predispose the patient to developing a COTI include the female gender, presence of diabetes, elderly age group, and the duration of catheter if more than 5 days. There are several sites of entry of these bugs, which include the junction of the urethra with the external urethrometers, then at the junction of the catheter with the drainage tube, junction of the drainage tube with the collection bag, and the collection bag. So these points need to be taken care of so that we can prevent the infections. The COTI care bundle includes the insertion bundle and the maintenance care bundle. We should be avoiding unnecessary catheterization, using appropriate sized catheters, sterile equipments, closed drainage systems should be there. And the maintenance care bundle includes asepsis, and the drainage bag should be above the floor and below the bladder. And there should be assessment of catheter removal, prompt removal, as and when can be possible. Coming to the catheter-related bloodstream infections, there are the CLAPSI and the CRBSI. And the various risk factors include the immunocompromised population, presence of prolonged hospital stay prior to the insertion, depends upon the site of insertion as well, and the indications. So it also has the insertion bundle and the maintenance bundle. They all will be dealt in detail, so I'll just rush those slides. There should be we should be assessing for the removal of these devices as early as possible to prevent the infections. In one of the studies which was done in the South India to show that these care bundles, when done together, they decrease the incidence of these infections, hospital-acquired infections. It showed that as you can see in the pink bars, after the performance of the bundle care approach, there was a definite decrease in the incidence of these hospital-acquired infections. It is similar with all the three, the VAP, CLAPSI as well as COTI. So when these bundle care approaches are done, we can decrease the infections. The other important components include the biomedical waste management, management of spills, and the patient placement, and the ventilation. So the biomedical waste management should also be done according to the rules, and it should be done at all the stages of the generation, starting from generation to segregation, as well as collection and treatment and disposal. The rules should be followed, and the waste should be disposed in the particular categories according to the rules. The environmental control also should be done. Like there should be certain air changes that should be done depending upon the area. Like if it is an registration area or OPD area or inpatient department, about 6 air changes per hour are recommended. But in the higher risk settings or waiting areas or the ART centers, the TB chest departments, about 12 air changes per hour are recommended so that we can prevent these infections. These are the methods of how we can disinfect these used instruments in the ICU. The HI surveillance is also a very important tool by which we can detect the infections early and can undertake measures to prevent them. The HI surveillance includes, it is an ongoing systematic collection of the data and interpreting it, how we can prevent the infections. It is to improve the quality of the infection control practices, as well as it also helps in evaluating the effectiveness of the measures taken. The outbreak investigation is also a very important part. We shall be discussing in details later. Like there are 10 steps to the outbreak investigation and all will be dealt in detail. So the HI prevention undertakes several steps as we discussed. The hand hygiene, the aseptic precautions for the insertion of the devices, the cough etiquettes, the adherence to the checklists, isolation rooms for the immunosuppressed, and following the SOPs. If these are done, we can prevent the HIs to a great extent. The other important component of the infection control is the antimicrobial stewardship, which means usage of the, it comprises of 3 parts. The antimicrobial stewardship along with the infection prevention stewardship and the diagnostic stewardship. All of these should be undertaken together. The antimicrobial stewardship is like the timely de-escalation of the antibiotics and depending upon the pharmacokinetic and pharmacodynamic properties of the drugs. The infection prevention stewardship encompasses the various measures that need to be taken, like the hand hygiene, isolation measures, and the screening of the patients. And diagnostic stewardship is the usage of the various rapid diagnostic tests to taper the antibiotics as and when they're required for the patients. So when all the 3 approaches are put together, we can have a effective control of the infections, the antimicrobial stewardship, and also these days the antifungal stewardship is also coming up. The other components of prevention of infection include prevention of the occupational hazards, prevention of the needle stick injuries, providing the post-exposure prophylaxis after the exposure to the infections, and the vaccination of the healthcare workers. Coming to the occupational hazards, they can be further categorized into the biological hazards, the chemical hazards, the physical due to the radiation exposure, the psychological as well as the ergonomic. The biological hazards, the most important ones include the blood-borne ones, including the hepatitis B, C, and the HIV, the droplet infections, and the airborne, the direct contact that we have already enumerated. There have been the WHO reports, a global report says that the needle stick injuries contribute about 39% of the cases of HCV, 37% cases of the HBV, and 4.4% cases of the HIV infections. And all of these are if taken care of, are preventable. Also, the studies have been shown that the transmission of TB in the healthcare facilities is also very high. In about 470 working doctors who were interviewed over a 1-year period, it was seen that about 9 of them developed TB during the subsequent periods. And in about 231 newly joined resident doctors, about 4 of them developed TB subsequently. The various contributing factors include low nutritional status, lack of proper diet, and having irregular breakfast and all that. They contribute to the increased incidence of TB in these healthcare professionals. The needle stick injuries are also an important thing, and the most important time when they can occur is during the use of these devices. And the most important devices include the disposable syringe and the suture needles, which comprise to the most important part of the needle stick injuries. They are all preventable. We should be avoiding recapping of the needles. The scooping method should be used for recapping the needles. And as you know, the 3 most important bloodborne infections include the hepatitis B, C, and HIV. And it is about 30% of the hepatitis B, 1/3 of the hepatitis B can be transmitted by these needle stick injuries, about 3% in the HCV, 1 in 30, and 1 in 300 for the HIV. So the post-exposure prophylaxis, there are several post-exposure prophylaxis. We need to categorize the exposure as well as depending upon the source code and the exposure code. If you have exposure, then the needle stick injury, then we need to immediately wash it, not to scrub it, and not to apply any antiseptics or bleach at the site. If there is a splash of body or blood, then we need to immediately wash it and not to use antiseptics. If it is exposure to the eye, it needs to be irrigated immediately with water or normal saline. And if wearing contact lenses, not to remove them before irrigation. If it is in the mouth, then we need to rinse it immediately and spit it out and repeat the procedure multiple times. Then categorizing the exposure, like there are several exposure codes for the HIV, like it is exposure code 1, 2 or 3, we need to know. And accordingly, the source code is also there depending upon whether the patient is a high viral load or a low viral load. This is the source code. And then accordingly, we need to categorize and we need to see whether the patient requires a post-exposure prophylaxis or not. Similarly, for the hepatitis B, it is so. The post-exposure prophylaxis should not be delayed. It should be given immediately within 2 hours of the exposure and preferably within 72 hours. And if the testing is not available, we should not be delaying the administration of the drug. The treatment of the preferred post-exposure prophylaxis is the TLD regimen, the tenofovir, lamivudine, and dolutegravir. Coming to the hepatitis B, we can further categorize the patient as the source code is there, and then if the patient is previously vaccinated and the antibody levels are more than 10, he does not require any treatment. If it is less than 10, then we need to, and the patient is positive, then we need to give the immunoglobulin along with the 3-dose vaccine series. The vaccination of the healthcare workers is also very important in prevention, and the vaccines that have been recommended include the hepatitis B vaccine, and the other vaccines include the influenza annually to be given, the measles live vaccine, the rubella virus vaccine for the female healthcare workers, and the tetanus and the meningococcal vaccine. So after dealing with all these things in detail, the 10 commandments that I think are important in preventing these hospital ICU infections include hand hygiene, use of the appropriate personal protective equipments, prevention of the sharp injuries and safe injection practices, observing the bundle care approach, the VAB bundle, the COTI bundle, and the CLABSI bundle, control of the environment like using appropriate biomedical waste management and management of the spills, sterilization and disinfection of the various devices that are used. The surveillance, hospital-acquired infection surveillance is very important in detecting these outbreaks very early. The antimicrobial stewardship along with the infection prevention stewardship and the diagnostic stewardship also is a very important role. Avoidance of the occupational hazards and needle stick injuries, and appropriate post-exposure prophylaxis and vaccination of the healthcare workers. These are all the methods that the commandments that can be helpful in preventing these infections in the ICU. So at the end, let us again evaluate, like after knowing all these factors, are we implementing all these in our ICUs, and how satisfied are we at the end of the talk, analyzing how these things go about. I think there will be a drop in the satisfaction levels after knowing. Slido.
Can we have the results?
It's not coming.
While they compile it, I think we'll summarize the talk by the moderators.
Thank you, Mona Lisa Madam, for that insightful fundamental concepts of infection control precautions, especially very important, like they may seem basic, but which are very important in regular practice to prevent the infections. One point regarding the recent update in International Society of Infectious Diseases regarding, as you were mentioning about VAB bundle care, where oral care previously used to be with chlorhexidine. Probably in that they mentioned one meta-analysis showed that rather than oral chlorhexidine, you have to use only toothbrushing. So because chlorhexidine can be cytotoxic, and it can actually increase the mortality. One meta, I think Weary et al. Or someone did that.
Now it is with normal saline, that is what is.
Yeah, only toothbrushing is enough rather than chlorhexidine. So that is one point probably just wanted to stress upon. And another important thing is vaccination, as you told, like recently we are seeing a lot of influenza epidemics. Recently we did one class also webinar. So on that, so most of the healthcare providers especially are not very vaccinated with influenza. the new influenza quadrivalent influvac has come. Now I think I suggest everyone to take that vaccination to prevent yourself from, because we are seeing a lot of influenza ARDS patients also.
The newer strain also comprises the similar strains that were available the previous year. So it is the same vaccine that has come. And awareness regarding the adult vaccines.
Recording in progress.
Okay. Any questions from audience?
Yeah, thank you, Mona Lisa ma'am. It was a very nice presentation, very vast topic, but you managed it to concise it so the audience gets the best out of it. And one more thing I wanted to add regarding the surveillance is, though we all know that surveillance plays a major role in preventing infections in any hospitals. So it's not only about collecting tools and charts and analyzing them, but it's also from the engineering perspective and administrative perspective that plays a key role. Like engineering perspective, I mean the regular flow check of airflow to control infections. That plays a main role. And from the administrative perspective, to create, after the surveillance, to create an antibiotic stewardship that puts all the departments in one page to restrict the antibiotic use in any hospitals. I think that goes a long way. Yeah.
Rightly said, Dr. Gautam. Like the surveillance is very important and it plays an important role in the antimicrobial stewardship as well. Thank you.
Okay. Hello. Madam, is there any recommendation for cleaning up the floors and beds in the ICU? Is there any recommendation for that?
Regarding the cleaning of the floors and the high-touch surfaces, it should be done about 3 times a day. And if there is any increased incidence of these infections, then it can be increased further. The number of times can be increased further, and hypochlorite solution to be used for the blood spills and all.
For the floors
So the floors which are known as a low touch, floors which is, if you see the CDC's latest recommendation, that is 2024, they give you clearly how many times. So high risk, so ICU comes in a high risk area. So they recommend minimum of 3 times with disinfectant. That depends upon which disinfectant you use for the concentration, right? To determine what is the concentration. So minimum of 3 times. But then if you have a high flow of patients and relatives, you can do as and when.
Yeah, it's very important actually, especially as you are mentioning about even cleaning of the bed and all the surfaces, even monitor and all. We at our Yashoda Malakpet, we were discussing with Venkat sir in our meeting. Regularly we conduct our monthly meetings. So we had more Acinetobacter infection. Suppose one patient coming from outside came with VAP and Acinetobacter comes in. So we have a bed distance bit less, where it is easy to spread the Acinetobacter across. So when we had 2-3 cases and outbreak, we used to do terminal cleaning. We will be used to vacate that area and clean all the beds, monitors, everything, then shift these patients. Before shifting, clean even patient and shift to a new bed. So we did this practice regularly. We could totally eradicate Acinetobacter. We had a vast discussion, sir was telling. So especially the Acinetobacter point of view, if you do this practice, it is very easy to eradicate as compared to Klebsiella, Pseudomonas and other things you may not be able to eradicate. So it plays a very important role. Sometimes we call it as terminal disinfection, even cleaning ICU AC vents and all.
Is there any solution to recommendation for the cleaning of the surfaces, monitors and the beds and all those things, sir?
So we will be dealing with that a little in detail in the afternoon. So your doubts will be cleared with that. We are running a little short of time, so we will go to the next topic. Thank you, moderators, for moderating the session. I request the next moderators, Dr. Madhusudan Jaju, the head of critical care unit and also the chairperson of HIPC program at the Yashoda Hospitals, Hyderabad, to moderate the session. Also request Dr. Kola to moderate the section. We're going to the next topic, that is challenges in implementing infection control practices in ICU. This talk will be given by Dr. Anup Warrior. Unfortunately, we don't have him here because it is Onam, but he will be joining us through Zoom. Dr. Kola to introduce.
Yeah, so
please turn on the camera.
It's actually an honor and privilege to introduce Dr. Anup Warrior, who is a good friend of mine, and he has been a pioneer in infection control, and he has been very passionate about it. That's why we wanted Dr. Anup to be here to actually deliver this lecture. He's an infectious disease specialist by specialization, but he also takes a lead roles in many administrative as a group chief of medical affairs and quality, Aster DM Healthcare India. And he has been ambassador for SIA and many actually a seasoned clinician. So we will take Anup Warrior will be also available live all to us. So we'll start the session.
Good morning to you all. And first of all, apologies for not being there in person. It's Onam for us on 15th in Kerala here. The topic assigned to me is to discuss about the challenges to infection prevention programs and infection prevention control in the ICU. And this I'll be discussing in two parts. There are some modifiable factors in prevention of hospital-acquired infections. So that is obviously where we want to put our focus and efforts on. But there are also some non-modifiable risk factors, which are challenges, but unfortunately there is nothing much we can do about that right now. Examples are age, genetics, etc. Other than this fact that there are some non-modifiable risk factors, one of the biggest challenges for infection prevention in ICU or in hospital in general remains the gap between knowledge and practice. So most of the healthcare workers do possess basic knowledge of infection control and asepsis. We have umpteen number of training programs, induction programs in the hospital, etc. In spite of that, the practice at bedside is still lacking. So this bridging the gap is something again which is a challenge and which we need to address, and I will spend a couple of minutes on that. Starting with the first part, as I was mentioned about non-modifiable risk factors about which we can't do much, is the patient vulnerability. With the age and comorbid illness, including more and more immunosuppressive states being produced, with transplants increasing, rheumatological conditions, immunomodulators being used, oncology patients, chemotherapy, etc. The kind of patients which we see in our ICU are more and more immunosuppressed. The mean age of a medical ICU patient is more than 65 in many of the ICUs in India. Sometimes an ICU more than 50% is filled with elderly people with severe comorbid illness. And we know from multiple studies that age and comorbid conditions are independent variables that impact mortality and ICU outcomes. And they invariably have problems with infection prevention. They develop multiple episodes of hospital-acquired infection, and it's a great challenge managing these people. We also cannot do without invasive devices in the ICU for monitoring purposes, for medication administration, for draining out an infected fluid. So from head to toe, a lot of invasive devices are used in the ICU, and these create what we call as portals of entry, right? So a person without an invasive device is obviously at a less risk of hospital-acquired infection than somebody with an invasive device, right? Because these invasive device in a vulnerable patient, we are introducing a portal of entry, and that because we cannot do without these, because either they are for monitoring purposes or for administration of medications, or as I mentioned, for source control, etc. End of the day, we do need them, and it is a challenge managing them without them functioning as portals of entry for infection. Nursing ratios may not be something which at the larger picture we focus, but this is one of the surveys done in 2018, published in 2020. It said that more than 50% of the ICUs in India actually lacked adequate nursing ratios when compared with the patient acuity they were dealing with. We know from multiple studies, again, with evidence base, that nursing ratios have got significant impact on hospital-acquired infection. Now, is it modifiable or non-modifiable? If modifiable, who can modify that? Who can ensure that nursing ratios are implemented? That is all for debate and discussion. But end of the day, we know that nursing ratios versus patient acuity has an impact, and providing adequate nursing ratio based on the patient acuity remains a challenge for us. If you look at the WHO IPSC program manual, we talks about something called as multimodal strategies, right? So many things being done together so that you create an impact at the bedside. So in this, if you look at the foundation, okay, which is in the brinjal or purple color, the foundation is what is called as enabling environment. So even in our day-to-day hospital infection control programs and practice, if you look at it, we actually focus on the middle blue part. That is, we focus on guidelines, we focus on education and training, we focus on surveillance, we focus on monitoring, audit, and feedback. But our focus and action to ensure that there is an enabling environment for the staff to make these things effective is a challenge and is often lacking. So what is this enabling environment? It can be classified into built environment, that is how the design and infrastructure of your ICU is there in terms of bed spacing, in terms of requirement of isolation beds, right? It can be in terms of materials and equipment. So are they easily washable, disinfectable, cleanable materials? Do your equipment handle the disinfectants well? The workload, staffing, and bed occupancy are all linked. Based on the bed occupancy and workload, enabling and ensuring trained staff is a part of having the right environment in place. Okay, and again, going back one slide, this enabling bed environment is the foundation of an IPC program. So without getting sometimes the foundation well or well entrenched or well set, we often move on to the implementation part of it: guidelines, training, surveillance, monitoring, feedback, etc. So one of the challenges for us is to go a step back and look at whether we have provided the right environment for our staff to practice what we are telling them to do. The next challenge is what we can call in a nutshell as lack of culture of safety. Okay, so culture of safety is an attitude. It is the way people think and behave in the environment in which they work. So it starts with a set of values which all of them agree together, right? So, right, it may be an example that we need to prevent bloodstream infection, and for that we all need to adhere to hand hygiene practices or handling the line practices. So it's a set of values which all of us agree. There are rules and procedures which all of us follow because we believe by the values which we stand. There is open communication so that gaps and lapses are identified and corrected. There is ownership of the whole program or the requirement or the project. People are recognized for what they do well, and to facilitate this whole thing, there is adequate leadership. So all in all, this is what builds up the culture of safety. And this is again a challenge to establish this culture of safety where all of us agree to common values, all of us agree to follow the rules and procedures, all of us ensure open communication, we take ownership of what we do, we ensure that people who do well get recognition, and we are able to provide leadership to the unit in which we work. There are plenty of guidelines out there for infection prevention. So there is no dearth of knowing what to do. So anybody can open a Google and find out the latest updated guideline for preventing catheter-associated bloodstream infections or preventing catheter-associated UTI or preventing VAP. So you have plenty of guidelines out there. So it's not that we do not know what to do. We can all look at what to do. The problem is implementing these things on the ground. So globally, these are the 5 strategies which have been used in implementing. So audit and feedback, all of us are familiar. Educational material distribution and other parts, ways of educating, all of us are familiar. But rest of the 3, facilitation, that means all of us who are stakeholders, nurses, technicians, doctors, management, etc., sitting together like a classical or a traditional HICC, Hospital Infection Control Committee, and have open discussion on what needs to be done and what can be done. That is called facilitation, and that's an improvement aspect, and that is very important aspect of the implementation. Second is strategy tailoring. That is, each ICU, each person, each hospital is different. So based on the hospital, based on that ICU, based on the people who work there, you identify the barriers to what you want to do or get it done, and your strategy to get things done is tailored at addressing those barriers, right? So you have a deep knowledge of individual hospitals problems, individual ICU problems. You identify the people with whom you have to develop a connect, and you develop a strategy to address those. Identifying clinical champions is often the next strategy which is used. This again, though theoretically this has been widely publicized, the implementation part of it, having a clinical champion who actually takes ownerships and runs this program on the ground, that also becomes a challenge. So somebody who has a strong clinical champion on the ground for IPC is actually lucky, because they can really turn things around. They can provide the leadership which we mentioned earlier. Now we have material or guidelines on how to implement this knowledge also. Okay, so this is the SHIA IDSA EPIC practice recommendation, which was published in 2023, which tells you how to do what you need to do. Okay, so the previous guidelines which we discussed, or which I showed you, all of us tell you what you need to do, right? You need to hand hygiene, you need to do barrier precautions, you need to wear PPA, etc., etc. But this is a guideline out there which is telling you how to do what you need to do. So this is what I was talking about, bridging the gap between knowledge and practice. So this is giving you knowledge about implementing the knowledge which you have. The last part of this session is to discuss a bit about execution, because all of us start with a lot of ideas, lot of plans, sometimes on a wide scale, sometimes on a smaller scale. But end of the day, it is a challenge getting this done on the ground and to demonstrate improvement. I want to take you through the 4 disciplines of execution, and to take this back and try to apply it in your practice when you look at infection control programs, or you run an infection control practice in your ICUs or in your hospital. So first is called discipline of focus. So that means you may have 100 things to do, but you should prioritize. You should be able to prioritize and get down to the bare 3 or 4 things on which you have enough time, energy to get those, go behind those, and get those done on the ground. So first is discipline of focus. Learn or identify focus areas and try to prioritize and look at what is most important. Okay, so one of the typical examples is that many of us spend a lot of energy focusing on people's footwear, or ensuring that people change into gowns, etc., rather than the actual handling of the line or hand hygiene before touching the line, right? Because it is easy, or the focus sometimes shifts to something which is not as important as footwear or a changing of gown, to something which is majorly important, like hand hygiene when handling a sterile line. The second is called discipline of leverage. That means you need to identify lead measures. That means once you identified your goal, what to do, how do you measure what you are going to do, or the goal or the final output of your activity? How are you going to measure that output of your activity? So that is a lead, called a lead measure, and you need to act on this lead measure. That means you need to generate a measure on which you will identify whether, how can I know that the work I am doing is making a difference on the ground. Third is called discipline of engagement. And this talks about using a compelling scoreboard, meaning you keep your eyes on the road. So once you have identified your lead measures, you have a scheduled review of your lead measures, so that you know that you are going in the right direction. You are going in the way of improvement. You are not stagnant, so that if you need to change strategy, you can do it early enough. You know when you fail, you know when you succeed. So you need to keep the eye on the road using what is called as a scoreboard. Finally, and most importantly, it is something called as discipline of accountability. So here, the culture of safety and this are interlinked, where each person in the unit takes accountability for the best outcomes of each patient. And this is again a follow through of what I spoke about, the culture of safety. We should also understand why execution fails. If these are these disciplines of execution, why aren't people able to do this on a day-to-day basis? So first thing is what is called as a whirlwind. That means you have so much of, you are caught up in so much of day-to-day work. That is what is in the slide described as existing work and urgent tasks that need attention now. That all our energy and time and focus is spent on just doing that. right? You are focused on just doing the day-to-day work that you don't have time to take the big picture, move back and look at all these goals, initiating new activities, identifying important tasks, etc. So people lack the clarity, commitment, and accountability. So even when you have the time and you have identified what are the activities to do, sometimes the people on the ground still we are not able to give them the clarity. We are not able to get that commitment and accountability from them to actually deliver on these goals. So these are the two major reasons why execution fails. And this is one of the reasons why the leader of the unit should not be too engaged into day-to-day work. That is very, very important. If somebody is too engrossed into the minute day-to-day work, they will not be able to provide leadership and improve or work on quality improvement, because somebody has to take a step back, look at what is happening, measure what is happening, monitor what is happening, and act on certain things, right? So for that, you can't be too engrossed or put your head burrowed into day-to-day work. So before I close, these are my take-home messages. We need to overcome these challenges and what I described in this short time. The starting point is that we need to establish a culture of accountability and collaboration. Okay, so this is a challenge. Establishing the culture of accountability and collaboration is a big challenge for infection prevention. And if we need to do this, we need leadership. We need good leadership at the hospital level, and we need good leadership at the infection control program level. Okay, so it may be your ICU head, it may be your infection control officer, whoever is it, and it may be a CEO, MD. So you need leadership so that culture of accountability and collaboration exists in your hospital, exists in your unit. That is the first challenge which you have to overcome and address. Second is that you need strong data and technical support. Why? Because you need to establish strong surveillance system. You need to measure compliance as well as outcomes. So if you want to have surveillance system to measure compliance and outcomes, you need people and technology, right? So that is the second most important challenge. We need people, we need technology, which ensures that we have strong surveillance system. We are able to measure compliance and outcomes so that we can identify what has to be done and how it has to be done. The last and probably very, very important is lack of execution capabilities. Many of us are not trained in what is called as project management. We need to work towards a consensus goal. That means all of us in the unit or the hospital agree that we need to come or reduce the CLABSI or COTI or VAP to this within this time mode, right? We need this consensus and we need to work in a project mode. So what is the difference between a project management mode and just having a goal in your mind? When you convert it into a project, it has defined interventions. Everybody knows what is going to be done and who is going to do that and how that is going to be done, right? There are defined timelines which are monitored and looked at with accountability. So people are held accountable for their interventions and to their timelines. And finally, all of us have a target to reach to, right? So this means that all of us should come together for execution in a project mode. So quickly summarizing, major challenges for which we need to address for infection control programs in your hospital as well as your ICUs are: ensure leadership so that culture of accountability and collaboration can develop, ensure people and technical or data support so that you can have a strong surveillance system to measure compliance and outcome, train yourself to execute in project mode so that things get done with fixed timelines and achieving your targets. So to close, I summarize all this in 6 major headings. The IPC challenges in the ICU. One is patient vulnerability, about which we do not have much control. Second is use of invasive devices, which we have some sort of control. We can decide the indications for insertion. You can control how you handle these invasive devices with suitable asepsis, etc. Nurse-patient ratios. Again, this is something under our control. Good manpower, trained manpower giving at bedside is very important, and that remains a challenge. Lack of enabling environment as the cornerstone of the WHO's IPC program recommendation, meaning the design of your ICU, structure of your ICU, the machinery, the equipment used, the people who are there, etc. So that providing that enabling environment becomes a problem. Developing that culture of safety, predominantly from a good leadership becomes a challenge, because sometimes we don't have that kind of leadership available on the ground who are able to develop or get this culture of safety embedded into the staff. And finally, lack of training on execution among the leaders. Some of us are leaders by default because we are put in there because of either seniority or because we are been in this profession for so long. But we might be extremely good physicians, extremely good surgeons, but are we good executioners? Are we trained in executing a project in a timely fashion, in a goal-oriented fashion to achieve the targets? Right? That is also something which sometimes requires training. And that I would put as the final and one of the important parts of the IPC challenges in ICU. Thank you all, and I close my session now. And I will be joining you live on that day. And if there are any questions or queries or which you want to discuss any other points regarding this, you're all welcome. Thank you.
Yeah, thank you.
Good morning to you all. And first of all, apologies for not being there in person.
Stop the
It's
video.
Onam for us on 15th in Kerala here. The topic
Stop the video.
assigned to me is to
Yeah, go to the live. Yeah, good morning, Dr. Anup, and welcome you on board for this program. It was a
Morning.
wonderful session. Happy Onam to you.
Thank you. Thank you.
So it's so kind of you to be available to us to enlighten us on this topic, which I have seen you over the years to decades. You're being so passionate about infection control, and you are talking about these antimicrobial stewardship programs also with collaboration with your colleagues and teams, with taking accountability and responsibility. Is year back, 15 years back, when I actually heard those lines from you. And today you are again talking about enabling your environment, collaborating, taking the leadership, execution. These are the major challenges which we face. You raised two important components, and you actually kept very diplomatically that line ki modifiable or not modifiable, that is nursing ratio. So it's been a universal challenge across, like a universal precautions. So as an administrator, as a even ID specialist, and even a leader in infection control policies, how are you addressing that from your organization?
So one of the things is to accept it as a lead measure, as I was saying in the execution thing. So unless we monitor the patient acuity versus the nursing ratios, and we are able to communicate this to the top management. So you see the MD or whoever has holds the purse, right? Whoever has to spend. So first step is to have it as a measure or as a quality indicator of the ICU, and ensure a system where this is monitored, measured, and transmitted to the people who hold the purse, so that they understand this is where we stand now. As you mentioned, I always believe in collaboration, and the same thing applies when we deal with the management also, or the administration also. So getting a buy-in from the administration is often possible, and to make them spend money is often possible if the communication is right and you have developed that relationship with them in the right way. Okay. So, but you have to talk to them with data. Nobody will open up their purse based on an emotional appeal. So you have to talk to them with data. So we monitor the nurse-patient ratios in the ICUs, look at the outcomes, transmit or inform this to the top management, so that the HR and others are provided the right orders, that this is the number which we need for this much patient strength, and this is how you will need to plan, budget, and allocate your manpower. Okay, so one of the things is this, we have to be a part of the budgeting exercise, the nursing budgeting exercise also. Just have a, why I'm saying this, I don't know if there are nursing heads or somebody in the crowd, but what I'm saying is that most of the nursing leaders, they would want to run with say 80 or 70% of the total planned manpower, because with the ups and downs in the hospital occupancy, it sorts of what do you call balances off. But when it comes to ICU, you need to look at both your peak occupancy and your mean occupancy, and you need to budget and plan for your peak occupancy, so that even when it is stressed, your systems don't collapse. Okay. the manpower can be sometimes shifted from a different location or a unit to your unit to handle the peak. But when you budget at a larger level, that means your ICU nurses total in the hospital, you need to budget at peak level. Okay, so I'll just quickly summarize 2 points to address this. One, you need to keep an eye on the nurse-patient ratio so that you can communicate in hard data what is the nurse-patient ratio and what are the outcomes. And two, you need to be a part of the nursing budgeting and ensure that your peak ICU occupancies are considered when they budget for the nursing number.
Thank you, Anup, for giving and quite difficult topic, putting in a proper way to understand for most of the people. Lot of people have the confusion regarding that. We know the knowledge, but how to implement on the bedside is a big issue is there. I think you given a lot of clarity. Any other questions? Anybody having the questions?
Anybody has questions? Yeah, we have nursing heads who has the same challenge.
Dr. Anup, this is Lakshmi GM Nursing of High-Tech City. So, yeah, so you have elaborated very well. Yes, of course, you have focused on budgeting, and yes, of course, we always take high frequency, then high occupancy. When we come to the high occupancy, yes, budget numbers are approved, and again, COs also are sitting in the planning of budget, and they also giving the proposed occupancy. Yes, of course, everything is right. So what, as a leaders, what we have a challenges, we are not getting the experienced nurses. Though we have budgeted, we get only freshers. How are you dealing that kind of situation in your hospitals?
So this is going to be a perennial problem, and it is a, like Dr. Venkat was mentioning, it's a universal problem everywhere.
Yes,
that
yes.
all, even in Kerala, which is the largest producer of nurses, all of them go abroad to GCC or some other countries. So we also face the same situation as not having trained or experienced nurses staying very long with us. So we have, what we have done is we have a 3-tier system, or you can say 1/3, 1/3, 1/3 of it. So we try to have a 1/3 of nursing at a senior level by really paying them well. So there is even from the pay rank itself based on the number of years of seniority. So there are nurses, senior level nurses who take as high as a lakh. They're very senior level nurses. So we want that 1/3 layer to stay, because those are the people that hold on to your systems and cultures which you have put in place. So everybody just disappears. The years which you have spent, 2, 3 years or 4 years, 5 years, you have spent in putting that culture in your ICU, or it will just disappear. So you need to put in money, pay them well, so that at least 1/3 of your people are senior, and they are at a supervisory or a, what you call, do and show sort of people, who ensures that the efforts which you have put in developing that culture of safety or the infection prevention practices or other medication administration practices in ICU stays as it is. Okay. So then you will have a middle level who will not be that this thing, but they will definitely stay for about 3 to 5 years. And these are the people who act as, in our parlance, in our nursing, say they say buddy systems. Okay, so they act as guide and mentors to the trainees, or the new joinees, or just passed out people. So everywhere, even in my system, about 1/3 of them will be new people, and that attrition is also highest among those people because they get etc. The attrition is slightly lesser among the second band, and attrition is extremely less, or we try to do maximum to avoid attrition at the top 1/3. Right. So this is how we plan, and so that there is a constant supervision and training. So this training and supervision is not at the time of joining or what you call as induction. So unless you have, you assign these new people to these mentors or buddies who are held accountable for their practices, this junior 1/3 practice who come in and then go out, etc., then this cannot be implemented on the ground. So you need to have that middle level and senior level who effectively mentor these juniors and who are held accountable. So they are actually tied 1-to-1. So we know that this nurse is the buddy for this nurse, and hence the accountability and the practice measures and the outcomes of the patients, etc., are all matched. So some sort of an accountability is linked when it comes to performance. And as I told you, the top level, we really pay them well because they are those people who hold on to the whole culture in our ICU.
Thank you, Dr. Anup. Well explained.
Thank you. I think a lot of people have also faced the practical problem the same. A lot of people know about how to do follow about the catheter care bundle, central line, ventilator bundle. But at the bedside, we see that almost more than 50 to 70% of the things it is not followed. Anybody having the question? Any other suggestions from your side? Or anybody is facing the problem in daily practice? Please.
What are the ideal ratios for different categories of patients in ICU? Thank you very much for the very elaborative talk on nurse-patient ratio. Thank you.
Okay, so this classically it is based on acuity, and there are validated scores for acuity. Okay, so like TIS scores and all. So the one way is to be very objective and do the TIS scores. As I was saying, if you want to talk with the data in terms of this thing, we can do objectively, we can do TIS scores, have the acuity levels and match as per that. But obviously, as people who have been in this healthcare and in critical care for 15, 20, 25 years, we know that somebody with organ support system, be it a ventilator, be it multiple inotropes, etc., by default, whatever score you apply, they are going to be of high acuity. So you can just eyeball and understand the acuity. So with ventilatory support and inotropes, the 1:1, there are good trials, randomized and prospective trials that show that with high acuity, 1:1 ratio makes a difference in the infection outcomes, okay, or sepsis outcomes. So this is, so either you can do an objective scoring, like this scoring, and then decide which patients need this 1:1 ratio, which patient can do with 2:1 ratio, or you can just eyeball and look at who all are on organ support systems, and at least those people we ensure that they receive 1:1.
Thank you so much. Thank you, Dr. Anup, for spending so much time with us. And
thank you, Anup, for that wonderful even interaction. It was a privilege and honor for us to host you and make you available. Thank you for being there with us. Thank you.
Thank you. Thank you.
for everybody else, we'll break for a short break for a tea for 15 minutes, and we'll all be back at 11:30 for inauguration.
And I think the most important part, we actually wanted these 3 or 4 theoretical lectures just to begin the concept of infection control practices in ICU. But the real game comes when you don't want to listen to any lectures. It will be on the bedside, how your ICO, ICN, your critical care doctor, critical care nurses do it in the bedside. And we put a lot of efforts to create the direct live rounds that each patient bedside on a different spectrum, from an extracorporeal membrane oxygenation to a ventilator patient, to a patient who is on a CRRT, to a patient with a trauma, to a burns. So a spectrum of cases will be there where the challenges will be handled by our ICO, will be live telecasted to you. And then we will have a sessions on a different areas. So we will join here in a quick session of 10 minutes so that we will actually continue to follow those rounds and followed by workstations here. Please join us in 10 minutes. Aditya, you
వినిపిస్తుందా? ఒకసారి మేడం మేడం మాట్లాడు, ఒకసారి మాట్లాడు.
ఎస్ సార్, క్లియర్ సార్.
క్లియర్ ఉందా?
ఎస్ సార్, క్లియర్.
మొత్తం లోపల చూడండి మేడం, లోపల దాకా వస్తుందా?
హలో.
వాయిస్ ఎట్లుంది? ఒక్క నిమిషం మేడం.
సార్ ఇది స్ట్రీమింగ్ వెళ్తుంది.
ఇది కూడా ఒకసారి చెక్ చేద్దాం.
ఒక్క నిమిషము. ఇది ఆడియో టెస్ట్ అవుతుందా? ఇప్పుడు వినిపిస్తుందా? వినిపిస్తుందిగా? రైట్ క్లోజ్.
A very good morning to all. On behalf of the organizing committee, it is my pleasure to extend a very warm welcome to all our delegates and our chief guests for the day, Dr. Pavan Gorukanti sir, Director, Yashoda Hospital, Dr. Sunil Bidayat sir, Unit Head, Yashoda Hospital, High-Tech City, to this inaugural function of the G-SPARC Pre-Conference Workshop on ICU infection control practices in ICU. We have had a great learning session this morning, and now I request Dr. Venkatraman Kola sir, Clinical Director, Critical Care Medicine, Yashoda Hospital, to deliver the welcome address.
Good morning and welcome you all to this session of infection control practices in ICU. We all understand that infection control practices are one of the cornerstone of any quality projects or a quality delivery of healthcare in any hospital. As our director, Dr. Pavan Goruganti, was telling on my way back to this auditorium that how many of us take a keen interest and enthusiasm in doing it. Yes, it is not one of those which has the flamboyant color to it, but it is one of the core pillar stone of actually to turning our patients back to a healthy state. They came to us with trust, so we send them back with the same trust without actually adding any new infection to them. This all program started with the G-SPARC, which is the Global South program or a conference for this infection control prevention conference, which is going to be act on the first week of October. So as a support to that and as a participant to that, almost 30 to 40 hospitals in this country have done a program, a pre-conference workshop in different categories, and we today have done infection control practices in ICU as one of the program for us. And for that, I think as an organization, Yashoda Hospitals, the young dynamic director, Dr. Pavan Goruganti, and all the other the founders and directors of this hospital, administrators, and our infection control team has put a lot of hard work over the last 2 weeks at least, from the live telecasting systems to the videos which has been created, and all our ICNs who actually put across their hard work in bringing this. Today, we will have a sessions which already happened, are a theoretical session followed by a practical and probably ward round sessions in the second half of this. And on this opportunity, I invite all of you and welcome you on this occasion, and I request our director, Dr. Pavan Goruganti, who has been not just an administrator and director of this hospital, but a clinician like all of us during his period, graduated from Usmania Medical College, postgraduated from Manipal Medical College, and went on to do his both critical care and pulmonary fellowship from the United States of America, and came back after his 6 years of extensive post-graduation experience. We all know the critical care being a 3 years program in India, but they're putting together, it was a 6 years program, and he carries a rich experience and a facet of how the infection control madness in United States and the infection rates being a madness there. To be very honest, he has been a part of the quality indicators in our ICUs. Many of our ICNs, ICOs and ID physicians here from Yashoda group of organization, we were trying to create every infection in our hospital to be presented and to be done a root cause analysis, not at the end of the month, but dynamically on the same day when it has been detected. And to that, we wanted a kind of a dashboard saying our hospital, we see this more of an Western pattern. What is our high rate? What will be our CRBSI rate? What will be our COTI rate? What will be our VAP rate every month on and on? And this was a kind of a challenge thrown to the team of infection control and the hospital, Yashoda, to bring it, and this has been a challenge given by Dr. Pavan Goruganti to us. So we all take the challenge, and hats off to all of you because of your confidence from the team HIPC. He has taken that initiative to actually put it onto a dashboard. With this kind introduction, I request Dr. Pavan Goruganti and all our faculty to be on dais to actually start this program with an lamp lighting ceremony. please all the faculty to join. She can be here, there. You want to. And our GM Nursing, Saujanya Madam, Vimla Madam, all can join, who was the senior leaders in the nursing department too, all the faculty. Sutapa ma'am. On this occasion, I request our director, Dr. Pawan Goriganti sir, to give a message to all of us on this occasion. So over you.
Thanks, Venkat, and thanks for the kind introduction. Yes, it is true that I did spend 20 years of my time doing MBBS in Osmania and then general medicine in Manipal/Bangalore, KMC, and then I was in the US internal medicine residency in Michigan State, Lansing, and then I was doing pulmonary critical care fellowship in Maimonides, New York. And after that, after my 20 years of study, I was practicing only 1 year in Upper Peninsula of Michigan, Marquette, Michigan. So it was 1 week on, 1 week off, and 1 month vacation. So effectively working 5 months a year. And just when I was having a good time, I was asked to come back here. So back in Yashoda since 5 years. So I do have some experience of how ICU is managed and what kind of medications were given. Like in Osmania and all, I remember at that time it was crystalline penicillin and ampicillin and those kind of things. Actually, those are one of the very good drugs, I think. Maybe you are forgetting now. I think hardly anybody has given crystalline penicillin, maybe, but I think because now everybody is giving meropenem and imipenem directly when they came in. So I think those kind of medications we forgot in the past, like chloramphenicol and this gentamicin and all that is very good medications in the armamentarium. Because in Manipal, I remember in North Kerala and all, they used to, at that time only they used to give imipenem and all, but the patient ended up in ICU in Manipal. Professor used to say, no, we'll stop everything and then we'll start with crystalline penicillin. Most of the time it worked though. So I think those kind of things we should not forget, because now with so much antimicrobial resistance and all, we need to try all combinations, and particularly in India, because cost is also involved. Different kind of things is required. So like I'm sure you are having high quality sessions today. Oh, this audience looks a little unusual. It's more than 90% looks like ladies here, so good. So I think I heard that you are dominating every field, but this 90% seems a little too much. So I think maybe critical care jobs we have to be sure that yeah, a few of in the minorities. So I think we'll we'll talk more for the ladies today. So, but yes, coming to the topic of interest, I think you'll have multiple sessions in multiple hospitals, I think. So Venkat was saying here it is mostly infection control in the ICU, pretty much. As you know, ICU is the sickest part. Most patients will end up in the ICU. I used to say in US and all, either the patient, because our ICU was in the 10th floor, either the patient used to go down if they get better, or they go up, because 10th floor is the maximum. So in ICU it was, so anyhow, any sick patient used to end up there, and everybody finally, septic shock, I always used to write it in critical care billing and all US, because I was absolutely sure something or the other will happen and the patient will end up in septic shock. So one of my diagnoses was already there for majority of the patients, and it qualifies for critical care time in US, and also septic shock was one of the most common things in ICU, and almost everybody has that, and most of the mortality, as you know, is due to the still infection control. Maybe we'll say that it's kind of like controlled after development of antibiotics and antivirals and all, but you know, in the ICU, like if you see every second patient, cause of death will be due to like septic shock in some form, I think. So I think this is extremely important thing, and we can make a real difference for the patient in ICU is how you, like, because after the infection is fully established, not much can be done, I think, despite everything we have, including ECMOs and all. So this month also probably we did some 20 ECMOs, I think, between the group. This month, it is not even COVID wave. But so even with all those experience and lung transplants and everything also, I'm telling is still, because if we can control the infection in the beginning stages, this will make the biggest difference in patient lives. And so we have to put all of our efforts in that. We are trying our best to in the hospital. If you look around this hospital, all of the ICU beds are like single room ICUs. There is no curtains and those kind of things. So chance of spread is very less. Everything from washing hands and the basics to you'll not believe, when I know central lines and all, I'm sure maybe discussed or maybe discussing in US and all, I'll tell some examples. So because in Michigan and all, I was in some ICUs in US, it was kind of like our general ICUs in India. But after I went to New York, I realized that there are a few things they are doing different in ICU. So no patient was on any sedatives or pain medication for the matter, including intubated patients. It was most of the high acuity ICU, so most patients were intubated and all, but nobody was on no propofol drip, no midazolam, nothing was there. So I was thinking, oh, patient may be in pain or something and all. We automatically used to start drips and all. No, I think we can do it without any drips also. 90% of the patients did not have any drip, and pain also, okay, only if the patient complains of pain, we were allowed to give. Even on a ventilator also, they had to ask for, okay, I want morphine or Dilaudid or whatever. So it was given. So most of the patients were awake and doing their things. And in US, this 30-day mortality, and particularly COTI and CLABSI is taken very seriously. So it was like central line. Sometimes if it was put down in the ER, my professor used to ask me, oh, might have been done in unsterile circumstances. Why don't you change the central line? It was just put like half an hour ago, but we had to change central lines many times, and every day we used to be like, does this patient need to be on central line? It was put exactly 2 hours ago. No, does the patient need to be on central line? Can we take it out? Can we take it out? Can we take it out? So it began, nobody had central line more than 5 days or something. And even if there was a port or a chemo port kind of thing inserted by some surgeon, even then patient had fever. Just put yesterday also, please remove. Surgeon refused, no problem. Call intervention radiologist, somebody, and remove it. So it was like that. And urine also, like none of the patients had Foleys there. 0 patient had Foleys. Urine output, is it really important? The professor was asking, like for many patients, maybe it is not that important. We can follow the urea and creatinine and all. But among all the ICUs in US, Maimonides ICU probably will be in the top 0.01 percentile, because we had no urine infection, almost no central line infection too, because it was done that way. So I'm not advising everything like that here, but there is room to do like any kind of lines and any kind of things, as you know, will be a nidus to spread infections and all. And nowadays, I think gut bacteria is also important. Maybe you should know a little bit about the functional medicine, what kind of microbe is in the gut, C. diff infection, whether we should treat only with antibiotics or should we change the gut microbacteria. So C. diff, fecal transplantation, I was thinking, wow, is it really something like that is happening? But yeah, maybe those kind of things may prevent infections too in the future. So like there is a combination of things, starting with the basics like washing hands and all, and making sure that our dress also in the ICU and all. Even in US also, the same scrubs, people used to walk in the subways in New York and all, like metro stations, and come to the ICU and all. So one day it came in Wall Street Journal also. It seems awkward that these doctors and nurses are walking out and coming to the ICU, and also we can make changes there from there to like the more complicated things, like maybe changing gut bacteria, kind of nutrition also. TPN, if you look 20 years back, everybody was advised TPN, nutrition. So, probably I learned it from there also. In our ICU, standard was used to give only like very little, just to stimulate the gut, like 10 ml kind of thing, nutrition wise, and that too even with lactate of 10 also we used to give, or like initially like 300-400 calories is sufficient, I think, for most people for 1 or 2 weeks at least, because nobody died less than on a 0-calorie diet also, less than 40 days. I don't think there is a recorded literature of anybody dying because of lack of nutrition. So I think all of those things, like in COVID, I remember many people were thinking immune booster diet, and they were eating all the cashews and all these kind of things. That is not exactly immune booster. That is actually causing more diabetes and more prone to COVID, and also like controlling diabetes and comorbidities and everything else is important. In small words, like everything in medicine you have to do, I think, to prevent infection. So I think that's great that we have a multidisciplinary team here, because one person cannot do, only doctor or only nurses or only ID or only microbiologists cannot do. So it needs a combination, multi-pronged effort, because everybody has to die at some time, and most patients die in the ICU with septic shock, and any small difference will make a big difference. And thanks, Venkat, for like accepting a challenge. So maybe we will beat Maimonides Hospital. Let us see. By not nationally, we are competing internationally. Maimonides Hospital in Brooklyn. So we can have a friendly competition, as I'm the alma mater from there, and hospital is ours, so we can have a international competition. This seems good. So sorry for taking too much of your time. I thought infection control will be not so, like maybe it is not like ECMOs or lung transplants or these kind of things, but all of you seem very interested and all. So unless somebody takes, I'll keep talking for the entire day. So just kidding. So we'll take over, Venkat.
Sir,
Thanks.
We will take your privilege presence here, and we'll honor our all faculty who came all the way and shared their knowledge and experience. We'll start with Dr. Jaya Banerjee ma'am, who actually take, yeah. So, she wants to come up. Okay, give her a big hand of applause. I request all the moderators, Dr. Madhusudan Jaju, Dr. Kaladar, Dr. Sasidhar Pulgam, Dr. Aditya, Dr. Gautam. So please stay back on the dais. I request all the speakers, Dr. Karthik, Dr. Monalisa Sao, Dr. Swati, Dr. Sweta, Dr. Sutapa. I think Dr. Akshiti is presenting, preparing herself for the this coming. So a big round of applause to Dr. Vinod Sekar, who came all the way from Delhi to actually support the air handling system. He will be demonstrating live on air handling system. So Dr. Jaya will take a memento here in front of. Okay, all of you can join in the front for the. All of you can join in the front. Memento. We actually wanted appreciation to the admin also, to Dr. Sunil Bidayat sir, on behalf of all the administration of this hospital, in providing you all the facilities which we got. Dr. Lohia, Venkatesh, Pradeep, please. Saujanya madam, Dr. Saujanya. Ma'am, we missed Dr. Saujanya, please do come. Thank you, Pawan sir. Thank you, Sunil Bidayat sir. And thank you all the dignitaries on DICE. We will move on to the scientific program to go on. So Tapa ma'am, over to you. So to actually take the next session on, I invite Dr. Saujanya, who heads the Department of Emergency Medicine in Yashoda Hospital, High-Tech City. I request Dr. Sasidhar Pulgam, who is a senior consultant in the Department of Critical Care Medicine, Yashoda Hospitals, Secunderabad. And I request Dr. Aditya G, who is a senior consultant in the Department of Critical Care Medicine in Malakpet. Now I request Dr. Karthik Vedula, who is a consultant in the Department of Infectious Disease, which has been a core specialty for all of us in this discussion. It is over to you, Dr. Saujanya ma'am, to introduce to Dr. Karthik.
Morning all. It's a privilege for me to introduce Dr. Karthik Vedula, a consultant for infectious diseases at Yashoda Hospitals, High-Tech City. And he's an organizing member for SITSCON 2024. And he has done an extensive work in the infectious diseases spectrum. And he is one person we go to for all the chronic infections and troublesome infections, both from ER and ICU. Over to you, Dr. Karthik.
So thank you for the kind words. Hope I'm audible. Yeah. So my topic is active versus passive surveillance of hospital-acquired infections in the ICU. So let's continue. So as we all know, hospital-acquired infection is acquired by the patients while receiving care in the hospital, and is one of the most frequent adverse events of hospitalization. And hospital-acquired infection is a complex and difficult to solve problem. Even the most developed industrialized countries also have issues tackling it. And the surveillance of hospital-acquired infection is complex, requires expertise and diagnostic facilities to conduct it. Briefly about the prevalence of hospital infections. In the high-income countries, it is about 7.6% prevalence, whereas in the low and middle-income countries, the prevalence of high is around 10%. And in the ICU specifically, it is about 17 per 1,000 patient days, whereas in the low and middle-income countries, it is almost double, about 42 per 1,000 patient days. This is according to the WHO report. And coming to the catheter-related bloodstream infections, it is about 12 per 1,000 device days, and catheter-related UTI is about 8.8 per 1,000 device days, and for VAP it is about 24 per 1,000 ventilator days in the low and middle income group countries. So this is about international. Now coming to India, as previously also discussed by Dr. Mona Lisa, this is was published in Lancet. It included about 89 ICUs throughout India, and they found that the pooled bloodstream infection was highest in the neonatal ICU, about 21 per 1,000 patient days, followed by the surgical and medical ICU, whereas the pooled CLABSI rate was highest again in the neonatal ICU, about 34 per 1,000 central line days, followed by the surgical and medical ICUs. And the pooled CORTI rate was about 4.5 per 1,000 catheter days in the pediatric ICU. So we know that there is a big concern of this high. So coming to the surveillance, hospital-acquired infections are those acquired during the process of receiving care in the hospital, and it is not present at or during or incubating at the time of patient's admission. It is usually take the infection to occur when it is more than on the third or calendar day or later. And the surveillance is the ongoing systematic collection, analysis, interpretation, and evaluation of health data, and the timely dissemination of this data to the appropriate stakeholders to monitor and prevent infections. So conducting surveillance allows us to determine the baseline hospital-acquired infection rates, and it allows us to monitor the trends of infection rates and identify outbreaks early. And it also allows us to evaluate the effectiveness of the infection control measures, and accordingly tailor recommendations in the high-risk areas, or whatever infections are higher in that institute, we can tailor recommendations to prevent those infections. And it majorly provides the data from benchmarking, which allows us to compare our performance, the quality of care throughout over time, and also with other institutes, so that we can improve our hospitals' performance and reduce the risk of adverse events. So the rationale of surveillance is, as we know, it reduces the hospital infection rates, and it has been showed that the reductions range from 70 to 60%, which is significant. And it is conducted by the surveillance team, which has to be motivated and multidisciplinary team consisting of a microbiologist, a lead nurse with clinical experience, and IPC linked nurses. They are the ones who are responsible for the data collection, analysis, interpretation, and the dissemination of these findings to the appropriate stakeholders. So basically a surveillance consists of a few steps. The first step is surveillance planning. Here we had to assess the population to be surveyed. We had to take into account the number of ICU beds, the total number of hospital beds, HDUs, transplant units, and then we had to select appropriate outcomes for surveillance based on the feasibility. And we always have to use standardized case definitions for infections, because otherwise it may lead to underreporting and misreporting of the hospital-acquired infections, and it also and it will introduce bias in when comparing the rates of infection between the hospitals. So once we have done the planning, then we do the collect the surveillance data, which is done by active and passive means. We'll come to it later. So after the data is collected, we'll analyze the infection rates and identify the high-risk areas, and we then communicate to the appropriate physicians or the surgeons or the ICU staff, so that they are made aware of the infection-related problem, and increase the awareness and promote the infection control measures and increase the compliance to the infection control measures. And finally, we have to always evaluate our surveillance system so that we identify any weakness and increase the efficiency and effectiveness of the program. So coming to the first step, as we said, we assess the population and select the outcomes, and we have to use standard case definitions. Here the surveillance outcomes includes the device infection rates and the bug infection rates, like MRSA, VRE, C. diff infection, hospital mortality, and hospital length of stay. So we have to choose the outcomes wisely as per the resource availability and feasibility. So basically, the more smarter we are in choosing the outcomes, we can maximize the effectiveness of the surveillance program in terms of better outcomes, like a reduced infection rates, and at the same time reduce spending on the of the resources. It will be cost effective for the hospital also. So briefly coming to the definitions. So ventilator associated event is a surveillance definition updated in 2013. It is a surveillance definition basically, and is not a clinical definition and not to be used for clinical management of patients. So briefly, a VA is said to be occur when a patient has stable or improving ventilator requirements for 2 days, and then after a period of stability, there is an increase in the daily FiO2 or daily PEEP levels for sustained for 2 days. Then he's said to have a ventilator associated condition, and if this patient has a fever or hypothermia or leukocytosis, then And along with that, if a new antibiotic is added, which for more than 4 days, then he's said to have an infection-related ventilator-associated condition. So, if this patient has a lab-confirmed infection, which is the criteria given by the CDC, either the pollen secretion not meeting the semi-quantitative or quantitative thresholds for the positive culture, or positive cultures meeting the quantitative semi-quantitative threshold, they are said to have this VAP. And also, if culture is positive from pleural fluid or any non-culture based test, they are said to have possible VAP. Coming to CLABSI, it is a lab confirmation of bloodstream infection where an eligible organism is identified and a central line is placed for more than 2 days on the date of event. An eligible bloodstream organism is given, should follow this criteria. Basically, a pathogen should be isolated in blood culture, and the organism should not be related to an infection elsewhere. And if a commensal is grown, they should have 2 positive blood cultures along with fever, chills, or hypotension. For COTI, it's a catheter-associated UTI. The patient must have a catheter in place for more than 2 days and should have either fever, subarachnoid tenderness, or severe tenderness, urgency, frequency, or dysuria, and a significant positive urine culture. For the surgical site infection, for superficial surgical site infection, the infection must occur within 30 days of the surgery, and it only involves the skin and subcutaneous tissue. And the patient should have either purulent discharge from the incision site, or culture is positive from a aseptically obtained specimen, and or if the patient undergoes debridement or the wound is open along with this local symptoms of pain, tenderness, swelling, or erythema. Okay, so then they said to have superficial site. For deep incision surgical site infection, the criteria is the same, but they should have abscess, or they should have deeper soft tissue involvement of the fascia and muscle areas. So now coming to the collection of the surveillance data, it is basically 2 modes, passive and active. In passive surveillance, the data is generated from routine patient records or reported from healthcare providers without the intervention of the surveillance team. It relies on reporting of the hospital-acquired infection by the clinical staff or the healthcare workers, and the data is not actively solicited. It is less demanding and cheaper than active surveillance, but it comes at the cost of low sensitivity. It basically follows the iceberg phenomena, where only the tip of the burden of the infections will be captured, and there will be underreporting of the infections, because primarily we rely on the information provided from the clinical staff whose primary role is the patient care, and they may not be familiar with the surveillance definitions, or they may be busy and not have time for this work. And so the quality of data is not high, but it may be the only feasible method in settings lacking expertise or resources. Now coming to active surveillance, it is the direct and vigorous search for information on the occurrence of hospital-acquired infections. Here the trained personnel actively search for new infections on a regular basis on the clinical rounds and audits. They look for the evidence to meet the surveillance definition of hospital-acquired infections. Here they do bedside rounds and review the clinical signs, the symptoms, patient notes, and lab data like CRP, TLC, and procalcitonin and microbial culture data to assess, identify, and report the hospital-acquired infection. Here it requires a high level of effort and a lot of resources are required, but it is the most sensitive and effective method of surveillance. So as I said previously, it is the burden of high is like an iceberg. If we see from a ship, we can only see the tip of the infection, but if we dive deeper into the problem and we look actively for infections, we can see a bigger magnitude of the problem. And the more amount of resources are spent and effort is put, the more infections we can detect. The sensitivity increases. So active surveillance is prospective because continuous collection of data is done on real-time basis, and as and when they occur, we'll know. And we can also target the surveillance to focus on high-risk areas like ICUs or transplant units for more efficient use of hospital resources. It may require the use of, we can use the use of electronic health records where automated alert systems can be automated because large volumes of data will be analyzed and they can provide timely alerts to the clinical staff to take appropriate intervention. And microbiological surveillance includes collecting and analyzing the microbiological samples from patients to detect and monitor infections, and also to conduct the MRSA or VRE surveillance, right? And infection control rounds, this is the most important part where the ICNs or the surveillance team members do regular every bed rounds in the ICU to observe the practices and review infection control measures and give feedback on the occurrence of any flaws in the or lack of compliance to the infection control measures. And also they will tell them about the magnitude of the problem so that the physicians are aware of the issues, and they take proactive steps to increase the adherence to the compliance to infection control measures. So in a nutshell, the difference between active and passive surveillance is that in active active surveillance there is more complete reporting and more timely and accurate information is gathered, and it is more representative of the problem, there's high quality data. It allows for better comparison of the infection rates between hospitals, whereas passive surveillance is less resource intensive and underreporting is more common. But it is simpler and inexpensive. So after we do the data collection, we mainly collect the numerator data and denominator data. The numerator data is the number of hospital-acquired infections identified through active surveillance, like the CLABSI, COTI, VAP, and SSI rate infections, and the number of infections identified by lab, like the C. diff, MDRO organisms, MRSA, or VRE. Now, denominator data is very important because that will, that will make an, it's okay. So that will, if you don't capture that properly, it will grossly underestimate our disease problem. Because if you take less number of patients, your infection rate automatically go up. So we had to take into account the number of patients at risk of acquiring hospital-acquired infections or the number of procedures at risk. And for device-associated high, we obtained the number of device days. So basically in the analysis we do the VAP, CLABSI device rates. We calculate per 1,000 device days, either ventilator days or central line days or catheter days. And for surgical site infections, we do it based on the per 100, well you say it as a percentage. And for the bug infection days, we do it per 1,000 patient days. This data is again gathered by the patient days can be gathered from the hospital admin staff, because they'll keep track of the number of patient admissions and the number of days of admission. And the device infection days and the catheter days can be collected from the ward in charges, who will keep track of the device days. Right? So after analysis comes the calculation and the interpretation part. Once we identify what problems are more concerning to your institute, we have to address those problems, and we have to communicate to the ICU staff and the surgeons regarding the infection rates and the preparation of the antibiogram and everything along with the antimicrobial stewardship programs. We have to communicate this to the appropriate stakeholders and take appropriate interventions so that we can control the infection. And also again evaluation, as I said previously, we have to evaluate whether we are using standardized definitions or any weakness is there in the surveillance system, so that we can make it more effective and cost effective. So coming to the challenges, as previously discussed by Dr. Warrior sir also, he has discussed in detail. So data accuracy becomes a problem because data collection may be difficult because of improper or lack of documentation. Because on rounds, usually nursing staff or whoever does, they may find that the documentation is incomplete, so they'll be in a fix whether how to collect that data and whether to include the patient or not, right? And also some of the clinical assessment is subjective, so it needs trained personnel and expertise for conducting this thing. And resource limitation is always a problem because hospital will be they'll be difficult to open the budget, and technological integration may be required for the electronic health system. And timely detection and reporting which is not done, so we miss out on outbreak detection. And staff compliance is a big challenge because we need continuous training and monitoring and supervision. And because the ICU patients, as discussed previously, so they are like special case where a lot of comorbidities are there for infections and a lot of invasive devices are there. So conducting surveillance in this context is a bit difficult. So as we've seen, it has these implementation of the surveillance programs will result in decrease in the infections. So I did a literature review to study the cost effectiveness of the surveillance program. So there was a systematic review which evaluated the cost benefit of infection control interventions targeting the MRSA in hospitals. They found that the median save to cost ratio across all the studies was favorable, and higher save to cost ratios were observed in the hospitals where MRSA was intermediate to high compared to the low MRSA prevalence. Another systematic review evaluated the economic evaluation of VRE control practices. But this study had a lot of low quality studies, and there was high heterogeneity of the data. So they could not actually make a definitive conclusion whether VRE control measures were effective or not. But most of the studies show that some VRE screening and use of contact precaution is cost effective. So briefly about AI, because AI is like now everywhere. It has pervaded everywhere, and now in future also it can come into the hospital surveillance system. Study was conducted in Brazil. They studied the hospital acquired infection surveillance using different AI algorithms. They found that overall the accuracy using one algorithm was about 80%, with the sensitivity of 88 to 78%, whereas for VAP it was more sensitive, about 90% accuracy and 95 to 90% sensitivity and specificity. So advantages of AI is, again, it saves time, frees up manpower resource, and the measurement is objective, and there's improved accuracy and interfacility comparison. But again, disadvantage is it requires compliance to the electronic health records, and doctors may not be compliant to the electronic health records, and it increases the IT cost. And some of the high elements like SSIs have limited automation potential, and the definitions also keep changing over time, so it requires manual updating and supervision. So these are the advantages and disadvantages of AI in hospital service. So thank you. So any questions?
One more thing which I wanted to ask. Actually, majority of times we will go by definitions. So, but if we go by the definitions, our numbers will be very low, even if we go by active surveillance also. So, because majority of times we have to have a culture positivity, that is one thing, and clinical signs and symptoms. But if we see practically, our patients, more patients will be, antimicrobials will be escalated after 3 or 4 days of ICU admission. Which major chunk we will be missing in this, even in the active surveillance system also. What is your opinion?
So that's what I said. All these VA, these are like surveillance definition, and we have to stick at the start of the program only. We have to fix the definition. You have to stick to it. Otherwise, there'll be like variations in comparison. Like with ourselves also, if we compare over time, if we keep changing the definitions, the obviously the events captured will be less or like different. So we have to stick to like international standardized definition, and even if it's low, whatever, we have to basically look at who is collecting data and whether they're trained or they have the expertise, because we usually delegate it to the nursing staff or like ICU and healthcare, the infection control team. So we need to ensure that they are trained, they are aware of these definitions, and then whatever data we get, we have to look at it. So
my opinion, actually, what I feel is even antimicrobial usage also should be taken into the consideration, because majority of times we will escalate and that won't be counted as an infection in the ICU. That usually in our HIPC meeting, majority of times Venkat sir and our people, we all ask the ICNs to look into that data also. So considering some infection, we will escalate the antibiotic, but actually numbers wise, if we see, our high rates will be always low, but all clinicians and intensivists all are worried about infection related mortality. So that is one thing which is maybe globally that should be incorporated into the surveillance system.
So I agree, sir. But again, this is again a surveillance definition. What we do for like surveillance and what we do clinically may be different, will be different. But for surveillance purpose, we have to have a like a universal like standard definition, and even if it is less, whatever, we go with it.
If any questions or comments from the floor.
Or otherwise also to answer that, we can frame or we can study and look at review literature and we can make our own definition. But then again, if there'll be bias in comparison, because if we as a group of hospitals, you may make a definition, you stick to that, you can compare within yourself and over time you can compare the what is the rate. But the problem comes is when you want to compare with other hospitals. That is what benchmarking is. So within ourselves, we will be that'll be good. But when we go outside to compare, then we cannot. Like comparing apples and oranges, so it's not comparable.
Actually, this discussion actually comes from the point that if you look at any of our hospitals, if you look at as a Yashoda as an organization, or in that say any of your hospitals, when your HIPC meeting happens and your ICN or your ICO presents your data, the data looks like something like that: WAP 1 or 0, CRBSI 1, 2 or 0, and your COTI 2, 3 in a month, or sometimes SSI is 1 or 2 in a month, or otherwise 0. Okay, and that what does it mean? In the whole of the month, maybe 5,000 patients, 3,000 patients, 2,000 patients, whatever your admission patients are, only 2 or 3 patients got infection in your hospital. That is what your definition and criteria of your HIPC says. And that is the definition which Dr. Karthik is talking about. Across the globe, we have a uniform definition from CDC or either ASIA or whatever it is. And most of these definitions are based on the microbiological positive data. It is not even grams, and it is some bacteria or a virus that has to be grown up in a, even we don't take a PCRs or we don't take any molecular diagnostic test as a test. Okay, now coming back, if that is true, assuming our surveillance credibility is very good, we are sticking to the definition, look back at your antibiotic use. Every time we ask the same question in your HIPC meeting. How many of your patients after 48 hours of hospitalization, in the day 1, the patient gets antibiotic because the patient comes with an infection from outside. But after 48 hours of your hospitalization, how many of your patients in the ICU or in your hospital gets a high-end antibiotic? There are many. They are in hundreds. Then why are they getting antibiotics? There is some suspicion by either you or any of your clinical team members that they are having some or the other infection. But why are they not been counted? Because they are not fitting into the definition. Either none of them have grown anything, or much before the cultures antibiotic has been given or something. So we thought ki passive surveillance was the regular phenomenon which all of us do in as a part of your any program or any accreditation. Active surveillance should be a part of it. Again, the question which Dr. Sasidhar asked, even you do active surveillance and definition remains the same. That's what you are asking. Active surveillance, you may do active surveillance. What is active surveillance means? Dr. Karthik pointed out, active surveillance means you see and visit all the patients of your hospital, not those who are culture positive. Passive surveillance, what you do, you go to the microbiology department, see what are all the culture positive and how many of them have grown after 48 hours of hospitalization or a line or a tube, and which were normal before that. And you come back to the patient and check whether they are fitting or not. But in fact, in active surveillance, each patient in your ICU should be visited. And each patient should be evaluated after 48 hours if this patient has developed a new fever, new leukocyte count, a new antibiotic initiated, new organ failure like hypertension and all. And again the question, it can not only not happen with infection, it can happen with many other reasons. For example, what can be the other reason? It can be because of your some drugs which you are using. That can cause acute kidney injury, that can cause fever, that can cause phlebitis, that can cause right in TLC. So here is the difficulty. So to fit into a definition is a difficulty. But what we are doing in our institution right now, we are also asking our ICNs for the last 6 months to a year to capture all the new fever cases, all the new TLC rise, all the new hypertensions and all the new organ failures. Yes, many of them may not be because of infection, but we keep on tracking them. If you look at VAE definitions, ventilator associated event definition, it doesn't talk about cultures. The first one, it talks about a stability of PEEP and FiO2 of a 2 days, and then it drops. The PEEP requirement goes up, FiO2 requirement goes up. And that is a VAE or a event or a condition. Then the next step talks about if your patient requires an antibiotics and your clinician started saying antibiotics, you suspect an infection. That doesn't talk about any culture positivity. Only possible or probable VAPS talks about a culture positivity. That means in ventilated associated events, now we are talking about if a patient initiated on a new antibiotic or a revised antibiotic, you need to keep a watch on them. And that again adds to that. They talk about there is a rise in temperature, increase in secretions, rise in leukocyte count with a new antibiotic. That comes under a scanner. But that is not a VAP because you don't know for sure whether it is positive or negative. The last part comes as a possible and probable VAP. But this is only confined to VAP or a ventilated associated event. Does there any similar definition for COTI or CRBSI? No. Does there any similar kind of things for SSIs? No. So what do? We keep on monitoring all these patients who developed the new fever, keep on watching them what is happening, because many of them may be having infection. Because if you look at, if I have a patient with bacteremia, okay, I send cultures, only 40% or 30% will be positive. The rest 60% with a bacteremia cultures may be negative. The culture positivity rate is not 100%. It is probably 40 to 60% depending on how much amount of blood you send. If you send 10 ml, 20 ml, it is still below 20% or 30%. If you really send 60 ml, that is 3 sets, one Arabic, one anaerobic, and lime, similarly 3 sets, maybe your culture positivity will go up to maybe 60 or 70%. There also, you still have a lagging of 60% or a 40%. In the similar way, it happens to the VAP and also COTI. The reason is antimicrobial use. The patient must have been received a dose of antibiotic and all. In the future, I think to answer Sasi and Dr. Karthik's viewpoint, we need to actually do a clinical active surveillance, which we are already doing. Yes, we may not consider them as a case of HAI, but that should be a case under scanner or a suspected case like a VAE. And in future, we should have something like what we are talking about, a clinical context, a clinical sign like a new patch in the lung with a maybe multiplex PCR getting positive or a molecular diagnostic getting positive, or you are one of the markers getting positive, that giving a clue that these can be also considered a probable HAIs. If not confirmed, probable HAIs, and those should also be kept under the scanner. Because what we are now being complacent is our high rates are 0, our high rates are 1. Our high rates benchmark is much below the Mayo Clinics or universal global standards. So this is making us complacent, saying ki on paper you look very, very good. But unfortunately, what point Dr. Sasi is making is, if you really look at your antibiotic use, probably that should give you a benchmark that your infection rates are low or high. Suppose you take in this way, all the antibiotics which are initiated within the first 48 hours of patient's hospitalization should not be considered, because that is not for the hospital acquired, but after 48 hours, suppose your hospital is using per patient how many antibiotics? So many doses which we talk about. So that should be a kind of a reflection of your criteria. That's what he is talking about, that your patients are receiving so much of antibiotic, whereas it is not matching to your high. That means there is a gap. This need to be worked on. So I think we need to kept on thinking about that as a area to develop.
So Sasi sir, whatever you asked, that even if we are doing active surveillance, then also our rate is very low. So definitely we are going according to the definition, and we are doing in-plant surveillance, and whatever the rate comes, it's really very low, and we are giving to the in quality indicator and all that. But when really we are, many people do passive surveillance, but for us, we are doing, our institution is doing active surveillance. And whenever we are taking the SIRS, Venkat sir's parameters, all that leukocyte count, any changes in the X-ray, all those things, antibiotic usage, we are getting few of the infections. Those are really, it's not fitting into the criteria. We cannot give as a high, but we can say it's a really high. So those things we are particularly keeping separate, and we are discussing as a off-plan surveillance for better understanding for the clinicians and for ourselves where we are lacking behind. And we are discussing every month regarding these cases. These are called off-plan surveillance. We are not throwing into quality indicator because these are not fitting into the criteria. But active surveillance, we are getting few of the high, but few cases are patients are getting antibiotic because they have already started antibiotic and all that. So just to tell that.
So just another point I would like to add, what Skola sir said, like few cases, what we take as hospital infection from calendar day of admission. But here, being a referral center, tertiary center, we get from outside. So already he's having some catheter or Foley's. So that usually we miss out. So that we also we are missing out. So that is like secondary attribution. But we are not taking into account. So probably we have like paradoxically lower errors, lower rates. Okay.
Thank you so much, sir. We thank the moderators and Kola sir and Jaya ma'am for the insights. Thank you, sir, for the wonderful presentation. Now we shall be transported to our ICU for the live rounds that will be taken by our ICO, Dr. Akshit Timaya, and our critical care consultants and ICNs. It will be a live demo of the ICU rounds that will be projected here. We'll have a glimpse of the ICU rounds now.
Mic check.
Yeah.
Can they hear?
Yeah, ma'am, we can hear you, please.
Okay. Thank you, sir. Good morning, everybody, and welcome to the live rounds in the ICU. This exercise today is to show you how we do our regular rounds every day in the morning. So our regular round starts by our ICN, who starts at 8 o'clock in the morning. She comes, and depending upon how many patients are there and the traffic of patients we have or the inpatient admissions we have, she finishes her rounds around 2.5 hours, 3 hours she takes, and after that she gives me a call and I come for the rounds. So today we have Sister Pavitra who will join us for the morning rounds.
Good morning, ma'am.
Good morning, Pavitra. What is the census today?
Madam, total we have 16 cases, ma'am. In that 820, CVC 8, ma'am, and a total 16 patients having Foley's catheters.
Are all the patients stable?
Yes, ma'am.
Any sick cases require attention?
No, ma'am.
Who is joining us for the...
The Priyanka is there, ma'am. She is the in charge of ICU. Yeah, sure, ma'am.
Please call Priyanka.
Sure, ma'am. Priyanka, can you please come and join rounds?
Good afternoon, Priyanka. How are all the cases?
It's good, ma'am. Good.
Where do we start?
Here, ma'am.
Okay. Sister, can we have a minute?
Ma'am, she is a 61 years old female patient. Came with complaints of DCMP with severe LV dysfunction. She is a known case of CAD post PTCA case and LRTI, and we kept here for observation, ma'am.
She's on any devices?
Only a peripheral line cannula and Foley's catheter is there, ma'am.
We are not going to see the meatal care today, but we have to make sure that the meatal care is checked every day on your rounds. Who has given meatal care, Priyanka?
Ma'am, morning staff.
Morning staff? Have they given?
No, when I came morning rounds, staff was not given properly. Priyanka initiated them to clean properly.
Priyanka, that staff is busy with other patient. She'll come and she'll give it.
Okay.
No, but is the morning care given?
Yes.
It's given?
It's given.
How do you give it, Priyanka?
Ma'am, usually we are giving morning care during the bath time. So we are given morning through pubis emphasis and inner thigh with bath towel. And usually we are giving is normal saline and sterile gauze. If it is male patient means we are giving whole gland of the penis and initial part of the Foley's catheter. It is female patient means we are giving devia majora, devia minora and the initial of the part of the Foley's catheter.
One of the common observations we have seen is, though we ask them for a Foley's catheter care, most of the staff don't know how to give a Foley's catheter care. So it's important to ask them, how have you given the Foley's catheter care? So, and educate them on a day-to-day practice so that they also become familiar about Foley's catheter. If the patient is awake, then we can also go and ask the patients whether Foley's catheter care was given. We move to the next case.
Yes, ma'am. Your one more case is there. She's a 41 years female patient admitted here IC bleed with midline shift. Initially she got seizures, ma'am. Initially they went outside hospital, they stabilized, then they brought here further management, and day of admission 13 we done a craniotomy. So today post-op day 2, ma'am.
Post-op day 2? All right, so she's on ventilator.
Yes, ma'am.
What are the devices she's on?
So she is having a ET tube with a mechanical ventilator support, central line for multiple injections, arterial line for BP monitoring, Foley's catheter care, Foley's catheter for urine output, ma'am.
Okay, we'll start one by one.
Sure, ma'am.
We'll start with ventilator care. What is the head end elevation?
Ma'am, it was 15, ma'am.
Priyanka, any reason why it is at 15?
Actually, ma'am, patient BP are fluctuating. That's why we are keeping.
If the BP looks stabilized, can you just increase it?
Yes.
Priyanka?
Sure, ma'am.
Okay, stop. Let's see. There's no fluctuation. Okay, I think it is good.
Now 30 degree, ma'am.
Okay. Right. Was the oral care given?
Yes, ma'am.
Priyanka.
Oral care was given. Right. I think the guidelines have been changed, and in the morning, Dr. Kaladar also stressed that now the guidelines of 2022, which has come in 2023, says that oral care with chlorhexidine is not required. We can give it with normal saline. If the patient is with ET or TT, we can give with mechanical brushing with normal saline. In a patient like this, with the gauze piece and with normal saline, the sister will give the care. We also have the respiratory therapist over here. Hi, Sapta.
Hi, hello ma'am. Good morning.
Good morning.
Yeah.
Have you suctioning done?
Yeah, ma'am. We have done the suction in the morning. We have done it in the morning, suctioning. Yeah.
Okay. Any change in the secretions?
Yeah, ma'am. Today we have found that the secretions have become little thicker, and also like the quantity has increased than before, so it's slightly more.
Pavitra?
Yeah, ma'am.
Any ventilator increase in ventilator settings required?
No, ma'am.
Any fevers?
No,
Abdominal
ma'am.
increase in fevers?
No.
TLC counts, have you checked?
Yes, ma'am. It was normal.
It is normal. So, have the consultant finished their rounds?
Yeah, doctors have finished their rounds, and sir have asked for a ET culture to be sent, so we will be sending it now. ET culture
Okay, can you demonstrate it?
Yeah, sure, ma'am. I'll just take Priyanka's help for this.
I will be demonstrating how an ET culture is sent in a ventilated patient.
Yeah, so basically right now I've done a hand scrubbing. After that I have wore this sterile gloves. I've pre-oxygenated the patient with 100% FiO2 because we will be doing suctioning to take out the ET culture. So after that I've put this sterile this draw sheet, so that over this I'll be putting this mucus extractor through which we will be collecting the ET culture right now. And then so now slowly I'll be moving towards doing the culture.
Dr. Akshita, you can actually keep on talking when they are doing the procedure related to that.
Hello?
Can you hear me?
Yeah, we can hear you. Yeah, so the respiratory therapist over here is going to do is actually taking the sample for the ET culture.
So basically,
Sir, I
one
cannot
person.
see it.
Yeah, one person can actually is been using only sterile gloves and the whole sterile pack, not touching to the unsterile zones. And Priyanka, our in-charge nurse, is helping us touching the unsterile zone, so that the non-touch technique was going on, so that we can actually take a proper sample. Are you getting any secretions back if it is dry enough?
The secretions.
So basically, they are trying to demonstrate the mini ball technique, where sometimes you, in viral pneumonias, where you want a lower respiratory tract panel, or when the secretions are too dry, you are not able to pick up things. So they use a saline of 10 to 20 ml of saline, allow the ventilate for maybe a minute or so, and again aspirate back whatever sample is left behind. But yes, most importantly, 2 persons minimum. If you have one other third person like a respiratory therapist is fair enough, at least 2 persons, because 1 person should not be touching the unsterile zones and wearing a sterile glove. As you have seen, Sapta, the respiratory therapist, is handling the whole sterile portions, weared a sterile glove, handling the sterile catheter, and the catheter mount, the trapper, mucous trapper, where she is collecting the sample.
We're done with the procedure, so I'll be discarding the leftover things which is there right now.
Thank you, Sapta. Now we will go ahead and Sapta will also demonstrate to us how to check the cuff pressure in this patient. So when we're looking at a ventilator care preventive bundle, right, we are looking at certain parameters. One is head and elevation. We are looking at oral care. We are looking at oral care. We are looking at any increased secretions. So during the secretions, during the suctioning process. We're also looking at cuff pressure monitoring. Now Sapta will demonstrate that for us.
So we generally will be monitoring the cuff pressures every day. So we need to keep that cuff pressure at the optimum level. Generally, the cuff pressures of a patient on tracheostomy or ET tube, it has to be 25 to 30 centimeters of water, which ideally has to be always maintained. So right now, I'll just check the cuff pressure of the patient. This is the cuff pressure manometer, so through which we do the checking. So yeah. So yeah, this is at 30. So right now it is fine. So yeah. So we will maintain.
So why do we actually monitor the cuff pressure manometer, and every time you check that it should be maintained? It should be maintained?
Yeah, it has to be maintained, sir, because to prevent any kind of aspiration, so we have to.
Just a minute, Sapta. We will just take questions.
Yeah.
Why do we need to monitor that cuff pressure of an endotracheal tube? Yes. You can be louder there.
Yeah, so we have to maintain the like.
Sapta, wait for a minute. Okay, we are taking audience question now.
Sure.
What will happen if my cuff pressure are a little higher? So what is the cuff pressure I need? Why 25? Why not 40? Why not 10? Why 25 will not injure? Why 30 will injure? So just imagine the endotracheal tube has a size which only caters 50 to 60% of your trachea. The rest is open. Okay? So you need a seal for that rest of the space to avoid a microaspirate, which happens on the side of your endotracheal tube, which is still open. Okay? For that, we use a cuff, which we inflate to seal that area. Then what happens? Secretions get deposited above that cuff. Okay? Now, we need to maintain that cuff pressure in such a way that it adequately seals, doesn't harm, and it is also been make sure that the seal is adequate, that nothing goes down. And that is somewhere between 25 to 30. The reason is your capillary pressures of your mucous membrane of your trachea is somewhere 25. If you use a pressure higher than that, your capillaries are getting into pressure to an extent that there will be no perfusion to the mucous membrane of your trachea. So that causes the mucosal death, denudation, strictures, stenosis, and all that. So to avoid that, you maintain a pressure which is adequate enough to seal it appropriately, doesn't damage the mucous membranal capillary pressure. Okay, that's the reason. And there is a very interesting thing which she was demonstrating. When she was demonstrating, she was trying to link the cuff pressure pilot balloon with the manometer. Okay, very, very common. We actually do it to prevent aspiration. A junior nurse who joined, if she doesn't know and by a quick rush presses the release button, if it is little higher, it grows to 0. So every 8 hourly, instead of you checking it appropriateness to maintain at 25, you actually create a microaspirate by deflating it. Are you getting my point? So you need to be very, very careful when your junior nurse is handling. Tell them, be confident. You connect. Don't release any pressure. If it is high, slowly release that pressure to extend that 30. Most of the times when I go back to my ICU rounds, if an intubated patient has been shifted from ER or from one bed to the other or intubated a half an hour back, I see the cuff pressure of my pilot balloon of the endotracheal tube looks like somebody puffed up at 200 kilograms. It will be full. When I check the pressure, it will be more than 200. What is the problem there? It will cause harm. You see those patients come back to us after 3 months with a tracheal stenosis, subglottic stenosis. So you need to take care of that. Over to you, Sapta.
I think we are done with. Okay. Now, thank you, Dr. Kola. The patient is on central line for how many days?
Demonstrate the subglottic suctioning.
So we can't show that.
Yeah, okay, we keep going.
Yeah. So the patient is on central line. Just focus on the central line. Whenever the patient is on central line, it's very important to focus on the site of insertion, because you have to look at whether there is redness, how the site of insertion is, whether there is erythema, any ooze at that site. Because when there is a ooze at that site, if there is the site is wet or it is not clean, the area is not clean, we expect the dressing to be changed and care to be given for these patients. When was the culture sent? Culture was sent?
No, ma'am.
Cultures were not sent. Okay, fine. Is it done outside?
Yes, ma'am.
It's done outside. Okay. It looks clean. The site of insertion, if you see, it is clean, it's visible, and this is exactly how we see the line to be.
Can we actually change the Riles tube position to the other side so that we can see very clearly the insertion site and the dressing?
Okay, sir. The Riles tube is...
Can be shifted to the other side,
Yeah,
opposite side. Just change the Riles tube now from the same vision. Position of the Riles tube to the other side, other left side. Put just. Yeah.
He can't see.
Yeah.
Okay. Don't block.
Yeah. So or you can put a little down so that we can see that. Yeah. Yeah, we are clear. So you can just make the points which a ICN or ICO should be checking in this position.
So can you see it?
Yeah, perfectly. Yeah, ma'am, go ahead.
Yeah, so we've finished the ventilator care. We've also seen the area of central line insertion. Now we will be going to another patient. Any other patient which requires attention?
Yes, ma'am. Here we have one ECMO case, POD 12, ma'am.
All right. Is Dr. Ravi available?
No, ma'am. He is in another procedure. Now we will see for surface cleaning,
Okay.
ma'am.
So we have another very interesting case to show all of you. Before we go to that case, since the Dr. Ravi is a little busy with another case, we will discuss about surface cleaning. Can we have the housekeeping person?
Yeah, ma'am.
For the cleaning?
Gagan, he is the housekeeping supervisor, ma'am. No, we will
Kaise hai
call.
Gagan ji? Aa jaiye. Namaste. So I think morning there was a question about how do we clean the surfaces, what is the frequency of cleaning, how do we monitor the cleaning. I think this is a common question which all of us have, that how do we monitor the cleaning. One is visual inspection. You can, very easy, you can see around the surface and see whether it is clean or not. Can I have the tissue paper?
Yeah, ma'am.
So other very easy technique is with the tissue paper. Hold the tissue paper in your hands when you're going around, swipe around and see whether there is any dust. Visually you can see that there is a dust or not and give the feedback then and there. We have few exercises what can be done to see this monitoring. It is an exercise purpose for education of the staff, especially the housekeeping staff, where we say that when you look, you understand better. So we have something called a glow gel exercise. Glow gel is a fluorescent dye which can be applied to the high set points. So we do this exercise very regularly as a teaching process for our housekeeping staff. So in this exercise, a fluorescent dye is put on high touch points. The housekeeping staff are not involved. I mean, they're not aware of this point. They do their regular cleaning. And with the supervisors, we go next day to show them how they have cleaned and what is the process they have followed. You want to demonstrate that?
Yes, ma'am. Yesterday, actually, how they are cleaning, for that reason I applied gloves, ma'am. It's a total hand I applied. They done cleaning here. It's not visible anything.
We will repeat it again. So in this glow gel exercise, you can see that this is a high touch point where they have applied the glow gel. So in the places where it has been cleaned, you can see that there is no glow. But at certain corners, you can see that there is a glow. That means fluorescent dyes have left. You show them, let's focus on that.
And a few areas also we can observe, ma'am.
Patient is a little irritable, so we cannot go inside. गगन जी, आपने देखा है? आपने देखा? क्यों ऐसे क्लीन नहीं हुआ? आपको ये एरिया देखना चाहिए कि वो क्लीन हो रहा है या नहीं. कैसे डिसाइड करते हैं कहाँ कहाँ क्लीन करना है, कितना टाइम क्लीन करना है?
हम लोग को टाइम में 3 टाइम क्लीनिंग होता है डे. तो ये फ्रीक्वेंटली जो हाई टच एरिया है फ्रीक्वेंटली हम लोग को क्लीन करना पड़ता है. बट कभी बाई वर्किंग टाइम में दिस हो गया, बट ऐसा नहीं है, हम लोग क्लीन करते हैं.
ठीक है. आपको हाई टच एरिया, लो टच एरिया क्या है मालूम है? क्या है?
जो फ्रीक्वेंटली टचिंग एरिया रहता है वो हाई टच एरिया रहता है. जो लो टच एरिया रहता है सीलिंग्स, एसी ग्रिल्स, वॉल्स, ये सब लो टच एरिया रहता है.
ठीक है. सो इस रूम में कब क्या क्या हाई टच एरिया है?
डोर हैंडल, बेड साइड रेलिंग, बेड रिमोट्स, बेड रिमोट्स एंड आईवी स्टैंड, मॉनिटर्स, ये सब है.
आपको सप्लाईज रेगुलरली मिलता है?
जी.
कोई प्रॉब्लम नहीं है. सिस्टर्स सब मंगवा के देते हैं आपके. This is also very important that to find out from your housekeeping staff, who are the ground level staff, that whether they're getting adequate supplies, adequate disinfectants, so that you can monitor and coordinate this process of disinfection. So that coming to the next question, what is the frequency of disinfection which is required? So ICU, as you know, is a high touch area, the high risk areas. So how do you divide, how do you classify this area? There's a beautiful description in CDC which describes the area based on patient vulnerability, patient access, and the amount of patient exposure. Based on all this, there is a scoring system according to which the areas can be divided into high touch, low touch, and moderate risk areas. It's very clearly given that if you have a high touch area, you're required to clean it with minimum of 3 times of disinfection. Then if it comes to moderate, maybe twice, and low risk area, maybe you can take a decision of doing it once a day. Or if it is not required, it's not patient area at all, it is in the hospital, like your auditorium where you're sitting. It is in the hospital, it's in the 5th floor where you're not, patient don't have an access. So in that area, a detergent is more than enough to clean those areas. So that discussion and decision has to be taken by a HIPC team with your housekeeping team and made a decision. Now coming to what is a kind of disinfectant we require. I think most of the hospitals we have aldehyde based, but slowly we are at the phase of phasing that out and going to quaternary ammonium compounds, or we also can have peracetic acid combination, hydrogen peroxide combination. It has to be seen with what are the materials you use and whether it is compatible. This is one of the major things that you have to see the material compatibility, and you can take this process ahead. Okay. Now moving to the next case, we often see cases where patients are on ECMO, and this is a very, very common finding that we see patients on ECMOs. Having so many ICNs and ICOs here who find it challenging to see how to take care of a patient, or what are the points we have to look in a patient with ECMO. We have Dr. Kola here who will take us through this process of the points, salient points, what we have to look when we come to see a ECMO case. Over to you, sir.
Yeah. Hi friends, they can hear me, right? Just confirm they can hear me?
We are able to hear.
Okay. So I have to come back to my ICU because we are initiating one more ECMO. So a couple of my team members are engaged in cannulating them and occupied with that. So I'm here to actually take care of and show you how a complex patient can be there in an ICU. So can you show them? So from here, can you show them the patient and the area? So for the privacy purpose, we actually has hide the identity by a cover to the face. But you can see the same patient in the same ICU have so many multiple gadgets and connections here. You have a extracorporeal membrane here with lot of circuits and cannulation, and this patient is on a multiple monitors, pre and post membrane pressure monitoring system, and there were multiple infusion pump syringes going on and a regular monitor. And if you can see, this is a patient with ECMO. Whenever you come across a patient like this with a multiple gadgets with you, these patients will actually have a very high invasive devices, like somebody like this patient, where you can see such a huge cannula into her neck vein, which will drain the blood. And we will also have a similar kind of femoral cannulas which actually can drain the so these are the femoral cannulas, which actually, again, the cannulas which drain the blood to an ECMO machine, and the circuit again gets oxygenated, and this blood goes back to through the jugular cannulas, which is a returning cannula. But what we are trying to focus here is, once you see this patient, you can see the amount of cables, wires, and different circuits available in this patient. So here also you can see a ventilator, a humidified circuit. There is a lot of actually exercise of a lot of oxygenators, oxygen pipelines, gas pipeline, the compressor air pipelines, and there is actually you can see the gas pipelines has been divided. So this all looks like a very complex and complicated kind of environment and ICU cabin. So what is the problem? What is the importance of infection control in this patient? The problem in this patient is, first, because of such a big cannula size, it is very difficult to give a proper care and cleanliness to these patients. The reason for that is, any change in position without a proper attention can dislodge those cannulas. So that makes these patients very difficult to position change. So our sisters, how do you actually take care how do you give a bath in this patient? What are the precautions you take care? Can somebody has a mic there? What are the precautions you take care when you actually give a...
Sir, along with doctor, respiratory therapist.
So by rule, you need a doctors and a team members like respiratory therapist, a perfusionist, who will make sure that they are holding and carrying those lines which are in place into the circuit. And then you actually try to give a position change with the help of housekeeping team and clean. So that's a big challenge. So if you don't have adequate team members, then it is very difficult to actually give a back care, perineal care, whatever actually cardiac care or a central line care or a mouth care will be difficult in these patients. Number one is that. Second challenge in this patient is surface cleaning. See, when you have so many circuits, wires, cables lying down, our housekeeping team will have a very difficult to actually enter to this room. They will be scared to enter to this room. So what we have done, if you see the surface has been kept free. All the cables has been kept into a tight bundle so that the surface is clear, and our regular 3 times a day to 4 times a day cleaning doesn't get hampered. So that has been taken care in this ICU. And the surface cleaning has to be done like any other patient, because one, these patients have a higher risk of infection because of invasive lines and invasive circuits. Again, it is not just about ECMO machine and ECMO circuit in this patient. All patients who are on ECMO, other than these 2 big lines which we have seen and a circuit which we have seen, these patients will also have a regular endotracheal tube in place. You can show the endotracheal tube or that endotracheal tube and ventilator circuit. And these patients will also have a Riles tube in place. These patients will also have a central lines in place, and these patients will also have an arterial line in place, and these all are considered as a devices. And some of these patients, when actually they leak, actually when the lungs with a blub or some kind of bulla ruptures, they also get into a position of needing a ICD. So what we are trying to explain you is, some of your ICU patient will be very complex like this. And whenever you come across this complex patient, we try to get away from a proper room or this surface cleaning, because neither my housekeeping team, neither my nurse will be comfortable in allowing them to clean. This is the patient where the infection risks are extremely high. So one side I have a high risk patient with a lot of complexity, the other side I have a team, housekeeping team, nurses who are really worried. So you need a training for these patients. These patients need an extra attention with a set of manpower who should able to handle. Other than ECMO circuit and multiple devices and lines, these patients will actually have a pre and post membrane ports. And these pre and post membrane ports were generally used for ABG sampling very frequently, maybe sometimes hourly, maybe sometimes the 4th hourly, 6th hourly. And as I understood, you can see these ports, and these ports can be a source of infection. And this circuit is not like your central line or arterial line where you find something grown, you need to pull out and put a new one. This is next to the impossible. If your circuits get infected, you are screwed badly. Your patient is under threat. So what you need to do, you make sure that all your ports are handled aseptically. It is a closed system, and we need to actually keep a very, very strong vigilant act whenever you are handling them. So we can actually take a kind of an example how our perfusionist or kind of our respiratory therapist take the samples from this part. So she basically rubs her hand adequately so that the hand hygiene remains that, and she uses a sterile glove whenever she is handling a circuit. Can we have a kidney tray, or you can use that? Can we have the tray there? Can we have a kidney tray, the whole cardiac table? Hand alcohol swabs. She swabs it with alcohol swab, and she wears a sterile glove. So the technique is a sample. उसके बाद rub करके flush कर दो. So after the procedure, she need to again rub the hub and again has to flush it back. And close it, and again close the system. So these are the ports of entry for any patient. See, we may be thinking that ECMO circuits are the source, but most of them they are closed. None of the ports we generally open. These are the ports which are continuously opened, and this has been sampled from here. So this can be really a source. So not like a ECMO patient, but all other patients where your arterial line has been sampled, central line has been sampled, you make sure that the rub the hub technique and SAS, saline, then probably sample, and again then the saline need to be followed in all your patients to make them clean. Rub the hub technique has been one of the common root cause analysis which we found key. Many of our nurses in the time of high acuity in emergency, they miss that in a rush. So that has been one of the breach in many of the situations, and because of non-availability of alcohol swabs, they may miss many times. So rub the hub technique has been one of the crucial point which we have realized in the recent times. So again, to summarize, to Dr. Akshit can come, in this patient, we have all those things in alignment, okay. So what are the things we are talking about? We are talking about in an ICU round, she spoke about devices in place. So our ICN spoke about which are the patient who have a devices, and she has reviewed all the devices care. It is not on paper. Mind you, all our nurses in a hurry, what they do, if they miss, they tick the check boxes. So if my ICN looks at the tick boxes or check boxes, probably she will not be appropriate. But what she do, what is the difference you do when you actually come?
So I will check what are all the device having patients. Is it central line or Foley's catheter and ET tube is there, means I will check insertion bundle along with the daily maintenance bundle. If the given care, even if they are not maintaining insertion bundle and daily maintenance bundle, I will call the concerned staff and I will educate them what are the importance. These are our evidence-based practice. For that reason, along with care, we have to maintain insertion bundle and a daily checklist bundle.
And one of the things we have also not shown is discussion with the clinician. So
You can do that. You wanted to discuss? We can. I'm a clinician too. It's not a part of the conference. Yeah.
Yeah. So whenever we have a patient like this, we always have, after the discussion, initial discussion with the ICN, we always come to the clinician and ask them.
You can ask a question related to this patient also.
So
what question generally you ask her?
So the TLC is increasing. What do you think is the reason?
So these patients, what we actually every day, in last 24 hours, we have not seen any drop in his blood pressure. We have not seen any rise in temperature. The leukocyte count remained to be the same. But yesterday we had an episode of, I think there is a drop in HB that leading to some amount of hemodynamic instability requiring a 2 or 3 units of packed cells. And the reason we found out was this patient, whenever they were on any ECMO circuit, they will be anticoagulated and the ACT remains to be around 200. And whenever they are on anticoagulation, we generally see they may bleed anywhere. So this patient had a GI bleed, for which actually we dropped our anticoagulation and started, but we didn't find any temperature rise. But one interesting finding in ECMO patient, you will never see ECMO patient spiking fever. The reason is this, you can show. So what does it causes? This causes a temperature regulation. The temperature has been titrated and monitored to a normal AC. Neither this patient will have a hypothermia, neither these patients will have a fever because of the thermoregulation. So you have to only rely on either your markers like either your CRP or a procalcitonin or TLC. Any cultures, TLC and other things, but fever will be a big challenge. And anything else you wanted to know, ma'am?
So we need to send cultures because TLC is increased and...
So what we generally do, if I have a patient where I am suspecting a infection, in this case because yesterday we have transfused 3-4 units of packed cells and we don't see any new organ dysfunction, my lactates remain to be normal and my peripheral smear looks okay without any neutrophilic shift to a toxic granules and vacuoles, probably I will give a time a day. But if it consistently rises up and I see my lactate rise or organ dysfunction, my threshold to do a cultures in them will be low because of the so many connections and circuits.
Thank you, sir. And we generally conclude and take antibiotic discussion also with that.
You can ask what is the antibiotics this patient is on.
But that's not the focus today,
Okay.
sir.
So generally also she inquires about what is the kind of antibiotic the patient is on, how many days the antibiotic being on, and what is the plan for those antibiotics? Do we need to de-escalate? Do we need to escalate? Do we need to stop those antibiotics? All this need to be a part of your discussion. To actually give a hints, then probably she will summarize. We spoke about 3 or 4 common bundles which we use. One is we spoke about a ventilatory care bundle. Then we talk about a central line bundle, which spoke about a catheter care bundle. Now we have shown a complex case of ECMO. So coming to the ventilatory bundle, she spoke about head and elevation, which is to prevent regurgitation and aspiration. And then she showed about oral care, and she emphasized that oral care is not with chlorhexidine nowadays because we have papers and scientific literature evidence suggesting chlorhexidine increases the chances of chemical pneumonitis and ARDS. So the normal saline and regular oral brushing is as good as chlorhexidine. So that is now taken as a replacement. We used to use chlorhexidine for decades together, but now we have shifted to a normal clear water or a saline brush, which is quite good enough. Now the third thing she said is cuff pressure monitoring, and which I emphasized and monitored. And the next thing is subglottic suction. I think we can show the subglottic suction here. So what I told you is anything which actually gets a micro aspirated can be there just above the cuff and it gets accumulated there. So we have a subglottic port. This port goes to the subglottic part. Users. No, she can do it. Priyanka can do it and give a syringe to her. So it doesn't need a sterile gloves. We generally use a hand hygiene practices with a hand rub, and then we actually use a syringe to actually every shift they do a subglottic suction. This yellow one, this is a pilot balloon for the regular what you say the manometer, but the other one is the subglottic suction port where you are able to see there is nothing there in subglottic port. So every 6 hourlies they need to do it. Okay. So this is a one more bundle, and the most importantly, every time our ICO and our ICN and our critical care team should ask two important questions. Can I stop my sedation and my muscle relaxant? Is this patient on muscle relaxant?
Yes.
He's on a muscle relaxant. What kind of muscle relaxant?
Fentanyl sedation is going on.
I'm asking muscle relaxant. Don't confuse with fentanyl. And is he on an atracurium or a rocurium? No. So the patient is not on a rocurium. Is this patient conscious?
Actually, sir, now I was kept on her sedation, sir, not paralyzed one.
Did you paralyzed?
No, sir.
So she is not under paralysis, but she is under sedation. She is conscious?
Yes, she's conscious.
So every day we look at conscious state of the patient. If my patient doesn't need sedation, doesn't need paralysis, we try to stop the paralytics. We try to see that the sedation can come down so that I can see a patient consciousness. I have shown you a video where my ECMO patient was walking. So in this case, I'm asking what was the sedation scale? Is the patient walkable or can be awake by calling? She says there is no muscle relaxant. The patient can be awake by calling her. She is just in a sedation scale of maybe 0 to -1, which is probably ideal scale. But every time we should look at dropping the relaxant and dropping the sedation. It is one of the important component of your ventilatory bundle. The last one on a ventilatory bundle is a readiness to remove the ventilator. Is this patient ready to wean the ventilator? Is this patient ready to wean?
Yes, sir.
Is ready to wean the ventilator out of the patient?
No, sir.
I'm asking, can I take out the ventilator?
No, sir.
Weaning is that.
First we will wean on the.
So is this patient on ECMO?
Yes.
So first we will, every time whenever we talk about a weaning of ventilator, we first see whether our patient, why we actually intubated and kept on a respiratory support, is that been better? For example, this patient got intubated and put onto an ECMO because this patient suffered a viral pneumonia, influenza pneumonia, and that was too bad that this patient needed intubation. We tried to prone, the patient was not improving, we initiated an ECMO. So now when I talk about a weaning, first I have to see whether my patient's lungs are improving. And how do we do that? We probably look at our chest x-rays and then PF ratios, but here because the patient was on ECMO, PF ratios may not play a big role. Then if my chest x-ray is improving, my patient is conscious, now first thing I will do is I will try to drop my ECMO support. So that is called a ECMO weaning. Once I wean ECMO, then I will think about weaning my ventilator in this case. But in normal circumstances, when the patient is not on ECMO, in another case, for example, we had a patient with a trauma, head injury or other cases, where we actually talk about can I wean ECMO, can I wean ventilator? If yes, we wean ventilator. If no and that patient needs a longer time, probably we also go for a tracheostomy. If I can wean, my patient's weaning criteria is fit, probably I will put onto the weaning trial. If my weaning trial is working well, I extubate. So these are also important points. The more the device days, the more the risk of infection. So every time my ICN, my ICO, my clinical team during the rounds should ask these questions also, other than head and elevation, subglottic suction, cuff pressure manometer, oral hygiene, sedation vacation, weaning from the ventilator, is it ready or not? These are about central line. So these are about mechanical ventilator support. Ma'am, can you summarize about a central line? Here you can focus the whole things which you have seen as a central line care. Okay, we can do. You keep on talking.
When you're looking at the central line, I think we have already seen that we look at the site of insertion. We look at we see whether there is redness, whether we can remove the central line is also a requirement. We look at whether that area is clean, whether the hair care and hair is away from that central line site, whether care is being given every day. If the care is not being given every day, if there is soiling, then immediately that has to be clean. With this, we also have to look at all the parameters, like if there is any unexpected increase in fever, increase in TLC, any rise of fever, any unexplained cause of hypertension, patient going into multi-organ failure, these also can be related to central line. Then you also see when was the culture sent, whether peripheral line, central line cultures were sent, whether the set of cultures were sent, when the cultures came positive, what is the time duration, so that you can see whether it is catheter associated bloodstream infection or it is only in the central line. Then you can take a decision on whether to remove the central line. If it is not required, we can always remove the central line. We can take a decision whether, but if you require the central line to be there, then it is, if the culture comes positive, it's required to the central line to be changed.
How do you look at incessant bundles, Pavitra,
Sir,
in your regular ICU?
Always we prefer transparent dressing, sir. Then transparent
Incessant bundle. So this is a maintenance bundle. We divide the central line into two components.
Yes, sir. Insertion bundle, maintenance bundle is there. Maintenance bundle, what are the parameters is there, means why we will insert. Is it any required for vasopressors? Is the patient in shock? These are the parameters we need to observe. After that, what type of catheter we prefer? Is it central line or PIC line or HD sheath? We need to observe. After that, how they are inserting? Is it they are following aseptic techniques or not? These are the parameters. Did they done hand hygiene? Did they applied as a disinfection solutions or not? These are the parameters we need to observe insertion bundle. The maintenance bundle is the insertion site is any oozing, any redness, any swelling is there, that we will maintain daily bundle.
So we also look at, they also look at the whole waste segregation part. Can you explain how do you actually every day look at waste segregation?
Sir, here we are maintaining 4 bundle, 4 biomedical bins. Green we will go for general
So
waste.
check how you check every day.
Daily
We
I
don't
will,
want.
daily I will observe, sir, like this.
Yeah.
So for green general waste, yellow bin is all anatomical waste, red is all plastic waste. If bin was full, that I will call HK staff to remove the bin. Alright, 3/4 is a bin was full means we will call and we will tell them to empty.
Are you actually also seeing the areas of dirty utility and clean utility,
Yes,
how
sir,
your
I will
disinfection
observe,
happens?
sir. So how their
Can we actually speak to one of your housekeeping team?
Sure, sir. Gagan, you have to full exercise. Join us.
No, you were doing with him, right?
Yes, sir.
So this is our ICU, which is around a cluster of 17 beds. You can all come. So. So the 2 team members, can we have all nursing teams on their patient bedside? So as a team members, the respiratory therapist, the ICN, ICOs, and one of the critical care team member who joins them with our housekeeping team, we all talk about, we have a housekeeping members, come. So we all try to talk about whenever we actually see a rise in infection rate, or whenever we see 1 or 2 new infection, we actually create a kind of root cause analysis thing. So how do you do a root cause analysis? Suppose assuming one of your patient had a new onset bacteremia and you think this is related to the central line. So how do you investigate?
So how?
Mic closer. Mic closer.
I will observe.
Mic
Sir.
closer.
I will observe central line side if they are done dressing frequently or not. Few times after dressing also is the line side oozing. Few cases we can observe because of patient having anticoagulants, that cases having oozing problem. So I will initiate the particular staff to do. We can keep that kind of patient gauze. With gauze we can cover dressing. So if gauze covering dressing is there, every 2 days once we need to change, sir. That way I will educate to the staff. So
She can add.
Okay. So I think the question what sir said is, now the patient is on central line. Think that patient has come for viral pneumonia. He's on central line for some purpose, and he's also on peripheral line. So now the central line has grown Klebsiella pneumoniae. Now I have said that it is a CLABSI case. Now you have to convince the consultant that it is CLAPSI and it is.
And there has to be a discussion. How do you do that discussion? So you can explain.
What do you do?
So I will inform the particular consultant doctor, sir, patient having is the kind of growth. Can we escalate antibiotics? We need to remove the central line if required, if not required, and we need to change antibiotics. What are the sensitive to the patient? That way I will.
So sometimes you may not have already a positive, maybe the growth is yet to actually flag what kind of identifying organism or sensitivity. So empirically we may optimize based on our hospital antibiogram, but in the meanwhile the general trend what we do is whenever we actually suspect any hospital acquired nosocomial, CLAPSI or a CORTI or a VAP, our clinical rounds team, the HIPC clinical rounds team will come here. They will actually try to discuss with our nurse in charge, the nurses who are taking care of this patient, the doctors who are taking care of the patient, the respiratory therapy who is involved, the housekeeping team who is involved. The discussion is something ki one of our patient, he has got a new hospital acquired infection and we are all responsible and accountable for that. And where did we miss, where did we breach in that particular thing has to be evaluated. And what is the most common finding when you actually look at those root causes, ma'am?
The most common is the line care. The line care is not given adequate because when we do a root cause analysis, of course, we first confirm that it is a CLAPSI case. Then we go back and see our regular rounds, right? We'll go back to see our observations sheet and see whether in the last 3-4 days, whether there was a breach. And invariably, we will see a breach that the line care was not good. Even for the catheter QWERTY case also, if you go back to your observation notes of the ICN, you will see that the care was not given, especially the meatal care was not given. I think it's a most important simple step, but it is quite often missed in these cases. So however important we say the bundle care is, it's quite often missed. So I think the importance of today has to be on the bundle care and regular follow-up of this bundle care. We have Dr. Ravi also who has come and joined us.
So we'll just walk around, we can walk around? So this is our ICU line and we have Dr. Ravi. I think Dr. Ravi has got occupied. Generally he will take care of the rounds. So he is occupied with, is the ECMO cannulation done?
Done, sir.
So I think what are generally whenever they cannulate?
Venkatramana sir, we are not able to hear you.
Dr. Ravi is here and he was actually occupied with the ECMO cannulation. It is just done now. And generally whenever they cannulate and do such procedures, what kind of observations we do, ma'am?
Sir, I will observe the SAR is doing hand hygiene, how SAR is wearing gloves, what solution he is using for disinfection.
Suppose some of them are not following, what do you do?
It's an emergency time. It's an emergency time. It's a life-saving time. I will.
You will compromise. If it is not an emergency and life saving.
I will inform according to doctor advice.
So she need to be firm on you and she can stop. So that's what we expect. She can stop, she can be firm, she can do. So sometimes fortunately we get an opportunity in daytime during the procedure when we are on rounds, we take the call on that. And I think in the vicinity of time we will cut short the whole. We have taken a round, we have showed your ECMO patient. We have tried to do whatever possible rounds, ma'am. Over to you.
And I'm sure all of you have a lot of questions sitting in the 5th floor. We will be coming on the 5th floor to answer your questions. Thank you, Priyanka. Thank you, Priyanka. She's our nurse in charge of ICU. Thank you for letting us observe your practices. I know it is not easy to let us all come in with our cameras and observe your practices. Thank you to you and your team. Thank you, sir. Thank you, Sapta, and thank you, everybody. We will be we can take questions.
Any of you have questions?
Swati, we can't hear your questions, so if you can take the questions, we will come on top.
Yeah. No questions? Okay. Akshita, are you able to hear me? Okay. Any questions regarding the practices or anything?
No, thank you for all the, it's quite confidential in many places, which is like not allowing anyone to, outsiders. I thank you very much for letting us see the ICUs during the rounds, and actually allowing, that's quite very, the people become very conscious, and but it is very highly appreciative of you doing this workshop. Thank you.
Thank you very much, madam, for the kind words. So we just wanted to make sure the workshop to be more practical rather than lecture. So this was our idea to show you how the bundle care practices are done, how the ICU or ICN actually have to do the rounds. So this is our practice, so that's what we try to project you. Thanks for appreciating our effort. Any questions, or we can break for lunch otherwise? We have lunches arranged in the gardens area, so you can all have lunch, and we'll gather back in 45 minutes here for the next session. Thank you.
Just be seated for a couple of minutes. Just door closes. See, we have a G-SPARC's organizing chairman and the whole group, the organizing chairperson of that international conference who joined us. We'll felicitate them. Ask all of them to come inside. అక్కడ రెండో మూమెంట్ అందరికి వెళ్ళి పిలిచేసి So it's a pleasure and honor to invite both Dr. Rangareddy Garu, who is a senior faculty and a founder member of Infection Control Society of India, and he has been a part of many initiatives to actually prevent infection, and probably programs and trainings associated with Hyderabad University. Many things are probably under statements for him. Sir, we privileged and honored to have you here, sir. Thank you. Please come on to the stage, sir. I also request Dr. Govind Hari Garu to be a part of us, and he has been also putting all his efforts to be a part of this organization called G-SPARC, the conference. I request Dr. Mona Lisa ma'am to actually give a bouquet to Dr. Rangareddy Garu. Dr. Swati, Dr. Sweta, Dr. Sutapa, all the faculty members can come up to actually felicitate them. Sir, please, both of you come, sir. Swati. I request Dr. Akshita ma'am, who was not available, to felicitate our guest. One more. So both of them got occupied for the inauguration program with the health ministry. So they are a part of G-SPARC. Thank you for giving us an opportunity. We hope we deliver that expectations whatever we had. And I just wanted a few lines from you.
Good afternoon. I really don't want to stand between you and the lunch, but first of all, I would like to thank Yashoda Hospitals, especially the Yashoda high-tech team, for organizing such a wonderful program. From the morning, honestly, although physically I was with the Health Minister along with Govind Harigaru to discuss some of the issues related to the current state of affairs on the public health, but also about our upcoming conference, G-SPARC. But my mind was here. I was thinking of all of you, and I was thinking what I had been missing. That is an academic feast, which usually is always given by Dr. Venkat and his team. And a big hand for him, first of all, and for all the wonderful team who always actually deliver such a high-level program. You know, I always feel entering into this floor especially, I always feel that whether I am in India or elsewhere, a big round of applause for all those people, you know, who have made it happen. Just 2 lines. Govind Harigaru has kindly been with me in this endeavor, co-chairing, although he is a co-chair, but he is more than a chair in organizing and facilitating the conference. And he had been a big force behind it. He is the General Secretary for Telangana Specialty Hospital Association. And what I can promise as the chair of the conference to you is we are going to have a wonderful time, right? Just in 2 lines, why G-SPARC? You know that antimicrobial resistance and healthcare associated infections had been on rise for some time, which are almost threatening the way we function in our healthcare institutions. If the situation is going to continue like this, we will not be in a situation to help the patients, you know, whom we are supposed to be caring and who are actually having a lot of expectations from all of us. These kind of, you know, huge, ultra-modern hospitals would be of no use if we are not going to prevent healthcare-associated infections and antimicrobial resistance, right? That is absolute truth. And forget about actually the patients. It could happen to us also, to our family members, to our dear ones. So as healthcare workers who are knowledgeable about these affairs, it is our responsibility to look at how do we improve our practices, how do we actually take this message to as many people as possible. And one of the things what we have done, about 140 of our institutions across the world, including WHO, Infection Control Academy of India, US CDC, and several institutions across the world, this 26th September, UN General Assembly is having a high-level meeting where AMR is going to be discussed. A political declaration is going to be made. And, you know, I am really happy that, you know, we had been part of it. But at the same time, I am also looking with the trepidation what is going to be the outcome of this 26th September. So during this conclave from 3rd to 5th, the global conference, which is inviting all the Asia, Africa, Middle East, and partly South America, we will be discussing these topics too. So this is a forum, this is a movement which we have built in order to ensure that especially those countries which have the resource constraints to deal with these problems are going to get united in order to do the research, evidence building, improving the practices, and ensuring that our patient safety is going to be the highest level. And one more point, I would like to bring to your notice is, thanks to people like Dr. Kola and all the other team and many other institutions, you know that 25 institutions have come together to organize the pre-conference workshops. This is a record of sort. It has never happened before. I don't think it will ever happen after. And even before we are going to start the conference on 3rd October, we would have covered something like 4,000 experts, professionals, and colleagues in this movement called as G-SPARC. And huge thanks to all of you. And you made already the history.
So
Thank you.
Ask them to join in the front for a photograph. So you are all a part of this G-SPARC movement. So we request all of you to be on the front so that we will have a group photo. So please join us in the front.
Hello, for all the nursing staff, there is a coupon available at the. Excuse me?
Done.
Okay. We break for lunch and we will be back by 2:30.
request all the delegates to please settle down. We'll go for the next session. They are doing. Kuchun, madam, they are doing it. For the next session post lunch, we would be going for engineering controls in infection control practices. So we have Dr. Vinod Shekhar, who is an expert in this field. He'll be showing us how the negative pressure, positive pressures, ventilation systems, or the HVAC systems work in the hospital.
Yes, yes. Just check, sir. Hello. 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 We have muted. Okay. This one is on, sir. Track details. Oh, yeah, I can start. Yeah. Yeah. Sure. Okay. Good afternoon, everyone. Yeah, I know it's very delicious. Good afternoon. Very delicious food. From morning we are learning a lot, right? And good interiors, good sofa. We have now next 1 hour. I need to keep you engaged, right? I could see all you people are good with your mobile phones, right? Yeah? Yes? Take out your phone, go to that menti.com fast. They are giving me only 60 minutes. I have too many things to convey. It will be fun learning, right? Trust me. Just everyone in any career, any level, just go to menti.com and give this particular code 58916959. And you need not to reveal your name. You can select some secret names when you are logging in. Make it fast. Code, yeah. You guys are technocrats. Everybody has got a smartphone and we use it daily. Let's use it. It will be fun. Nobody is watching you. Yes. Even if your boss is next to you, don't worry. No, don't show me. Yeah. See, till now only 13 people are logged in. We could see 14, and we should have at least we should have at least more than 50 to have fun. Make it fast. Don't take a photo of the screen. Log in. Done, 31. Make it fast. Is anybody having any technical issue? Yes? What sort of issue? Wi-Fi is available, yes. And your network is still good in the room, in the auditorium? Okay, I think I have to keep my finger. Yes. 11 more will start. I'll wait for the 50 numbers. Make it fast. No, only once. Yep. Okay. 4 more login. Who answered the fast, who answered the correct, we get the points. Okay. So let's see how smart we are. 4 more, at least 4 more. Make it. Anybody is still having issue? 48. See, I have just 1 hour time. 2 more, please. One more. Okay. Again, I repeat. Faster and correct answer would get the fun. एक बंदा भरोसा दिखाओ यार. Okay, perfect. Let's start. If somebody is coming late, they miss a chance. Let's make it full screen, sir. Good. Answer fast. Scanner Wi-Fi का स्कैनर था. Oh my God! In the entire auditorium, I have only one human. In the entire auditorium, we have got only one human being. See, imagine in hurry, we tend to do a lot of mistakes, right? We always go for the easiest option. We don't read anything fully. We don't give importance. See, ICNs, I am the ICN fast, doctors, and someone gone at the last to admin and engineering, they miss being a human. So small mistakes makes a major impact. Now let me talk to the one human. Who is that one human? Good. Okay. See, in the auditorium, if we are got there are 56 people voted, and 47 is saying mere fun, right? We are spending a lot of time of ours just for fun. We hardly. Who said the knowledge you are getting from YouTube and Instagram? Who's that? What sort of knowledge you are getting from YouTube and Instagram?
I don't use Instagram.
In YouTube, what sort of knowledge you are getting?
I use YouTube sometimes for some
Shorts.
knowledge stuff. So.
Rarely people see educational videos in YouTube. We only just sit, some idiot made something foolish, we sit and waste our time by looking at that, which is not going to give us any benefit in terms of knowledge, neither in terms of money. Who is that 4% said money? Please tell me, I will also earn money by using YouTube and Instagram. I hope your boss is not next to you.
That is one more reason they will write it more.
See, the person who answered for this, no comments, they're highly diplomats. They're highly diplomatic. Na is taraf, na us taraf. And who said no? In Hindi they call it chamchagiri, right? Chamcha people. And somebody else, they are some extent straightforward and honest people. Most of the time the juniors feel our boss or our senior doesn't know anything. And whenever ICNs go for rounds, the other nurses don't care. Housekeeping staff don't care. They don't listen, right? So I will tell you one small. Is it what? No, it's not in the main set. No, it's okay. I'll go there. So I connected my laptop. So I'll give you a small story, right? My presentation will be full of stories and fun. You will hardly get to learn something new. Okay, so one assistant director, movie director, he was frustrated with his director, so he called the God, right? He said, God, this director doesn't know about movie making. He don't know how to direct, how to write a song, or how to edit music, nothing. But he became a director. I know everything, but still, I'm still an assistant director. For that doctor, the God said to him, see, correct, he doesn't know anything. You know everything. No, but he knows how to become a director. Maybe he doesn't know anything, but he knows how to become a director. So if your boss is there somewhere above you, they are there because of some additional knowledge, some additional caliber, some additional responsibilities. So always listen to your boss. Most of the bosses are good bosses, because I have more than 20 people in my office. I'm boss. So listen to your bosses. They are here to teach you and train you. Okay. Keyboard set of assistants. Do we need to? Okay, you guys see the thing in your lab. Should I remove it? Is that visible in your phone? Yes? Okay. Quit. Okay, perfect. Thank you. किसका काम है? Who is responsible for infection prevention and control? Good sensible crowd I have here. You know, most of the people want, people are responsibly answering. It's a work of everyone. Why it is the work of everyone? Again, I'll tell you one small story. So I was working with the Central Pollution Control Board way back, around 15 years back, and they asked me to go to one particular hospital in Uttar Pradesh, government hospital. They asked me to see what is happening with the biomedical waste at the end of the day. So I went as observer, stood there in the OT the entire day. In the evening, when they were segregating the biomedical waste, the person put one particular stuff in a wrong bin. I said, you are putting in a wrong bin. He said, kuch nahi hoga, chhod do, in Hindi. That means nothing will happen, leave it. Kuch nahi hoga, chhod do. So I was waited there, and then all the biomedical waste went to the biomedical waste department. We went to the biomedical waste department. We waited till 6 o'clock. The gentleman collected all the waste, threw it behind the wall. What is his job? To remove the biomedical waste from the hospital. What he did his job, no? He threw it. You can't see it in front of you. So it's behind the hospital campus. It is not in the campus. So we went behind the wall to see what happens to all this biomedical waste. Small rag pickers, kids, no shoe, no glove, no PPE kit, no mask. They come fighting to collect all the cottons with the live blood, pus, human tissues and everything. They fight each other to collect all this blood. With all this cotton, they go to a small shop. They sell it 1 kg for 3 rupees. Wherein we consider that as a waste. The cotton with live blood and pus. The kids sold that cotton for 3 rupees per kilo. So we went to that shop. That shop collects same sort of cottons from across the town, from various kids, collect everything. And next day morning again we went. They put all the cottons in a small vehicle. In a small vehicle, and they sent to another shop at 30 rupees per kilo. So 0 to 3, 3 to 30. That shop collects all this cotton and produces something. What is that? Guess fast. What, ma'am? Toys? No. Compressed foam mattress? No. Earbuds? Yeah, they produce earbuds. In the Signal, you get 3 packets for 10 rupees. Johnson & Johnson sells 1 packet for 30 rupees. Where do you get the cheapest one? Earbuds. So the person who said kuch nahi hoga chhod do, that is leave, nothing will happen. हो सकता कल को अगले दिन सुबह उसकी कान पे, means his own mistakes will come back to his own ears. हो सकता maybe his son or daughter will be using the same buds. So one small corrections he should have done, or the biomedical waste department should have done their work properly. Otherwise, the shopkeepers should have done the work properly. If everybody thinks it's job of somebody else, we end up doing a massive catastrophic problems for us and for our family. Still a good crowd. I appreciate. Most of the people does not answer intact skin, whether they'll go for antibiotics or disinfectants. So it's very important. We need to understand the basics very first. Maybe during first course of us, they must have told us intact skin is the very best mechanism against microorganisms. But we leave that, we go for super beyond, we keep pumping us with a lot of chemicals, which we will discuss during my presentation. In COVID, everybody negative isolation, negative pressure isolation. What does that mean? And in this auditorium, except one engineer, everybody is, or nursing staff and everybody, we have dealt with the negative isolation during COVID. What is negative isolation means? My presentation is going to be tougher for me because everybody is knowledgeable. So if you guys are aware what I'm going to teach for next 40 minutes. Good. Indoor air going out mainly in high level. It's a negative pressure isolation. And this question, it's about money, and this is the last question for this short session. And I think you guys are smart enough to answer this question. How much money is it? Yes. नहीं, मुझे तो 15 लाख आ गया, आपको नहीं आएगा? See, maximum females in the crowd, they are good in mathematics. I expect a good answer for this. Yeah, it's yes. Yeah, so I lied that I don't know who answered what. Who is Ruhi? You. And who is Wolf, Mister? Wolf. You. Second. You. Both of you chosen Wolf, Minister? The second one. This one. Who's chosen? It won't come. Okay. The second one. Who is Ganesh? Third one. Okay. So you three will go for the second round after my next presentation. Right. So it's just to break the barrier, and let's get into the main topic. Just I myself introducing, just leave it. So we are going to talk about engineering controls of infection control, right? You may say, what I got to do with infection control or engineering team? I'm a nurse or I'm an ICN. I'll come and look after my patient or come and look after myself. Why should I bother about engineering controls? Okay. Imagine this is a sterile object. Okay, it is a sterile object, and you are disinfecting this surface, this particular surface, you are disinfecting it, and the nursing staff who is going to handle it, she or he disinfected hand properly, and they are removing this particular object from a sterile pack and keeping it on this surface. The surface is disinfected, the nursing staff disinfected our hand, and this object is removed from just a sterile pack. Now, is the object sterile or not? Why? Why it is not sterile? I just removed it from a sterile packet. Yes, sir, but again this object which I took out from the sterile pack, is it now sterile or unsterile? Unsterile. Reason being airborne microbial settlement. Now everybody's done our work. Housekeeping staff disinfected the surface, nursing staff disinfected your hand, CSSD done their sterilization properly. Now who has done the work properly? Who has to do the another work properly? Engineering team. Engineering team should make sure the air which is getting inside the room should have utmost cleanness with a limited number of microorganisms. Most of the time we ignore this particular parameter, mainly engineering controls or airborne air quality, and we focus on too many other things. There are research papers which says 55% of hospital acquired infections are directly or aggravated by poor indoor air quality. That's why the engineers should also be a part of engineering infection control team. Who all played this game? Not kids. You play or did you play or not? No, at least now you must have playing with your son or daughter. Everybody played, no? If we all played, then we all are also engineers. You know, while making this particular game, we make sure the balance is proper, it is standing properly, there is a window, there is a door, there is a visibility. So we all are also engineers. We should not bother about ye kaam sirf engineering ka. So I'll give you some examples of, no offense to any engineers in the auditorium, what happens in India with our engineers. What is this? No, don't tell me it's a men's urinal, but you guys are intelligent people, so at least answer what is this? Jugadu. That person, he used his brain, you know. In Japan, sir, India mein ajib sa mila ye mujhe. In Japan, you have got inbuilt with flush also. Exactly. Now, this person made this. He thought people has to wash hands. The same water can be used for flushing, and we can increase the men's to increase hand wash. Hardly anybody does in men, so he increased. This one now became a commercial product, right now. So somebody did a jugadu, and some company copied it and made a commercial product. So this person put a brain and somebody copied. Now, what we are doing, this is in one of the public toilet, female version. Means I didn't go inside, but I got this picture. It's a female toilet. For the carpenter or for the engineer, he has to fix the door. He fixed it, no? His work is done. He didn't bother why he has to do the job. So when we are doing our job, we are not bothered who is saying anything else. Mera kaam hai kaam karna, mera kaam kar diya. This is how. This is another worst one. It is a bone marrow transplant isolation room in Delhi in one of the private hospital. Between the toilet seat and the door handle is 4 feet. You can check the tiles. All the patients are not Superman to hold it. So patient has to go with the relative. He will hold the patient hand and the door rail. If they should have thought about it, small engineering corrections. It's very, very important why we are doing any process. Why infection protocols are very, very important in hospital sector. You guys must have seen this box. Anybody seen this box in the roof? Yes. Any ICNs? You guys go up and see. What is HVAC? Oh, it's already clicked. Okay. Heating, ventilation, and air conditioning. In India, we hardly use heating. We use ventilation and air conditioning. Tell me, everybody is using AC at home, right? No? Which AC is a good AC? Means good one. Box AC or split AC? Split AC, why? Which AC is good, box AC or split AC? At least now, see, there is. You can tell me last row also. You can be loud enough to convey. Which AC is good AC, box AC or split AC? Split. Why? Why split? No noise. Expensive. Box. Anybody for box? Okay, let's check the voting. How many for box? Who is saying box AC is good AC? 1. How many saying split AC? Okay. And which AC gives fresh air? Box. Okay. How many saying split AC giving fresh air? At least you can raise your hand, sir. I know food was very good. both the ACs does not give you fresh air. Most of the places we could see, they spent the money in making a modular OT and put a split AC, say that I have done my air conditioning. No. The name of this air conditioner is called only air conditioner. It will take the air from the room, whatever the temperature you set, 21 or 24, it will reach the particular temperature and automatically switch off. Again, when temperature increases, again air will take in from the room, again condense it, again release in the room. So the air conditioner, split AC, box AC or cassette AC does not give you fresh air. You need to have a HVAC system, heating, ventilation, air conditioning system in healthcare settings. At home, you use any AC, that is not an issue. But again, in a hospital, no jugadu with box AC or split AC, it should be air conditioning system. Why we should use air conditioning system, we will discuss in detail. I want to show you a small animated video how an HVAC system works. You can see the red color air which is coming from the roof, that is contaminated, and you can see there are HCCC, that is filters, pre-filter, fine filter and HEPA filter. They are filtering the microbes. The air gets into the ducts and travels across, coming down to your ICU or your working chamber or OT, wherever it gets in, and because of human being it's getting contaminated, again becoming red. Again it will go through return riser, it will go again, some air will be sent out, some amount of fresh air will be added. I repeat, the air comes from the roof to HVAC, we filter it out, we remove all the microorganisms, it comes to the room. Yeah, so it's come contaminated, again goes to return riser, again filtered, again the cleaner gets in, right. I'll just go this. Okay, it plays a crucial role in air filtration system and contains AHU, heating, cooling coil, filtration model, multiple filters, temperature, humidity, pressure difference, lot of parameters are being used here. Now, you guys know what all filters we have. Anybody can say, well, any we listed here. In the hospital, we use pre-filter, fine filter, HEPA filter, activated carbon, whatever. How many guys, how many of you having air purifier at home? 1, 2, 3, only 3 people, 4. Delhi? Yeah, I am from Delhi. No, Delhi also I don't have. Why we are having air purifier? Any reason? It will keep the indoor air quality clean. Air purifier is nothing but a dustbin. What we do brooming at home, we collect all the dust, put it in the dustbin. Same way air purifier will take all the dust from your room and keep it with it. And there is no study shows that indoor air quality improves because of an air purifier. हमारा घर में bedroom में अलमीरा है. We do have अलमीरा at bedroom. उसके ऊपर last when did we clean? When did you last clean above the अलमीरा? Once in a week? Really? Impressive. Once in a Diwali we clean? Only Diwali we clean that. Otherwise we are not bothered. Sankranti time. Okay, good. Today evening you go and check the dust level above that particular almirah, right? What we do, we buy air purifier costing 20,000-30,000. We imagine that will do all the magic and we will not do anything. You should not depend on, unless until you yourself reduce indoor air pollutants, the machines cannot do anything. Air purifiers has got their own limitations. But here it is comes with the multiple sort of filters to filter. So just to pass through, I will show you this one. So pre-filter is the first stage of stopping the dust particles up to 10 micron size, okay, 10, and then there are fine filter, it will do up to 5 microns. So stage pre, fine, and then comes HEPA filter. Everybody must have heard HEPA filter, HEPA filter, HEPA filter. So I already described its high efficiency particulate arrestance filter, and they say 0.3 microns. Why 0.3? Why not 0.1? Why not 0.4? HEPA filter, we all know, it filters up to 0.3 microns, 99.99%, 995%. Why 0.3? Why not 0.2? Microbial size. No, sir, we have certain virus, if it's 0.1 also. Droplet? Of course, virus travels with some droplets or fungus, but still, because as on today, we have measuring monitor only up to 0.3 microns of a particle. Till now, there is no measuring monitor to detect something which is less than 0.2 in a filter. That's why HEPA filter has got a capacity to filter only up to 0.3, but it may do much better, but we can only measure up to 0.3 microns. And HEPA filters fitted in two ways, one in the roof itself, another one in the OT, correct, no? Other one in the OT. HEPA filters you guys must have seen. Now, this gentleman is checking in the OT how HEPA is validated. I will show you the next picture. Activated carbon, we all know, even in the shampoo ad, they put an activated carbon, it absorbs all the waste and it makes sure the water and microbial particles are removed, activated carbon. Now, maintenance and replacement, when we should change the filters, most of the hospitals in India, most of the hospitals, for an engineering team, these filters are nothing but a physical barrier. They may not understand what is the importance of these filters having in their infection prevention. For them, 6 महीने हो गया, filter बदल दो, 15 days हो गया, इसको धो के सुखा दो. So most of the hospitals does not have a proper engineering preventive manuals, and engineering staffs are not involved in infection prevention team. It's very important the engineering team should be part of infection prevention team, and the ICNs should have a capacity to go to each room and check whether did they do the proper pre-filter cleaning, fine filter cleaning and sun drying, and followed by HEPA filter validation as well as HEPA filter when you have to change. There is one hospital in India, in my experience traveling all across India, who is having the best engineering preventive maintenance protocol and following it is JSS Medical College, Mysore. They didn't change the HEPA filter for last 7 years. Still, the HEPA filter is giving 99.995% of efficacy. So, a proper preventive protocols will help you in reducing indoor airborne microbes. Now, what is this? Can somebody guess? Duct. This is a brand new duct. It's a brand new duct when they install. This is after 3 months, because most of the Indian hospitals are whether in a crowded metropolitan city or in a rural village area with a lot of plants and trees. So, this is after 3 months. These are pictures taken by us. This is after 6 months. So, we go in the morning front of this, we all consume these dust particles. You are not going to get a great fresh air unless until your ducts are cleaned and disinfected. This is after 1 year. So, our ducting is as dirty as our wash basin, the pipe you must have seen, the biofilm pipe, it's as dirty as this. Is anybody in this auditorium, ICNs, had ever went up, removed this grill and checked it? You guys check? Okay, that's good. How many of you do duct cleaning once in a year? Okay, good. Duct disinfection? Many of times, good. Most of the people does not even know where is the duct and how it is going. It's very important, because if you want a clean water on your tap, your water tank, the entire pipe should be clean. Same way, if you want to breathe the clean air, the HVAC system, the entire duct has to be clean to get you a clean air. Now, it's a small video of an operation theatre in Bangalore. It's a live video which we shot. This is what getting inside the OT, and it's an ortho OT, right? I'll repeat the video, maybe you guys can see again. It is not seen by us, that's why we don't give importance. Most of the time human beings give importance for the thing which looks good for us, by eye. It's a duct. It's a duct just entering to the OT. Yeah. Now, after HEPA filter, you still get this much of dust. Sometimes HEPA filters are in terminal. Yes, in this hospital. Yes, because this hospital has got a plenum HEPA. That will capture. If you have got a plenum terminal HEPA, it will capture. If you have got a plenum HEPA, it will not capture. Even if you have this much of dust, even your terminal HEPA will have a lot of load on the dust. So, the HEPA will fail much faster. Duct cleaning? Yes, every year. So, you guys must have seen this is a brand new OT, correct? No? Where is laminar airflow here? Where is the laminar airflow? This one. This is written grill. Though you can see in the top, that is called laminar airflow. Light के ऊपर जो white color का जो there are 12 boxes, no? Why laminar airflow fitted there? Why not on the walls? Goes to say you are creating a flow, laminar airflow. But again, we can also have from sides pushing to the patient. Okay. This is an example video, right? We have got a door, we have got a window. Above the window, there's a small one. What is the name? Ventilator. You guys might have at your house, old houses. What is the need for that ventilator? Hot air. As a human being, we release body heat and we create volatile organic compounds, VOCs, lightweight microbes, most of the time the virus particles, something. They float 7 feet above. In an indoor air, you divide into 3 categories. One is 3 feet below. That's why most of the time you do air sampling 1 meter above air sampling and 7 feet above. We humans, we only breathe between this gap. When I'm walking, I don't disturb the air like this, right? The body weight or lightweight microbes or VOCs are floated above 7 feet. That's why we had ventilators in those days to flush it. In these days, we have ventilator at home? No. And also we don't open the windows. We say मच्छर आ रहा है, बगल वाला बंदा घूर के देख रहा है, you know. All this, we don't ventilate our houses properly and then we complain मेरे बच्चे को अस्थमा आ गया जल्दी जल्दी. If you don't have a proper ventilation, you will have all these respiratory related problems. So laminar airflow fitted on the roof to flush everything from the bottom and to send it on the sides. So these are the sides. In most of the OTs, in my experience, I have seen the medical trolley will be kept here, or biomedical waste bin will be kept here. They don't keep this area clean for the air to pass in. We only keep all the stuff which is important stuff. You are sending a contaminated air out, but there you are keeping all these hurdles. So these 4 areas should be always clean and clear for the air to move out, right? Temperature and humidity. And yeah, before this, I want to show you something. Now we are talking about laminar airflow in India. If you go to European hospitals, mainly in Finland, they say laminar airflow, it's outdated, it doesn't work. Reason being, when I'm flushing the air and pushing it in the sides, these 2 zones, it's called gray area, wherein there is no air movement. Imagine we are just flushing it like this at fast. These 2 areas are called gray zones. There microbes stayed stagnant. So now they started coming up with a mixed ventilation. In some countries, even though it stopped fogging, they are again going back to fogging to make sure these gray zones also corrected. Now, this one. Temperature and humidity. What is humidity? What is RH? What is relative humidity RH? Okay. Yeah, what is it? Audience, what is RH? Relative humidity? That is amount of water molecule in the atmosphere. Okay. If you have got dry weather, then you sweat to equalize the temperature. If it is raining, you will feel stickiness because outside humidity is more and you are less, something like that. The relative humidity should be between 45 to 60 as per the standards. 55 is ideal, so that you don't sweat, neither you are feeling some other uneasiness. But have you guys monitor or take a note of relative humidity during your daily protocol in the OT? RH? Does your hospital has got such a screen in the display? Yes. Do you guys make a note? Yes. And temperature should be 21 plus and minus 4. Most of the time what I have seen, people put paper. By patient को ठंडा लग रहा है, हमने paper लगा दिया. If patient को ठंडा लग रहा है तो you increase the temperature. Don't cover it with that. You are having more and more problem. For example, in your bedroom, Indian standard bedroom is of 200 square feet. If 3 adults are sleeping in the evening at 10 o'clock in a 200-250 square feet bedroom, around what we do to save the energy and power, we close all the door, windows of a room so that air doesn't go out, and we close and sleep. Around morning 4 or 5 o'clock, the available nascent oxygen level will start dropping because there is no fresh air supply, and you closed all the doors and windows. And that's the reason when you sleep and wake up early in the morning from air conditioned room, you feel little lethargic, you will feel little tired, you will feel lazy. Unless until you come out and take a fresh air, you will not feel fresh. So it's very important to have a fresh air supply, and temperature and humidity also plays a major role. These are big tricky calculations. Air changes per hour. You guys must have studied in OT we need 22 air changes, in ICU we need 12 air changes. Why do we need air changes in OT and ICU? Why do we need air changes in OT and ICU? What is the reason? The person must have thought something. What is the reason the air changes? How many times in 1 hour you are circulating the air? What is the need for it? Any guess? Okay, tell me one, except doctors, one bacteria becomes 2 in how much time? Nursing staff. One bacteria becomes 2 in how much time? You guys are smart here, you answered good for a first session. One bacteria becomes 2 in how much time? 20 minutes? If my air change is taking more than 1 hour, by then the microbial level will be too high. That is the reason the air circulation runs as fast as possible to remove the microorganisms from the atmosphere. The more the critical area, the more the air changes is required for that. Pressure difference. Have we ever felt while opening the OT door or closing any door, it's very difficult to push? Yes. Why do we need to have a pressure difference? Positive pressure will work. Reverse. But what is the need for a pressure difference? Will not go inside, or it will be flushed out in the pressure difference. Is there any BMT people here? Anybody from bone marrow transplant? As per the standard, the pressure difference for a bone marrow transplant or any transplant room is 2.5 pascals pressure difference, right? But in India, we have checked it in several hospitals across India, 2.5 sometimes doesn't work, because Indian buildings are not airtight buildings, right? So sometimes people are using 4, sometimes people are using 12. So before you calibrate your area, you need to check which suits your hospital, which suits your scenario, and you need to adjust the pressure difference between these two areas. Airflow pattern, okay. Can someone tell me what is the technical name for ceiling fan? You know ceiling fan, panka? What is the technical name? Whomever is having an app, tell me what is the technical name for the ceiling fan? 3 blades? What is the technical name for ceiling fan? Guess some random guess. Air distributor. No, it doesn't distribute, no, it doesn't go there and come. Disperse, it has to move out, it is not moving out. Anybody from the back side? Circulator. Ma'am, circulator means it has to come the circulation. People are Googling it. I know Wi-Fi, people are Googling it. The actual name for ceiling fan is air grinder. You see oriental fan, or you see yourself, if you are below the fan, you get good wind. If you go a little away, you don't get the air. It's called air grinder. So what it does, if a patient is sneezing or coughing or vomiting, if they are below the fan, that particular airborne will remain in the same place, it will not move out anywhere. That is the reason in critical areas like ICU, OT, or even in OPD areas, ceiling fans are not allowed. Otherwise, the particles will remain there only. And above the blades, it is a stagnant area. It does not move here and there. Now, at home, whenever you are cooking, if some item is burned, what we do first? First switch off the fan, first switch off the fan, and then switch on the exhaust. So what happens if fan is on, the smoke will remain in the room same. So we are switching it off, and we are creating switching on the exhaust. What does the exhaust do? What is the role of exhaust here? Sucking. Negative airflow means you are removing the contaminated air from the room to throwing it out, negative airflow. So the positive airflow where the clean air gets in, like you should have a positive thoughts within you, same way in the positive airflow the clean air gets in negative airflow the contaminated air throws out. Where all we should have positive airflow? Back row. Transplantation unit. Everywhere except isolation area. Right. Only in isolation areas we will have a negative airflow. Otherwise, all the areas we will have a positive airflow. How much air changes is required? It depends on the place to place. Right. Now you see the green color, the air gets in more, gets out less. Positive airflow. In a negative airflow, you are getting the contaminated air out more. Who all tell me, who believes during COVID we learned a lot? Who all believes COVID taught us we are more stupids? Good, somebody agree with me, right? We did all possible gimmicks in COVID to save ourselves. We fogged the road, we fogged the building, we closed the entire street, we used disinfection tunnels. We were panicking to save ourselves, but we are not sticking to the basics of science, right? Now, you guys tell me, what is the difference between antiseptic, hand sanitizer, hand disinfectant? Everybody is expert here. Everybody is using on daily basis. Tell me what is the difference between antiseptic, hand sanitizer and hand disinfectant? Okay, ma'am. For what? Inanimate objects. Tissues. Okay. Some extent, correct? Anybody? This side. The girls row. Guess, yeah, you guys are using on daily basis. Skin. And sanitizer. We are using on daily basis. Whenever we buy a product or whenever product comes, first we see what? MRP, not composition. No composition. First we see MRP. Second we see the expiry. Sometimes we see who is a manufacturer. We never have a time to read the label of any product what we are getting, right? We just buy and then go. Septic, antiseptic, as ma'am said, it's only for living wounds. If you got a wound, what we say, septic ho jayega, pehle TT lagao. So to avoid the septic on the skin, we use antiseptic. Which all is antiseptic? Savlon, Dettol. How many of people using Savlon and Dettol for floor cleaning? Floor cleaning, no. Most of the hospitals I have seen in India, they are using Savlon and Dettol for floor cleaning, right? Private sector, maybe less. Government sector is more. Most of the government sectors. So the purpose is for skin antiseptic. We are using for floor mopping. Sanitizer will kill only bacteria up to 95%. Disinfectant will kill all the form of microbes except some fungal spores. Now in the hospital sector, you should use sanitizer or disinfectant. And then sanitizer. Sanitizer is for domestic purpose. Disinfection is for hospital purpose. But sometimes we used to see people misusing a sanitizer in the hospital, disinfectant at home. So what I'm trying to say, we sometimes try to do something extraordinary and we miss the basics. Any infection prevention protocols are very, very basics. We should stick to the basics. Now, you must have heard NABH audit आ रहा है. I have ISO class 5, I have class 100, class 1000. You guys have heard class 100, class 1000. What is that? This ISO, they call it in the US standard. Class 100, class 100 is a European standard, right? In operation theatre, you should have ISO class 6. You see, now class 6, class 100 of this many particles in 1 square meter area. How many particles are allowed in a critical area in hospital? That's a clear standard, and you have to achieve this particular stuff. But sometimes if we don't do the proper engineering parameters, proper controls, we not end up reaching these particular parameters. and then you will not end up getting NABH or JCI or any stuff. So, this particular chart is mainly with engineering team, and whenever you get a HEPA validation report, in the report it is clearly mentioned what you achieved. So, if you are getting this particular one, you need to understand what you have to do with this particular reports as well. So, opening your windows is key for the natural ventilation and key to the healthy life. Right. So, windows, I mean to say Ghar ki darwaja, not your Microsoft Windows. People misunderstand open windows means not in your phone windows, it is your home windows, you should do it. And maybe this is the last slide. I want you guys to give me interpretation for this particular picture. Give me interpretation for this picture. Helmet secured. Full ventilation. See, this helmet is for his safety, but he kept it safely. Same way infection prevention protocols are for our own safety. We are coming to hospital to earn money. ICUs will say, or nurses will say, oh, social service, if you don't get 2 months salary, your social service will go aside. We are coming here to earn money and take back money, not any infections. So, the infection prevention is mainly for yourself, then only patient. You have to safeguard yourself. So, the infection prevention is for your own safety, and you should use it wisely for saving yourself as well as saving the patients. You guys must be now attending today workshop. Again, there is a conference in G-SPARC. So, everybody will be geared up. Okay, whatever they taught me, I will go and execute in my hospital tomorrow, maybe from Monday onwards. You will be highly pumped up. Monday you will try your best, Tuesday little bit slow, Wednesday further slow. Within 1 week you will say nothing is going to change. Mujhe kya lena dena. So, sometimes or most of the times we want to execute, but we don't execute, but better to start with you. Your belief does not make you a better person, your behavior does. Right. Most of the time what we do, we think that let other person do and then only I will do. Otherwise, most of the time the juniors or seniors, doctor मेरा बात नहीं सुन रहा है, ICN का हमारा doctor है, nothing. You have to do a collective work for the infection prevention and control. So, I will wind up my story by presentation by giving one small story. Honeybee, you know, Madhumaki, honeybee was sitting with a friend. The friend was asking the honeybee, don't you feel sad that you are traveling to all the flowers, collecting all the honey and making honeycomb? One day one human comes with no effort, he kicks you out of your own house and takes all your effort, which is honey, right? So, that is what we do, we go and kick out the honey and take all the honeybee and take all the honey. Further the honeybee said, see, the human knows only to steal the honey, he don't know how to make the honey. So, if you are passing on the knowledge or if you are making a discipline, nobody is going to steal from you because your knowledge and skill will be with you. It is very important for the continual education in infection prevention and protocol. And the engineering parameters are very, very crucial for your hospital to run and for you also to have a healthy life. At your house also it is very, very important. Sometimes if something is not correct, you should not say that oh engineering unke department ka kaam hai. The entire hospital runs on trust basis, not the trust, ek dusre ka trust mein. So, everybody should involve in infection prevention and control. So, that is it for my presentation. Any questions? You guys will be attending this, yeah? Any questions on indoor air quality, engineering controls? Yes, ma'am.
Hi, many hospitals do not afford good engineers. Like, I don't know whether they are up to the mark. Like, is there any training program or is there any validated programs undergoing, like only for the engineers?
Yes, ma'am. There
to
are
go and attend and come back and implement.
Yes, ma'am. Yeah. There is a separate engineering.
Thank you.
Yeah, thank you, ma'am. There is again engineering controls for infection control or engineering controls for healthcare. That is a separate training program. they can attend for 5 days. There's a program. They can attend and what happens, engineer, he studies only building architecture or making. They don't understand the science part of it. So there's a separate course to teach them what is microorganisms, how it spreads, what is airborne microbe, what is waterborne, how you should see the biofilm and understand and do the corrections. Because most of the time the ICN or infection control team never goes to HVAC or the water tanks or the CSSD or biomedical waste outside. So the engineering, there's a separate now course only for medical engineering technology. People are studying it, but yes, engineers also there are courses to attend it. I attended a course in Harvard School of Public Health in US, wherein they teach for 15 days only airborne microbial control. So there are courses people can study, and yes, now hospitals have started hiring people who has got experience only in pharma and in healthcare. To have healthcare, it's a different ball game. Yeah. Yes, sir.
In India, there are so many small nursing homes. They will run the ICUs and OTs. If there is no HVAC system, how they can manage the infection then?
First of all, they are not bothered about infection, right? I've traveled, you name any state in India, no, they are not bothered. I've seen hospitals running in complex, shop complex, shutters, they are running it, they are not bothered, they only bother about money. Neither they are checking the parameters of the infection prevention, neither they themselves worried about. I visited one of the hospital in Hyderabad a week back, respiratory medicine hospital. Maybe within this space, 100 people are sitting, coughing and sneezing, no ventilation. Literally no ventilation. That means you are coming for one problem and you are going to get another problem. So the healthcare, now there's a hospital management course in that they are teaching about the importance of the engineering controls, or importance of ventilations and importance of all the stuff for the healthcare sector. That's why if you should be privileged to get treatment like hospitals like Yashoda. Otherwise, in rural zones where they are running a small clinics and hospitals, they are very pathetic in nature. Any questions? How do you disinfect the ducts? Okay. So basically there are dry fogging machines, dry fogging disinfectants where no water is required. The fogging is released on the HVAC. The HVAC run on a fan mode, so that it travels across the duct, again goes back, and there is a sampling is taken to check whether what is the load before and after. Can somebody tell me what is the difference between fumigation and fogging? What? Fumigation is wet mist. Fogging is dry mist. And fumigation? Same. Solution? No. I have time? Okay. So formaldehyde, ma'am said correctly, when you are using formaldehyde with potassium permanganate, you create formalin gas. That's called fumigation, fume, right? That is not recommended because it's carcinogenic, takes 36 hours, blah, blah, blah. Fogging, where we use fine particles of water droplets released in the atmosphere to kill the microbes, it's called fogging. Sometimes I बोलता fumigation हो गया. Fumigation is outdated, it's a wrong term to use. Fogging is the one which is happening now.
So any guidelines for cleaning of the pipelines? Because in many hospitals...
Water pipeline you talk about? Yes.
Yeah.
Ma'am, if you are finding Acinetobacter, Pseudomonas, sometimes Salmonella, then there is a parasitic acid stuff.
That we are doing, but like that we are doing only for the dialysis lines, not for the water types or other.
That you will be taking gradually, some samples you will be taking. If you find only, you should do it, otherwise.
Otherwise.
No, drinking water you will have a RO system.
Yeah.
You have to get it cleaned. Cleaned with the pipelines, parasitic acid.
Like a monthly basis, we are cleaning with the parasitic acid.
Yes.
Apart from that, there is any recommendation for like if the buildings are very old, 20-25 years. So there
then
is.
In that case, first they should do it with the chlorine, because chlorine is very strong, but not that good. Because to remove such a heavy load, you should use chlorine based, and then followed by they can start gradually doing it with parasitic acid granules. Yes.
Thank you.
Even for our house, your water tank should be cleaned once in a month, and you should make sure there is no biofilms on your water lines. Otherwise, you will have an issue, your kid will have an issue.
The surgeon was questioning us that I do surgeries in setup where there are only split ACs, but I'm not finding infection there. But the OTs which are fixed with HEPAs are finding infection. So we really couldn't explain him. I mean, I didn't understand also.
He lied. Very simple. He lied. He didn't tell the truth. With a split AC, you cannot say that I have no infections, right? No fresh air and no. See, these days even a split AC comes in with a virus filtration technology. All are just marketing. Nothing is truth, right? I'll wind up. Just the last one. How many of you have got a copper water bottle, 1 liter? 1, 2. How many? At what price you bought? 600, 1000, 299. See, any water bottle with 1 liter capacity, if it's a copper, it should not cost less than 1600. If anything cheaper than that, it's not a copper or copper coated or copper painted. So our purpose is to have a clean water. Paisa bachane ke chakkar mein we buy a substandard product and we end up spoiling our own health. Okay, thanks. Thank you for your time. Yeah.
Thank you so much, sir. That was an extremely interactive session.
Yeah. No, leave it.
Next, we have Dr. Jaya Banerjee, who is Infection Control Officer and microbiologist at Yashoda Hospitals, Secunderabad.
Because the raining really?
So she will be talking about surveillance squad, wash, watch and prevent 5 practice scenarios, real world capture and challenges.
Oh, thank you. Pleasure. Thank you.
Sir, there is, you asked us for the winners of the.
Yeah, I had one more small
Peter.
competition, but as we are running short of time.
But we can give the prizes to whoever's won till now.
Yes, where is the book?
So by the time they get ready, we can.
Yes, yes, give me all the three.
Take it.
That will take 5 minutes. No, but again, we are running short of time, right?
We can distribute this.
Yeah, okay. And who was 1, 2, 3?
I think
Yes, please
Ruhi
get it.
was one.
We had one more round, but short of time, so we are skipping and giving you the straight away the books. Second and third. Please, please.
We have Wolf Mister
Maybe we can
and Ganesh.
Sorry, Mama.
It's okay, fine.
Yeah.
So what you should do with this book? Most of us people keep it and they find it after 2 years. Yes, ma'am, please come. Thank you. Pleasure. Sure, thank you. Ma'am, it's attitude and it's a good book. Okay, okay. You are the Ganesh? Done. I'll get you. And 3 people came.
So good afternoon, everyone. So it's a post-lunch session, but Mr. Binod has made my job easy. So our topic is surveillance squad. So I think this topic will be very relevant, and I will not make you bore, because we have lot of questions, lot of exercises. So this is the thing, what we know theoretically, many things we know, but we need to know what is the really happened, what the real world capturing, and what challenges we, the preventionist, infection preventionist facing. So moving to the forward. First is, what is the squad? Anybody, can you tell me what is the squad? What is the literal meaning of squad? Squad is actually a group of people who are specified or specialized for doing some particular job in an organized way. So among us, who are the squad? We, the infection preventionists. It can be infection control officer, it can be infection control nurse or link nurses who are taking care of the infection prevention, right? So squad, we are squad, and what is our specialized work to do? To control, prevent and control the infection. And next, what is the job we have to do? We have to do for the infection control, okay? Now, what is the job we have to do? That is surveillance, to take care, to watch. So coming to the surveillance of the squad includes hand hygiene surveillance is the basic care bundle care, which includes urinary catheter, central line and mechanical ventilator, high surveillance and safe injection and infusion practices. So coming to the most important the point of the infection control is the hand hygiene. Why it is so important? It's a hand hygiene means any kind of hand cleansing, and it is the core of the effective infection control prevention. As Dr. Mona Lisa already said, that according to WHO, 70% of infection can be prevented by the proper infection control practices. Here, only the hand hygiene, again the WHO says, only the hand hygiene practices can reduce the transmission-based pathogens up to 50%. So that is the reason hand hygiene is so much important. We all know the hand hygiene steps, hand hygiene movements. So here this the WHO one picture which very nicely represents what is the geographical conceptualization. Means in a hospital, we all are in a hospital, but here the healthcare area in a red area, this red area you can see this is our in ICU the other areas, whereas this side this is the patient area. So whenever the healthcare area to patient area we are going, we have to do hand hygiene. We have to maintain. Now we can assume that everybody knows the hand hygiene steps and hand hygiene key moments, which has 5 moments given by WHO, right? So I'm not going into details, the 5 areas. So before touching a patient, before doing a process, aseptic process, after taking the body fluid, and after touching the patient, after touching the surrounding. Now steps also, 7 steps in the hand washing and 6 steps in the hand rubbing. Everybody knows, right? Okay, going forward. So what are the hand hygiene audit methods? We have the observation of hand hygiene practices. The most commonly we do direct observation. Now direct observation by pen and paper with the eye, or now the mobile apps are very much in use, and it's really very effective also. It's very handy and it's good actually. Whatever the analysis they have given, I have personally used, it's really very good. So many companies are coming up with that, MedBlaze, Ivor, anything. So, and but in that cases, in any way direct observation, it is recommended minimum 20 minutes per observation, okay? And total 6 steps if hand rubbing, total 6 steps if anybody doesn't do also, minimum 4 has to do for a practical purpose, and minimum 20 minutes. Observation through CCTV camera is also okay, but what happened in the direct observation, on-site corrective action we can give, whereas in CCTV we cannot give. Second is the next using is the consumption of the soap or this hand rub bottle, but it does not give proper accurate estimate, because many a times, I don't know you have seen or not, but I have seen that housekeeping staffs are taking the alcohol swab and cleaning the bench. So how will you calculate then? Have you seen any time? So then you cannot give the proper how much hand hygiene happened. So it is reducing in the number, but hand hygiene is not happening, right? Next is the conducting surveys through the structured questionnaire and assess the knowledge. But among them, direct observation currently is the gold standard. Why? Because of one part is the direct observation, and second part is the on-site corrective action. But what is the disadvantage here? One disadvantage is also there, that is the observational bias. When you are seeing someone is auditing or someone is monitoring you, you are doing the hand hygiene. When those are not there, they are not doing. So this observational bias is always a problem for the direct hand hygiene. But hand hygiene action must correspond to each opportunity. The right side this format is given by WHO for monitoring or auditing the hand hygiene, and we all are following by modifying this form only. Most of the hospitals use this by modifying according to our institutions. These few slides I have taken from WHO website only. Here the basic some points has been given how to follow. That is a header, always observations to be precisely located, where is the time, what is the time, which is the date, and along with the, before observing the healthcare workers, you have to start with the header should be filled, and after observing the data should be complemented and checked. It should be verified again. Next, what is the horizontal, this column is given. Each column can be dedicated to each professional, doctor, nurse, housekeeping, and allied. And thus, if you are going to one ICU, suppose, and you can see many people are working together, many people you can observe. But it is advisable by WHO that not more than 2 healthcare workers, 2 categories at a time can be observed, can be monitored. Because otherwise confusion will come and that auditing will not be accurate. And each row of the column corresponds to an opportunity where the indications and actions observed are entered. Anything which is missed, that you have to put in the missed column. You can see here, missed. Observer must detect at least one indicator for one opportunity. A hand hygiene action is performed either by hand rubbing or hand washing. If it is not happened, where it is required, action opportunity is there but action not happened, you can write missed. You have to write missed. And observed through the hand hygiene. Sometimes you may have seen the people do hand hygiene without going the patient side. That is not counted. And next is if auditor or whoever is doing audit, if he is not sure about that healthcare worker has performed the hand hygiene or not, you should remove that from the opportunity as well as action. These are the basics from given in the WHO guideline, WHO website. One more thing here, sometimes we have seen one nurse came to one patient, checked the pulse and all that, and without doing hand hygiene, he went to the another patient, or just checking one patient and going to another patient. For the last or that last opportunity for the first patient will be the first opportunity for the next patient. So here we should calculate only the one opportunity. Did you understand? So there, which one we will be considering before touching the patient? Whichever is doing afterwards, that will be counted. It should not be counted twice, otherwise calculation will be wrong. So whenever the 4th or 5th opportunity of one patient is coinciding with the first opportunity of the next patient, you always has to take in the second one, right? So now going forward, I think everybody knows how to calculate the hand hygiene adherence rate. So hand hygiene adherence rate is again, adherence or compliance rate is again of 2 types. First is hand hygiene, complete hand hygiene rate. That means all the steps has been followed, divided by number of opportunities into 100. Whereas a partial means at least 4 you have to follow, divided by opportunities and into 100. So generally we see 4 to 5, not 6, all the 6 happened. But at least 5 you can consider. Again, it's according to your institutional policy. And our horizontal approach of infection prevention is always effective when the effective environmental hand hygiene is with successful hand hygiene with the effective environmental hygiene. That means cleaning the surface is very important. So now we are going to see one scenario. See very careful, watch this video very careful. You will get some question papers, and I think you have got, everybody has got one hand hygiene audit form. Be ready with the form, number 1 form. Okay, we will show the video of, they are here, 2 nursing staff are working and 1 doctor is working. First is the male nurse, and second is the female nurse, and one in the blue dress you can see in the picture. The lady, she is a lady doctor, right? Purple colored dress is a male nurse, and later on one female nurse will come in the pink dress, and in between this lady is a lady doctor. Okay, so three healthcare workers are working. You just observe and write down how many questions will come. You can understand what you have to do. Shall we start? So now are you ready for the questions? Winner will get chocolate. So join for Slido. Are you ready? Have you Sandra के पास Ready? Can we start? Start? Okay, starting. Shall I do? Still joining. Okay, starting. Total how many hand hygiene opportunities were available? Total how many hand hygiene opportunities were available? Total. Total scenario. Next slide. So winner will get, right? Who is that? Dr. Mirza. No, Dr. Coqueen Guy. What is that? Coqueen Guy. He will get a prize, chocolate. Okay, coming to next question. Total how many hand hygiene actions were performed? Total. Total. Sai. Sai. Who is Sai? Please collect your chocolate. Next question. We can start. Next question, okay? Well, what is the overall hand hygiene adherence rate? Overall hand hygiene adherence rate. Coming to the answer, just 4 seconds, 3, 2, 1. Who is the M? Who is M? Only M? You. Okay. Give it fast. No. Okay. I'm continuing. It is unnecessarily getting late. Okay. She is, I think, M. Go, give it to M. M, she told. Okay. Next question is, what is the hand hygiene compliance rate of nursing staff? What is the hand hygiene compliance rate for nursing staff? Now this is profession specific. Earlier it was total, now it's a profession specific. Why it is so wrong? 50% only people, 20% people can do. Yazini. Okay. So coming to the next. What is the hand hygiene compliance rate for the doctor? Corner. This will be the last question for hand hygiene. 22% people are correct. Who is that? Again, Yazini. Okay. Now we have completed 5 questions of hand hygiene. Now next, surveillance. What doing for the surveillance? Next will be the 2. In ICU, hand hygiene, bundle care, active surveillance by high surveillance. So coming to the next most important is a bundle care. What is bundle care? It is a collection of interventions that are evidence-based, usually 3 to 5. Sometimes it's even 9, 10 also bundles are there for a particular device. And all are non-rule is compliant. If you do everything, that is fine. If it is you miss one also, it can cause the hospital-acquired infection. So bundle care comprises of 2 types, insertion bundle care and maintenance bundle care, right? So insertion bundle care, who is the responsible? Whoever is inserting the device or intubating. That means whoever is inserting the central line or whoever is inserting the catheter or central line or urinary catheter or intubating the ventilator, mechanical ventilator. Okay, right now if ICN or link nurse is present at that moment, they also can write the insertion bundle. But maintenance bundle is definitely to be done by who is giving the care to the patient, to the bundle. Okay, everyday job it is. Not only every day, sometimes 2 shifts sisters also you have to see when the sisters are there. Now coming to the normal calculation of the bundle adherence rate. Already I discussed that is at least 4 to 5 or sometimes 7, 8 also bundles are there for certain devices. So how to calculate the bundle or the bundle adherence rate? It is total bundle followed at that moment divided by total number of bundle into 100. Okay, calculation is fine. Now we will go forward. That is what is the actual workflow happens in the ICU. So whenever is patient admitted in either directly ICU or in the emergency and from there to ICU, so whenever it is required, we insert the urinary catheter. Whenever it is required, we insert the central line. Required, we put the mechanical ventilator, right? So whoever is inserting, wherever it is inserting, those insertion bundle care has to take care and to write down. And one bundle compliance checklist should be there where it is mentioned as the insertion bundle care, everything to be filled up, and maintenance bundle care, everything to be filled up. This is usually kept in the ICU case sheets, usually, but it depends. It's again, the organization may have their own policy protocol, they may have it, may not have it, maybe with the infection control, maybe with the case sheet itself. But we are following like that. Insertion bundle care checklist and maintenance bundle care checklist is with the case sheet, and whoever is responsible, they have to follow, they have to tick or check the checklist. Now this is the nursing staff's job for maintenance bundle care. Now all the time insertion bundle care we cannot see, infection preventionist, IC and ICU cannot see. Mainly when we go for round, we check the maintenance bundle care. In the morning session, Dr. Akshit has shown very nicely the bundle checklist, right? Bundle care. So that maintenance bundle care only mostly we can see. So after that maintenance bundle care, when we go for ICU rounds, we can check the bundle care bundle checklist which is filled up by the caregiver. So many a times we have observed that is checklist is become tick list. All are tick, 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 tick. Should we rely on that, or we should audit our by own? So we should audit. How that Sister Pavitra and Dr. Akshit has checked every bundle for one ventilator bundle care. So we should check every points of the bundle care by our own through audit tool. So 2 audit tools we have. One is the maintenance bundle care audit tool, and at the same time we have to check for the hospital acquired infection surveillance form. I'll show I think you have got one paper, that is a 3rd paper you have got, that is the hospital acquired infection surveillance form, and second is the maintenance of number 2 form is the bundle care audit form, right? So at the same time, these 2 together, audit tool for surveillance. Active surveillance is most important. Passive surveillance is just a data collection from the microbiology department and go back, retrospective audit. But active surveillance is the prospective surveillance that we need to do. I'll discuss in the later slides why it is so important, active surveillance. So right now, active tool for the surveillance is the bundle care and the hospital acquired HAI, we can say, surveillance form. Together, when we get it from the ICU as an active surveillance, then we can go to our ICU, or we can analyze that patient is having HAI or not. Okay, that time that bundle care form will help for the root cause analysis. Going forward to the what bundle checklist we follow. We follow in our institution the insertion bundle compliance checklist to be filled by whoever is doing insertion and assisting insertion. All the devices are there. Second is the maintenance bundle care compliance, which to be filled by who is the caregiving, that is nursing staff every day is giving, but many a times we have followed. Sometimes that is all are tick. So checklist became tick list. Now what do you have to do? You have to go with your surveillance audit tool 1, that is a bundle care audit tool. Here what are the components you can see? For the urinary catheter care bundle, closed drainage system is there, urinary catheter is secured or not, drainage bag is above the floor, and below bladder level, hand hygiene done, vaginal, mitral or perineal care given or not, single glove use, all points are there, whichever is in the bundle. Similarly, central line also 1, 2, 3, 4, 5, 6 bundles are there. And ventilator bundle care also, we have seen in the morning, it's very nicely demonstrated that head and elevation, starting from head and elevation, then adherence of the hand hygiene, daily oral care. Earlier it was 2% chlorhexidine, now it has changed to toothbrush with a normal saline. So whatever the changes is okay, but oral care is still there in the bundle. So all this we need to follow, and we should mention in our own checklist. We should not go with what the nursing staff has given, right? Second bundle audit tool with you, that is third number of paper, that now we normally follow CDC guideline for any considering any high to be COT or CLABSI or VAE, right, or SSI. So all the points, whatever, mainly COT, for COT, what we see? We see catheter present. What is the device criteria for more than 2 calendar days? Catheter should be there, urinary catheter should be there in place for more than 2 calendar days, device criteria. Next criteria is symptom criteria, and third criteria is microbiology culture positive should be there. So first, here criteria is catheter present or not, temperature, suprapubic tenderness. Normally we see dysuria urgency when patient is in catheter, we do not see. So next page you can see the additional information, that is a microbiological culture report also to be mentioned, and if additional information, the TLC count or any investigation sent. The most important is antibiotic usage. In the morning, on the morning session, Dr. Venkat sir already discussed that is why we are using so much antibiotic. That is the clue. Here if we write that form, that is what antibiotics to be started, from where. Maybe patient is not in catheter for 2 calendar days, but antibiotic, then we will cut, it will not come under high. But something happening. Something is happened. So we have to find out, we can track what is happening with each and everything in ICU. Okay? So this is the surveillance through audit tool by hospital acquired infection surveillance form. This combinedly called as active surveillance. Okay? Any doubt? Okay. So urinary catheter bundle care, always it considers prior to catheterization, during catheterization, and after catheterization. These are the insertion bundle criteria and maintenance bundle criteria. We will more focus on maintenance bundle criteria because we are going and we are doing surveillance for insertion bundle care along with the maintenance bundle care. And our ICNs are going there daily checking the maintenance bundle care mostly. Sometimes insertion also happened, that time insertion bundle care checked, but daily just checking insertion bundle care, maintenance bundle care. Thoroughly they are checking. So you can check the points, and coming into one more video. So again you will get to a question. So see properly what all points are there. How she is she is doing the bundle care. Yes, play. Observe it properly. Did you observe properly? Now one question will come. Again on Slido. Get ready. Shall I start? It's open only, na? Every time open, you have to open? Every time. Okay. What is the bundle adherence rate for urinary catheter maintenance bundle care? Already I have mentioned how to calculate. Bundle adherence rate or bundle compliance rate. Both are same. Wow, good, great. Sai. Sai got the first prize. Where is Sai? Okay. Coming to central line bundle care criteria. Again, the maintenance bundle criteria. You have seen, again morning already discussed, Dr. Akshit, what are the bundle maintenance bundle care for the central line also. That is the daily aseptic central line care should be hand hygiene, hub decontamination, that is called rub the hub, sorry, and dressing with 2% chlorhexidine. Daily assessment of the dressing changed or not, any local signs of infections are not, is there or not, and daily assessment of readiness of the removal of central line must be documented. Must be documented, okay? It should be written. So coming to the next. Again, come. Video. Again, one video will come. Insertion bundle you have checked properly. With you also there. You can use your paper. Observe properly. Corrective action at the same time, on-site corrective action wherever possible. Get ready. Next question. What is the compliance rate for the central line maintenance bundle care? Sai again, hat trick. Okay. Now coming to mechanical ventilator bundle care criteria. Here adherence to hand hygiene is the foremost, then elevation of head end, daily oral care, deep vein thrombolysis prophylaxis, need of peptic ulcer prophylaxis assessed, it is documented or not, that is important. Then daily sedation, vacation and assessment of readiness to extubate it, again documented or not. Cuff pressure 25 to 30, morning it has been discussed, sir, in very details, and subglottic suctioning. Again, many organizations followed oral or nasal, that is different, different thing. The major bundles for the ventilator are these only. So we are following this many. Coming to another video. Video followed by question. Please observe the video carefully. You can see most of them are thick, right? Morning time you have seen in a direct live this suctioning and all that. Now you can see video. This is subglottic suctioning they are going to do. Measuring cuff pressure. At the same time, my ICN is feeling the active surveillance, that is a high surveillance form also. Together we have to fill both, like bundle care as well as high surveillance form. Combinedly active surveillance. Combinedly called it as. So now question will come. You have observed everything. Okay, get ready. Starting. Calculate the compliance rate for ventilator bundle care. Now I believe you all are masters in this rate calculation, right? Responses are coming very good. Now coming to answer. Wow. 45% only. Okay. Yazini. Again. Okay. So coming to this. Now coming to hospital acquired infection. Just 5 more slides are there. So here active surveillance, here one patient of 54-year male in a surgical ICU admitted for the hernia and intestinal repair, and central line and urinary catheter inserted on same day, that is the 5th August. And my ICNs are checking every day, each and every day, 5th August, 6th August, bundle care they are checking, along with high surveillance form they are following. So what they observed, that is temperature, you can see that is according to CDC guidelines, what we criteria we followed for being a COTI or CLABSI or VAE. So COTI, first day temperature 98, continuously you can see 98, 98, 98, like 98.2. But on day 8, 98.3, okay, day 9 it became 101, and on day 10, 101, same. And CLABS central line also they mentioned the same thing. So when they saw the TLC count also the same, increasing trend has been seen from the day 8, day 9, and they have sent the urine culture by after changing the urinary catheter on day 9. When they suspected something, they used to change the catheter and to exclude the colonization. So blood culture and catheter catch urine they have sent, and after 2 days we received the sample, we received the report as a blood sterile for after 48 hours. And get ready. How will you interpret this? It's very easy question, although I am giving you. How will you interpret this? It's very easy, very common actually. Still 55% positive. Oh. Raj. Okay. Going to next question. So here 155 years male in admission in the neuro ICU with the some hemorrhage, okay, subdural hemorrhage, and decompressive craniotomy was done. Patient was inserted catheter and central line and mechanical ventilator all on 16th of August. ICNs are going daily and checking the bundle list. The temperature is constant with from day 1 to day 9, and even the temperature, even the counts are also normal. Just from day 8 it has started increasing. When we see the central line is in place and urinary catheter in place, patient is on mechanical ventilator. Initially, PEEP and FiO2 value was constant 5, 3, 5, 4, 5, and suddenly it increased on day 8. Day 6, it's increased to from 4 to 9, and even the quantifier, the antimicrobial, antibiotic also is escalated to amikacin. Initially, it was not there in the amikacin, and we collected all this data. When we checked, that is urine culture and ET secretion was also sent on 23rd August itself, but all the culture came as negative. So what will be the answer? I want 100% to be correct. I hope everybody understand the things. I know you people knows the basic things, just to refresh ourselves, okay? Answer is sterile. Cultures were sterile. ET secretion cultures were sterile. Okay. Now who is the Yajini? Congratulations. Okay. Another is this one. You just quickly check and tell me. This is no question. Just tell me what is that. Anybody? What type of high or no high? How many said no high? How many said it's a high? Okay. No high. Answer is no high. No high. Okay. So another thing we need to surveillance, that is safe injection and infusion practices. It is very important, but often we ignore that. So we need to check the date or label in the infusion bottles, when it is starting, or infusion pumps, everything, it should be proper, appropriate. Along with that, the multi-dose vial, when it is started, how many times? Normally we follow that is for a single patient, and it's maximum 10 times. So and we have an audit tool. That is up to your organization, your choice. You can put the audit tool. It is better to have an audit tool so that you can checklist for yourself, so can you go for data collection. You can track, anything happen, you can track it. So everything happened, many bundle you have seen that all the bundle are 100% not followed. What need to do? So only thing is corrective and preventive action as continuous training, and we need to ask our organization management also to get the proper resources. So many times we get resources, but because of lack of training, we do not get, because we know the attrition rate of the nursing staff and the housekeeping staff. So training is required. We are giving training to nursing staff, housekeeping staff, even doctors also. Even the doctors also we need to give. So as a summary, the ICU is a high-stakes environment, so where infection lapses can have the devastating consequences. So first, we, the intensivist, we are the squad in the ICU. What we must do, we must perform the surveillance as a bundle care check for the devices, as well as a high surveillance for the patient. And on-site correction wherever required, as our ICN told, that is, rub the hub was not there. So immediately she told, that is, you have to rub the hub with the alcohol swab. Sometimes cap is also available, we can use that also. Next is, after that was the active surveillance. After that, when we come back, we have to analyze those data available in the ICU, in our form, and incorporate into the reporting form. That is a part of passive surveillance, along with the passive surveillance from the microbiology data, right? Now we have to do root cause analysis by fishbone analysis and 5Y analysis, WHY. Some others are also there, general, many are there, type of analysis. Next, we need to do corrective and preventive action. These are the core of the infection prevention practices. So the bottom line is, ICU is a fragile ecosystem, and infection control is the key to maintaining balance. So vigilance is the price of safety in the ICU. Thank you.
Thank you, Jaya. Any questions? If there's no question, we'll move on to the next. They answered a lot of questions. We're going to the last topic of the day. That is a role play, crisis to control, mastering outbreak. By the end of this, we will all become the actors. I request the team to please take on the stage.
We assure you that in the morning you have seen a different way of the learning. This last session also, it will be entertaining. You will not get bored. Yes, it will be finished in another half an hour. Outbreak. It's an outbreak, they are nothing new. In the history, there are a lot of outbreaks has happened in the form of measles, HIV, then plague. So recent outbreak, what is this? COVID. Any news have you got? Yes, WHO has declared it as a global pandemic. So in future will come, whether it will come as an outbreak or it will be contained in that particular demographic area, right? So this outbreak is an occurrence of a disease at a greater rate in a specific area during a defined period of a time. When we consider high, what will be the area in the hospital, OPD, ward or ICU? Okay. We have to investigate the outbreak so that it should be investigated promptly, immediately. So because these outbreaks, they are associated with cost. They are associated with morbidity as well as the image of the hospital. If your hospital is showing if your patients are getting more infections, then the image of the hospital is not considered as a good. We have to identify what are the different modes of transmission, limit that transmission modes and contain the outbreak. If you are not doing an immediate basis or an urgent basis, then the time between the investigation and the yield from the culture will be diminished. And this investigation will help us in the future to prevent the future outbreaks. So how to identify the outbreak? By your regular seeing the surveillance data, your microbiology lab reports, or sometimes you get a call from the clinician saying that my patients are getting infections in that way, or there is some unknown pathogen which you are growing from your particular area. Some outbreaks, they are easy to control, but some, they are really difficult. Those who are in ICNs, they must be facing the control of an MRSA outbreaks, MRSA SSI or MRSA bacterium in their ICUs. We have to distinguish between outbreak and the pseudo-outbreak. Pseudo-outbreak is just the increase in number of the positive culture reports. But in case of outbreak, there will be, the culture reports, they are correlating with the clinical condition of the patient, right? The culture reports are positive and there are clinical symptoms in the patient. So these two things we need to distinguish. There are different steps which are involved. So I will not bore you with these steps. So we have a different way of telling which are the different steps in the outbreak management. So we have a small role play in which we are involving all our team members who are involved in the investigation of an outbreak. I hope you will enjoy and you will have some take-home message at the end of this role play. Okay.
So here we have set up our microbiology lab where we have our consultant microbiologist, and microbiologist is just reviewing some reports and needs to call our neurosurgeon.
Hello.
Yes, sir. Tell me, sir. Hello.
Hello.
Sir, I have called to inform this patient report. He is growing as this ET sample is growing Acinetobacter, sir.
Ma'am, we have been seeing this happening not today, at least last week also we have seen similar kind of reports of Acinetobacter. You know, ma'am, we do a very good surgeries, a complex surgeries, patient all over India come with the name of our neurosurgical team and us, and now we are seeing a lot of infections, and this is getting us done, ma'am. Something has to be done. Something is wrong with our infection control and ICUs, and every time our patients are going down with these infections, ma'am.
Yes, I do understand your concern. I will also check what is going wrong in the ICU. I am just going to inform to our administrator simultaneously and we'll get back to you, sir.
Yeah. I'm calling to my administrator and to find out. Yeah, Madam Admin, how are you doing?
I'm fine. How are
Do you have some time for the clinicians, or you still are looking for some balance sheets and positive and negatives only?
I understand you're very upset for about something. May I know what is the reason for your upset?
Yeah, ma'am. See, what's happening, we are all doing good surgeries, everything is going well. There's such a complex surgeries. Again, all your ICUs are full of infections. Your infection control practices are poor. Your nursing ratio has become a problem. Something is going wrong, ma'am. I think, do you want us to operate or we have to stop it? You have to be very careful about all these infection control practices. And we are getting actually scared by this. Do you want me to find out an alternative operation theater, or you will make some differences here?
Sorry to see you so upset sounding in the early morning. Let me check with our microbiologist and the HIC team. I'm sure that should not be a big problem. We'll surely handle it. Please be assured. I will have a meeting, call you back regarding the updates. Please be assured. Don't be upset over such things.
Okay, I'm expecting a quick response.
Sure.
Right.
We'll take care of it.
Now, microbiologist is
Good morning, Dr. Shweta.
Good morning, ma'am.
What is happening? I'm getting a call from the surgeon. He's threatening me that he will not be operating in the hospital anymore.
Yeah, I was just about to call you, but got engaged in a report, informing the other reports. We are seeing some rise in infections in the neuro ICU. Its fourth case is getting Acinetobacter.
Since when is this happening? Why I have not been informed?
See, this is since last week. Initially, we had only one or two cases, but now another fourth one is also having the same infection. We really, because I'm also concerned why the patients are getting infection.
So what should we do about it? Something has to be done. I can't keep getting calls from the consultants.
See, ma'am, I need to define some case definition. I need to do the line listing of the cases. Then I'll get back to you what is going wrong and where it is going wrong.
So you do one thing, please call all the stakeholders for the meeting immediately. Let us discuss what can be done at the best.
Yeah,
In the evening, 4 o'clock, we'll do the meeting.
Yeah, definitely we'll have some solution for this.
So microbiologist is calling all the other stakeholders like GM nursing, ICU in charge, the intensivists, ID physician, and ICNs.
So good evening, everyone. I hope you have all understood why we have gathered here.
Yes.
So anyway, I will request Dr. Shweta or microbiologist to please brief us on what is happening in our ICUs.
Good evening, everyone. We are gathered here to discuss some issue. We are seeing the increase in number of the cases in our INCU. So together we have to find out some solution as a teamwork, what we can do for it.
So what are the details? How many cases are there?
Madam, there are 4 cases. All the 4 samples are from ET, and they are growing during the period of 1 week only. So I think there is an outbreak in the
of around
INCU.
80. Why are you calling?
This is occurring during the period of one week. Okay. All samples are having same organism with the same sensitivity pattern. So as per this thing, it is HIPC practice, it is an outbreak in the INCU of the Acinetobacter.
Intensivist, sir, do you agree on this?
Yeah, definitely. Within 1 week, generally 1 or 2 cases means it's different, but serially one after the other 4 cases have occurred, and probably if we are not at this point of time containing these infections, probably they spread across other patients also, which will cause devastating problems, because these patients are sinking, especially after getting infected. The oxygenation is going down, spiking fever very much. The neurosurgeon is very upset in the morning. We had rounds with him. So he was so upset. He said you are not able to control anything. What is the status going on? So he was very upset in the morning rounds.
Like another clinician in the hospital or an admin, loose admin in an hospital, I'm just trying to find out. मैम आजकल तो सारे इन्फेक्शंस एसिनेटोबैक्टर क्लेप्सिला सुडोमोनास ही हैं. इसमें आउटब्रेक का क्या है? जो भी रिपोर्ट भेजो क्लेप्सिला आता है, एसिनेटोबैक्टर आता है, 1 क्या 2 क्या 10-15 आते ही रहते हैं. उसमें आउटब्रेक करने का क्या मतलब है? कोई आईसीयू में आजकल कोई इकोलाई या स्ट्रेप्टोकोकस थोड़ी आता है, सब तो एसिनेटोबैक्टर आता है.
नहीं sir, during this period, all Acinetobacter are having the same sensitivity pattern. So this is correlating with your phenotypic typing of the organisms. If you want to still confirm whether it is outbreak or not, we have to go ahead with the genotypic typing of the isolate. So
टाइप एक ही टाइप का सेंसिटिविटी, एक ही टाइप का पैटर्न, तभी आउटब्रेक बोलते हैं, नहीं तो नहीं.
सर अलग-अलग ऑर्गेनिज्म के लिए अलग रहेगा. Since Acinetobacter is a common, so they are defined as a number more than 3 is considered as an outbreak. If it is an uncommon pathogen like Stenotrophomonas or Burkholderia, even the one organism, if you are isolating from your ICU, it will be considered as an outbreak.
So ऐसा है तो मैं तो मेरा ICU को हर दिन आउटब्रेक ही डिस्कस करता रहूँगा, आउटब्रेक ही अनाउंस करता रहना पड़ेगा.
Sir, generally with the commonest organism, we are getting our E. coli, but they are coming at a different time periods and from different samples, along with a different sensitivity pattern. So that time we are not declaring it as an outbreak, but here it is common, same organism, same sensitivity pattern, and during a specified period of a time.
So what are our thoughts on this ID physician?
Looking at the data and all the cases being detected from the same localization in the ICU during the same period, ऐसा लगता है कि this is an outbreak. So we should be putting our actions, immediate actions to curtail this outbreak.
So I understand our microbiologist, ID physician, intensivist, all are agreeing this is an outbreak, right?
Yes, ma'am.
So you have around 4 cases which have to be stopped at this point. So since you are heading the HIC team, the microbiologist should, I think you should be having a plan of action. So what is your plan of action further going?
I have few points the plan of action. The first among which is we need to have a barrier nursing for these patients. So I request our nursing GM madam to provide 1:1 nursing for these ventilated patients at least, because I can understand the issue.
In this scenario, it will be very difficult to give 1:1 allocation. In this scenario, it's very difficult to give 1:1 allocation due to high occupancy. My girls are crying.
No,
it will
madam,
be difficult.
we need
You
to
always say that, but here now
have.
we have a crisis which is more than your girls crying.
Yeah.
So please see that whatever our recommendations from HIC team should be followed at the earliest.
यहाँ एक को 4 का 4 पेशेंट को एक नर्स का ठिकाना नहीं है, यहाँ एक का एक डिस्कशन हो रहा है. सिचुएशन क्या है, डिस्कशन क्या हो
It's
रहा
a
है.
outbreak
Yes, sir.
prevent
Surgeon
करने
sir,
के
don't
लिए
worry,
she
we will do it.
guide us. The second requirement.
Okay, I'll reinforce the. Okay, ma'am, I'll reinforce the allocation. 1:1 I will ensure due to outbreak.
Yes, this
Second
has to be done until the HIC team is
Yeah, I
asking
will
us to do
relook
it.
into that.
Yes,
And I will
yes, please.
request other nurses to stretch themselves for other
We'll
patients.
take care of the other things.
Yeah, I'll counsel them.
What is your next plan
Next
of
thing,
action?
we need to cohort these 4 cases at along the one side of our ICU and label the signage, put signage as a contact isolation. And we have to follow the contact isolation. Again, there is a resource allocation by the nursing GM. Madam, you please provide the required hand rubs, PPE kits and all. This PPE kit should be used for all categories, not only for the nursing, but for the housekeeping, which is coming in cleaning during this, for housekeeping, doctors, physiotherapists, every category of the hospital, in the ICU.
And I keep indenting, ma'am, as you all know that every once in a month we are having meetings, HIC meetings also, we are not getting the adequate resources. So you should emphasize to get the resource from the management side.
Madam, be assured we'll provide you all the resources required.
Ma'am,
as
so
per
far you did
recommend-
not provide anything, ma'am. How can we get this out?
So far we didn't had an outbreak, no? Now we have an outbreak, we'll take care
So
of it.
sure, ma'am, I'll reindent and I
yes.
will ensure that to get the resource, and I will ensure adequate resources everywhere.
And ensure you are not charging to the patients.
Yeah,
Yes,
sure.
surgeon sir will surely do it.
So we have seen that happening many times in all our hospitals, many hospitals, that during COVID, kits has been charged to the patients. Our patients come in a package, so this should be been discharged with the package, no extra charges for your containment.
Okay, sir, we'll discuss further about it to the management also. We'll see what best can be done for the patient. Next, what is your third
Next
step of
is
action?
I want to assure our ICU in charge nurse so that all these resources are available till we contain this an outbreak.
Okay, ma'am, I will arrange at the earliest immediately, ma'am.
And I want my ICN nurse to take all the education part. She should train our housekeeping nursing based for the contact isolation, hand hygiene, and the cleaning protocol for the housekeeping staff.
Yes, ma'am, I'll ensure the all infection control practices, and I'll be doing the vigilant supervision, ma'am.
Okay, so now we are going for barrier nursing. We are trying to give what resources required. The ICNs will take care of the trainings. And you will be doing any cultures, environmental surveillance?
Yeah, that's what I'm about to tell, that we requirement for the surveillance samples to know the from where we are getting this Acinetobacter. So we will screen some surface sampling in the coming 2 to 3 days, and we'll get back
So
with the
with
report.
all these actions, I'm expecting you'll come back to me with the source and a positive outcome of control, right?
Yes, we will do it, madam.
So please go ahead. We'll again reconvene once you call, and please keep giving me the updates.
Okay, madam.
Madam, this all need to be continued in future also, not for just a outbreak. And this kind of relaxation of all those availabilities should be a continuous process, ma'am.
Yes, sir. ICU is our priority. We'll ensure patients go out safe.
Scenario 2.
So here the ICN and the nursing in charge from the ICU, they are having, they are doing their jobs. This ICN, she is collecting the surveillance sample. Simultaneously, she will be teaching the healthcare staff. So first she is teaching the staff about the hand hygiene compliance. Please come.
Mask எடுத்துடுங்க, no problem. Okay. In this side, okay.
The scenario is she is teaching the nursing staff about the hand hygiene and the contact isolation.
A lock. Good evening, all. This madam. Good evening, all. Some slack is going on in AMCU, so we need to follow the strict contact precaution. So for each patient, and gloves and gown and gloves for each interaction. Okay. No, you have to raise the question, visitors. So visitors also need to follow the same contact precautions. So there is no regular hand hygiene complaints negotiation also. Okay.
We are following the infection control practices, as you said. So as you said, we are following infection control practices. What about the visitors? What are the protocol we are going to follow?
Visitors also need to follow the same contact precautions.
Loudly.
Okay, now I think training session is over. My ICO is in the. So for she's addressing on the contact isolation, they have to use the PPE in a proper order. Donning and doffing has to be followed, and all 6 steps of the hand hygiene, which has been discussed in the previous session, has to be done for all the cases whenever they have interaction with the patient. Now I'm talking with our respiratory therapist. तुम ये laryngoscope कैसे clean करते हो?
Ma'am, as we have a high occupancy and we have only 3 laryngoscopes, so we send it for cleaning with normal water, and then pre and post intubation we clean it with alcohol swab.
You are just cleaning with the alcohol swab. You are not doing anything, any disinfectant are you not using?
We are cleaning it with water.
Okay. So here I want to tell you that Acinetobacter is a water-loving organism. So we have to check, and the sample are from the ET. So we need to check the cleaning protocol for how the laryngoscope is being cleaned. Actually, it should, since it's a semi-critical atom, it should be a high-level disinfection. This can be done either by the use of the Sidex or Sidex OPI, right? Now the ICN, she is collecting the swabs from the different areas since on the high-touch surfaces. So one breach in the practice we have found out is the cleaning of the laryngoscope. So any of you can tell me which will be the high touch surfaces? है सर है हाँ. Tell the procedure ना वो side हो ना. She is taking the swab by the squeeze method. She will be dipping the swab in a sterile saline and then squeezing, and then will collecting the swabs from the different surfaces, right? So just to rule out whether our saline is contaminated or not, to have the 100% assurance, one saline sample we will take as a control also. Corner. We have to take samples from each side in a form the different swabs, okay? At the same time, label the swabs from where you are collecting it. One more question to the respiratory therapist. Are you changing the HME filters as per our hospital protocol?
Yes, ma'am. We are following the hospital protocols.
Again, for the ventilator cassette cleaning?
We are sending it for sterilization.
Okay, good. So now samples has been collected. She is sending the swabs to the lab for the cultures. Now again a scenario in the lab.
So the microbiologist is now seeing the culture reports of the swabs after 2 days of collection.
Infection control nurse, please come. Where is your mic? So have you seen the practices in the ICU or monitoring practices? Are they doing? Is there any increase in the compliance of the hand hygiene?
Yes, madam, they are doing training session. Yes, madam, they are doing training sessions are going on.
How many training sessions you have taken since last week?
Daily morning I am taking, madam.
Are you taken classes for the housekeeping staff?
Yes, madam. Nursing staff nurses and housekeeping staff and other staff also, madam.
Are the cleaning frequency has increased?
Yes,
how many times they are cleaning now?
Every 3rd hour they are doing.
See, whenever there is an outbreak, there is need to increase the cleaning frequency. In an ICU, as per the current recommendations, we are cleaning 3 times a day. But when you are facing an outbreak situation, you have to increase the cleaning frequency. In addition to that, you have to ensure that you are using your disinfectant in a correct dilution. Have you checked they are preparing it properly?
Madam, I am checking, madam.
Oh.
I check.
ID physician, madam.
Now the microbiologist, after reviewing the reports, is calling the ID physician.
मैडम आप 3 बार ठिकाने से नहीं हो रहा है, आप 6 बार की बात कर रहे हैं यहाँ. ये क्लिनिक कहाँ हो रहा है?
सर हो रहा है सर, एटलीस्ट 3 बार बोलेंगे तो कम से कम
आप आके देखिए 3 बार कहाँ हो रहा है?
सर हो रहा है सर.
3 बार हफ्ते में हो रहा होगा.
नहीं सर, नहीं. They are doing, sir. Otherwise, we would have faced this problem before also. Currently, there might be some breach, right? ID physician, madam, see, these are the reports. We are getting an Acinetobacter from our laryngoscope.
Okay. It looks good job done, Madam Microbiologist. It seems that we have controlled, identified the source from where it was likely the Acinetobacter was there. So with the strict hand hygiene and increased surface disinfection, high-level disinfection, also we can control this outbreak. And I think we should also be going ahead with doing active surveillance. Like for all the patients who come from outside hospital, we should be taking a sample outright. And if it comes positive, then doing the necessary action.
Yes, I think this is a good idea because this is also again one major for containment of an infection, the active surveillance. Whenever the patient is coming from the another hospital, outside lines or outside tubes, we have to send the cultures. So to check whether they are infected in their prior organization or after coming in our hospital.
And this active surveillance needs to be an ongoing procedure so that we do not get further outbreaks.
Yeah, we need to discuss because again it will be cost involved in this. We'll discuss with our admin madam and then we can think on whether to continue or whether to continue only for doing this outbreak basis.
Yes, madam.
Okay. Calling. Call only. Hello, madam. Are you busy or free? Can I talk?
Yes, please tell me.
Yeah, I just called because since last week, since last 2 weeks, we are doing our training sessions, we are monitoring our cleaning practices, and we are seeing there is decline in the rate of cultures. In last 2 weeks, only one patient is growing as Cyanobacter. So I think there is some improvement in our practices.
Okay,
And the
so
laryngoscope is again having a grows the Cyanobacter. So that is the source.
Okay, we'll do one thing. We'll all please call back all the stakeholders who were involved in the previous meeting. We'll just discuss what all steps you have taken and how the infection rate has come down. Please make sure you call the ICU in charge also so that we can understand.
One thing, madam, I want to tell here, because since laryngoscope is involved, so there are different ways of cleaning the laryngoscope. One can be a meeting.
Okay, let's discuss on this with the team. So now the meeting is again reconvened to discuss about the status of the outbreak with all the previous stakeholders like GM Nursing, ICU Intensivists, ICU in charge, ICNs, and the ID physician.
Yeah, I suggest, because there are less laryngoscopes for the workload we have, 3 laryngoscopes, I suggest the admin to buy 3 or 4 more laryngoscopes so that we can send these whatever used laryngoscopes to A-level disinfection.
Laryngoscopes are always the same. Why now only the outbreak is happening?
Because less laryngoscopes are available in between intubation, the people are opting to clean it with water rather than sending it to ETO and all, because it takes time.
Admin madam, आप laryngoscope की sterilization disinfection के बारे में बोल रहे हैं. वहाँ ओटी में तो हर 10 मिनट में एक ट्यूब डालते हैं. आप कहाँ से इतने लारिंगोस्कोप लाएंगे? आईसीयू में चेंज करें तो क्या होगा?
सर दस कोर्स बोल के ही पूछ रहा हूँ because
ER में क्या हो रहा है, OT में क्या हो रहा है?
I feel OT में it is a clean based surgeries, but the ICU is very much the patients who come with very high infections, and especially they come from outside and all, the possibility of infection will be there. So that is the reason I think we should be taking the ICU as the priority.
In OT, we are intubating only for a short duration of a period. But in the ICU, the patient, they are for longer duration of intubation. That might be the reason that we need to maintain sterilization, cleaning, high-level disinfection for our laryngoscope. But if it will be good practice, we'll implement in all the areas.
So you mean to say the practices are only confined to ICU, but OT वाले कुछ भी करेगा तो चलेगा? ये सब ICU वालों के ऊपर ही क्यों है जो?
अगर admin madam का support मिलेगा, so that we can implement the same practices in all over the hospital.
और OT में भी cases 5-6 दिन ventilator पे रहते हैं, cardiac case, neuro case, and post operative complicated cases. वो cases को आप कैसे handle करेंगे? I think uniform policy होना चाहिए और admin madam को ज़्यादा laryngoscopes लाना है, CSSD की force बढ़ाना है.
We will see on that, because can you assure me that if I give you more laryngoscopes, such outbreaks won't happen?
I can assure you.
I feel, definitely.
It's not about feelings, it's cost involved here.
So basically, if you are definitely providing, we'll show that there will be a decrease and no incidents and all.
Because we we can assure about the training session and there will not be any breach in the infection
I am
control
hoping
practices.
the HIC team will constantly keep overlooking the cleaning of laryngoscopes.
I feel buying 3 laryngoscopes will cost maybe 20,000, but if we are able to prevent one infection in the amount of the expenditure of antibiotics, where high level cholesterol and all definitely comes down. I think 3 laryngoscopes worth it.
Okay. We'll give you the 3 laryngoscopes. We'll see how the infection rate can be kept down. What was the next step? So the possible source you have identified is what here?
It is from the laryngoscope.
Okay, so you feel the laryngoscopes were the major culprits which caused
Here
the
in
spread.
our scenario, laryngoscope could be the major culprit, but since I told before also, madam, that Acinetobacter is a water loving. So for some scenario, we need to keep the wet ventilation. In that case, we have water. If we do not changing the humidifier water, then again that will act as a source of infection.
Okay. What is the next step you have done?
Next step, we are keeping the continuous vigilance. We are continuing with our training sessions, and we are checking our active surveillance also. So we'll see, madam, how the outbreak is going, whether we are able to maintain the decline in the number of the infections or it is increasing.
So finally, the idea, intensivist, microbiologist and ID physician agree that the outbreak has finally been contained. Can I inform the same to the neurosurgeon?
Yes, madam.
He can operate now onwards.
Okay, we'll make sure he'll operate.
He can go ahead without
So
dissatisfaction.
I congratulate the entire HIC team with the support of nursing GM and the ID physician and the intensivist in successfully controlling the outbreak.
Okay.
Please ensure no more such outbreaks happen in the hospital.
This outbreak in the form of a written report, so that in the future, if we get some again same type of the outbreak, so we can refer to that how we are contained at that time.
Okay.
Right?
हेलो मैडम, आप तो आपके हॉस्पिटल में लैरिंगोस्कोप खरीदवा लेंगे, बाहर का क्या है, कहाँ से लैरिंगोस्कोप लाएंगे? वो जो ER से या जो भी छोटे हॉस्पिटल से या एम्बुलेंसेस से इंटुबेट करते हैं, वहाँ से तो एसिनोडोबैक्टर फिर से आएगा ही आएगा.
So उसके
सर्विलेंस करेंगे. whenever the patient comes from outside, we will take the samples.
वहाँ पॉजिटिव आएगा तो क्या करेंगे फिर?
Isolate करेंगे and
तो
then change the tube.
ऐसे आते रहेंगे, ऐसे आइसोलेट करते रहेंगे, फिर हॉस्पिटल से बड़ा वाला वही हो जाएगा.
I feel
But we have
the
to take
cases
corrective
who are coming from outside, active surveillance in the form of initially
सारे
take
केसेस
pulses
आउटसाइड
and
से ही आते
nebulization.
हैं, आपके यहाँ से कहाँ से आते हैं?
So initially start with colistin nebulization and see whether we can decrease the colonization, which will later will form
उससे
as
रेजिस्टेंस
infection.
बढ़ जाएगा फिर से कोलिस्टिन का.
Nebulization mostly it may not cause much of resistance. Yeah, we may change the tube if the continuous they are coming with this thing to a new tube probably. Okay.
Need not to be intimated. Community acquired outbreaks, we see a cluster of cases coming into the hospital, then we have to intimate them. Hospital acquired outbreaks, we don't. This is a hospital acquired outbreak. There is a spread within the hospital.
So now here we are declaring the end of the outbreak session, and now forum is open for the discussion. Any questions?
No questions.
We have come to the end of this knowledge fest, and I know it has stretched a little, but I hope all of you have enjoyed and have something to carry back home and have some practices which you can put into use next day itself. Like Monday, beginning Monday, you should be able to put all the practices in place. So any announcement to be done?
Who actually put their all hard work should get a large applaud for them. So give a large applaud. I request all the ICOs, ICNs who have been a part of it, including Secunderabad, High-Tech City, Malakpet and Samajguda. Please come on to the dais. All ICOs.
All ICNs, please, you're all worked at the background, so.
And Dr. Kalada, Dr. Mona Lisa ma'am, and our GM Nursing who has been a part of it. So all those who have been a part of it, give him a big round of applause. All of you can come in the front. Because chairs are there. Come here quickly, Swati madam. So Akshita ma'am, Swati ma'am, Sweta ma'am, and Sutapa ma'am at the end, and all those who have been a part of this. This has been almost 4 weeks, all efforts for all of them. So they all need a big round of applause once more.